Yeah, Mpo is a gift. We have, I don't know if you're Catholic. There's a prayer we say. We happily receive the gift, right? Yeah. And on that, I will hand over this session to my colleague Sylvia, who will chair the very first session of the day. Ladies and gentlemen, I hope you have a great day. You stay engaged, and catch you again sometime during the day. Thank you so much.
Yes, so good morning, everyone. I hope you're energized from yesterday and ready to listen in to today's presentations. So thanks, Fred, for the recap. And in the interest of time, I think I just want to mention a few things. The presentations today, especially this morning, I think really interesting. But just to say that, yeah, we need to think of what's happening differently, especially now when we implement the projects and actually speak to them. What is different? Not just different for us as researchers, but what's different for the people who live with the condition, what's different for the health system, the whole mental health ecosystem. So, and some of the unique aspects of the projects today is because I'm just thinking of especially the ones this morning, because I'm chairing the session, just think of, we always think about picking up mental health conditions from DSM-5, all those tools. But we actually never think about the input the patient has. So we ask the questions, but then the patients also think about the conditions in a different way. They portray their conditions based on how they feel or how they behave. So the unique aspects around the innovations this morning is because they pick up on those patient experiences and actually bring them into the development of the tool, or actually helping to synthesize the conditions and the outcomes. So I'm really excited to invite the first speaker, exploring the role and feasibility of natural language processing techniques to improve mental health. And really exciting to hear this, because it's not work that we ordinarily do within the ecosystem. So it's really good to hear. And please take your notes and questions. I think it's really exciting to listen in. Thank you. So I invite John Black, who is representing the team. The team online, we have not forgotten you. So please, please look out. I think your team is online and looking forward.
I hope my team is online. Good morning, everyone. Yes, I see that, I see my team is online, so I've not been abandoned. My name is John Black Kabuche, and I am here with a team from Uganda and Tanzania, actually. So it's not only Uganda. The project is in 2 countries, about exploring the role and feasibility of natural language processing techniques in mental health services. I'm from Uganda, and we do not have a very good situation currently with Ebola, which is why my colleagues are not here. You would wonder how I managed to reach. That's a different story, but now that I'm here, then I have to carry the weight of the project. But I will try to do as much as I can to take you through the project and what we've been doing and what we are still doing. As it was mentioned yesterday, this is not the final convening. And then my colleagues will also come in and support because it's really interdisciplinary and it's a group effort. And my colleague from Tanzania, Sadiki, is actually also here, and he will come and cover bits of what's going on there. So, do we have the? Are you gonna look? Yeah. Not that there's a lot that is in the slides. I can try to cover that, but it helps sometimes when there is something that people can look at and not focus on me. But yeah, there we go. Yes, at least you can see the people, the teams involved. And I will do a bit of the introduction, and the more technical people come in and speak. My training is in medicine. I'm a medical doctor. I did also I did my PhD in medical informatics. So I'm kind of at the border, and I'll try to bridge. But I have people who are experts in, especially the technical staff who will come in. So as the template was, the gap, if you can go to the next slide, we can, I think yesterday we had a good, yeah? Okay, looks like they need all right, so as they do their thing, it's always interesting when you meet with very technical people and then basic things like getting a presentation up fail. Technology has a way of humbling us. Maybe someone didn't pray to the demo gods, and that's why this is happening. We had from the keynote speeches, but also from the introductions of all the projects, I think a good coverage of what the gap is in terms of the human resource, in terms of the burden of the disease, and also this is something that the keynote from the Africa CDC is one of the things that needs to be studied, and that's something they need to know, and I agree we all need to know about the burden, and we also need to come up with efforts to, interventions to improve the human resource. And here we are trying to also leverage technology in different forms to cover that gap. So I will not belabor that because I think we all understand that, but I'll go a little bit narrower on what our project focuses on, which is about communication and conversation. So we all know that mental health conditions, communication is very important in healthcare, in documenting, in explaining what a condition is, in making a diagnosis, but I think it is especially important in mental health services. In Uganda, but I think also in many African countries where patients usually present with very severe conditions, there is a very big role of pharmacological intervention. So we usually put patients on antidepressants and things like that. But if you really look at the earlier forms of mental health conditions, there is a very big role of behavior and communication, and other places people use a lot of therapy. They speak, and there's also been ideas on things like sports and counseling and all these conversations. So in that spirit, we look at natural language processing as an important component, and this is where our project comes from. This project is based on an initial project that we're working on implementing a call center. Now, we all know about call centers, especially from telecoms and banks, as customer service centers. And this has been around, and we all use them, and we all hate them because we call in, and then you get this automated thing that usually helps to route you to a person, and sometimes you wait for minutes to get a person to speak to. And so we wanted to use that model, but not in the exact format, make it a bit more user-friendly. And so we set up a call center at the Butabika National Referral Center in Uganda. And we designed it in such a way that it is not a triage center. So as I said, most times you call in and they tell you press this to speak to sales, or press that to speak to complaints department. So essentially the call center is a triage. It helps you to get the right service. But if you think about the mental health delivery systems, there might not be a person to speak to. So you want that when you call into the service, as much as possible, you can get the information that you need right there without having to press this to speak to this person, because that person is actually not there, or they are busy in the clinic. And so we did this thing where we curate out of information and design it in such a way that people can easily navigate it, and they can find information using IVR. IVR is interactive voice response, and it's essentially, press this to get to that, and then the message is pre-recorded and you listen to it. This is attractive because the information is nicely curated, so there is no risk that a person is going to tell you something wrong, because the information is already pre-recorded. Because sometimes you speak to a call agent and they tell you information and you think, I would just go and Google it because it's not accurate. But of course, also the beauty that call centers, you don't need to be able to read, and you can, call at any time, and so on and so forth. So we had this in place. And after that ran for about 3-4 years, we were accumulating data, which is the call conversations. Because when people call in, these recordings, these calls are recorded for quality control. And what we've been doing is that at first we're meeting every week to listen to these conversations together with the clinical staff, and check that things are being done correctly. So are we giving the correct information? What are the issues people are calling about? This can be useful in, for example, deciding on who is going to man the call center, or to woman the call center, if you want to be more gender inclusive. So to choose the people who are going to be in the call center. And this is important for us because 3 of the people who are answering these calls are actually people with lived experience. And this is very unique in our setting, and also something that we're very proud of. And we've also gotten feedback from the callers when we're doing surveys that they actually appreciate the fact that the people that they're speaking to are persons like them. When we're listening to these calls, you hear the conversations going along the lines, "Oh, you mean you're also mad?" And then the agents are gracious to say, "Well, I wouldn't put it like that, but yes, I have also had a mental health condition, and I have been on the side where you are, and now I'm on the other side, and you two can go through it." And the callers really appreciate that. But that means that we also have to do this quality control, these checking in to see that the agents are themselves not getting overwhelmed by the conversations, but also because they're not mental health experts in the sense of clinical training, that we can support them. But as you can imagine, that is a lot of work of going to listen to these conversations. Sometimes we have, I think now we have about 4,000 conversations coming in a year, and so we can't listen to them. And so we thought, well, there are all these AI tools that are coming up. Maybe we can put them to work to do this analysis for us. And that is really where we come from. Instead of doing a manual review, we wanted to have these conversations analyzed using automated systems. So if you think about where this project sits in the mental health care process, it is on helping the healthcare provider, helping the hospital, helping the person who is in charge of the call center to improve the operation of the call center. That should help to situate where this is, because I think last time when we were doing a dry run, there was a bit of a confusion on where, because some people thought, oh, this is a chatbot that is analyzing the conversations and giving answers. We want to reach there, but we're not yet there yet. Okay, so I wanted to make that clear, that the role of this is to really streamline and understand what is going on in this telephone service. I hope that is clear. And so natural language processing, I think we all know about that, but it is about getting the conversations that are being that are happening in this call center, usually between a person who is seeking services, maybe a patient, maybe a proxy, usually someone, a relative, a friend in the community calls, and they are asking different questions. Most of them are about what can we do? There's this person who seems to have a mental health condition, what can we do? But there are others that are also about, I am a patient who is receiving care, and I have a question about the medicines, or I have a question about this. And we're trying to see if we can train AI models to understand that conversation, and then we can ask it some questions. So for example, what are the common conditions people are calling in about? or who are our clients? Are they patients? Are they other healthcare providers from other hospitals and things like that? And we have all been talking about the issue of data scarcity. So in this case, we have data, but it is in audio format, in conversations. So I think that's a step behind what we've been hearing from the conversations from the talks yesterday, where people have data sets in Excel sheets, for example, where you have variables that have been labeled, for example, the male group, and they have been coded. Well, ours has to be extracted from a conversation. So the first step is to see that we can make sure that the AI can understand it and transcribe it, and then begin to tag it and figure out this part of the conversation is, even just starting with who is speaking. Is it a patient or is it a provider? And what are they asking? Are they complaining about a clinical issue or is it an administrative issue? And things like that. And we're trying to do this in what we would call under-resourced languages. So we all know that there is fairly good performance of AI models and chatbots and Siris and all those for English and maybe other fairly well-resourced languages, Spanish, German, French, Chinese. But for Luganda, which is my mother tongue, which is also the mostly spoken language in Uganda, not very well. But even in English, some things can be confusing. I remember when I was starting on natural language processing, the common statement people would say was, if a person came to you and says, I have a friend with one leg called John, you will figure out quickly that the friend is the one who is called John, not the leg. But turns out that the computers can actually fail to figure that out. And that is a very simple example. Now, you can imagine when people speak about how the mental health conditions present in how knowns they can be, it's very difficult for a computer to figure out that this person has, maybe a depression or anxiety or something like that. The other thing that I should also mention that is when you are in a call center service, you do not have a complete history. People will present and say, I am having trouble sleeping and maybe I'm stressed at work. And if you are trying to put that on a DSM-5 or whichever criteria you use, where there is, for example, a component of time. For example, to diagnose depression, you might need to have the symptoms lasting for 14 days or more, and you need a whole criteria of cardinal ones and the not so cardinal ones. It becomes difficult. And so we had to rethink how we're going to code this, and we had a lot of going back and forth with the clinician saying, well, you can't make a diagnosis on phone because you don't have a complete picture. And we had to kind of change how we look at it and say, okay, if I gave you this statement, if a person says, I am having trouble sleeping, would you then put it more in the anxiety side, or would you put it more in the depression bucket, or would you put it more in the psychosis bucket, or would you put it in other, let's say epilepsy or something else, or even just administrative? And then for some, they would say, well, that can go anywhere. And we'll say, okay, fine, we can put it in anywhere. But if a person says, I hear voices while I'm walking, would you put it in the depression or in the anxiety or in the psychosis? And they'll say, well, that would go a bit in the psychosis side. And I say, okay, that is what we want. So we cannot have a very high confidence, but we can at least try to gravitate towards one group or another. And that is important when you're trying to train models, because many times people want to have a very sure yes or no, or black and white. And in this case, it's not like that. Or you have to combine multiple variables, so to speak. And that is the background that I wanted to give about this project. So we are trying to explore the different natural language process techniques and what can it be used for. What do people want these tools to help them with? Is it to understand the conversation and transcribe them? Is it to predict if this person is going to come back or not? Is it to assess the conversation quality, for example? In mental health, of course, we know that the issue of therapeutic alliance and how well the conversation goes can actually have an impact on the outcome. And in call centers also, we can try to get a bit of that in terms of, we have a framework called the nursing telephone dialogue process that looks at rapport and listening, and you can pick some of these from the conversation. Is there, for example, person listening, or is there back channeling? Are they encouraging the person to speak? Are they, empathetic? Are they picking up on words like, yeah, I understand, go on? And we try to train models to pick up on these, and we see how that relates to conversation quality. So that's the background that I wanted to give. And I want now to hand over to my colleagues online to take us through the different technical things after I've talked about the first objective, which was really to do qualitative engagement with the nurses, with the doctors, with the patients, with the peer support workers to understand their perspectives. As you can imagine, there are many issues here. One being the expectation. People might think, oh, so the AI is going to do all the work, and we needed to make sure that that is well understood, what is possible versus what people expect. So we did some focus discussions with, I think we did 5 of them with the different stakeholders. And we try to understand what the expectations are and what they want it to do. So they want the AI to help them reduce the workload. They want it to generate summaries that they can put in a medical record. They want there are some ethical issues that we were worried about. For example, if the AI can ensure the privacy, or if the information is going to be put online or things like that. So we discussed some of those, and we can give more details. But I want to hand over to the next bits of this process, which was curating the data sets that then were used in training the AI and what has come out of that. So the team online, is it going to be Bruno? Can you allow them to, yeah, great. Okay, over to you, the team online. Joyce and Bruno. No? Okay, I have been abandoned. No, I haven't. Yes. Go on, Sula. Yes, we can hear you, Sula. Go on.
Okay, yeah, so we used a team of so that we get hello. Okay.
It's this that you're looking for, Sula. Yes.
So the things we're looking at first, of course, are looking at the agenda of the caller and the agent, Is it the patient, the caretaker? What are they calling? Is it about mental health? Is it about administrative work that is provided at Mhdp-A? The status of the patient, are they in care in Mhdp-A or somewhere else, or they are not under care at all? What languages are they using? Is it English? Is it Luganda? Is it mixed or some other language in Uganda? Basically, another thing they are rating, they are looking at the audio quality. Is it poor? Is it fair? Is it good? Based on the network of the phone they are using. Basically, these are the things that we are looking at to get an understanding of the data. So of course, as I said, we use more than one person to do the rating. We did some interrate agreement, of course. So basically, these are some of the parameters, the language, the caller purpose, the audio quality, how the raters were agreeing on some of these. And as you can see, for some, they agreed. For example, the language, they agreed more. But for things like the audio quality, I think it is very hard to rate a core which is of good quality or fair quality. So that's why the ratings are so lower than the language percentages. But of course, for audio quality, we expect it to be low because it is something that is subjective. So this is some of the agreements we managed to get from what.
Before we leave this, Sula, before we leave this slide, I wanted to point the audience to an interesting observation with regards to developing data sets for AI. That there is a lot of disagreement, which is an important issue, even on something that you would think is very obvious, like language. Because most of the calls are coming in English and Luganda, and really anyone who would do this, if they would listen, they would say, okay, this is English and this is Luganda. So you'd imagine that there would be a lot of agreement on that. And sometimes we have these assumptions, and they are not, it's not difficult to tell between English and Luganda. The issue is about the protocol for annotating that data. And here, the cause of the disagreement is when there is people switching languages. And the annotator then thinks, should I label this as English, or is it Luganda, or is it mixed? And so then you end up with a disagreement. And the source of the disagreement is not that they can't tell what the ground truth is. It is in the labeling protocol. And I wanted to point that out because this is an important issue when you're developing data sets, and it comes out a lot. And if you see disagreements on the other variables, for example, on caller purpose, are they calling in because of an administrative issue or because of most of it is not because people can't tell you what the problem is, it's because the protocol is not clear on how they should be labeling. And that is an important takeaway for anyone who is developing, especially complex things like these. It is easier if you have made a protocol for, let's say, gender shall always be M and F, or M and F and other, or M and F and intersex and whatever different genders you're going to use. And then everyone has to fit into that. But if it is more nuanced like natural language processing, it is very easy for things to actually reach a disagreement. And if you have a disagreement, then you have a very small data set that you can use for training AI models. And that is something I wanted to point out on this slide before we go on. Sula, next.
Basically, when we looked at some of these parameters that we are looking at, for example, the caller type, we see most of the people that are calling in based on the data that we have, or based on the data that we looked at. So most of the people that are calling in are like the caretakers or the caregivers, and then the patients, and then of course other people from the general public. Look at the status. Some people are in care who called in, or some are not even under care at all, and that is a big percentage. And that saving is a big percentage based on the data we looked at. Next slide. Basically, I wanted to understand what this data looks like.
Can I also make a comment here, because I want to take the audience
Yeah.
through this as we go on.
Next.
The other thing that you notice here is that the people who are calling in, a lot of them are not the patient. That is important because we are trying to understand how do patients who present with depression or with psychosis or anxiety communicate. And you would have an assumption that you are speaking to the person themselves so you can understand how they communicate. But we are now speaking to someone else on behalf of the patient. And that someone else, the way they communicate does not have signals of depression or anxiety or other mental health condition because they don't actually have the condition. They are a proxy for someone else who has it. And that also is an important thing because we might have assumptions before going in and thinking, okay, it's a call center about mental health conditions, so we are going to really hear maybe people who are suffering from depression. Maybe they might have low mood, they might have fewer, maybe the speech is a low tone and all those kind of things that you would expect. And if a mother is calling on behalf of a child or a friend is calling on behalf of someone else, they will not have those signals. So that's also important assumption that you might have ahead of time, and then realize that this only applies to a very small 33% of the data that you have because the callers are someone else. It's also important to know that when you're designing solutions, you're not designing for only the patient, but the system around them, the caregivers, the community, so that even how you design, suppose you're making a chatbot, it should actually have that knowledge that you're not speaking directly to the person. Okay, and I wanted to also point that out, that the patients are only 33% in the data set that we have. And other people who are calling are people from the general public. Sometimes we have other healthcare providers from other facilities calling in, asking about services that Mhdp-A offers, because Mhdp-A is a national referral hospital. All right, go on, Sula.
Yeah. Thanks, Doctor. Okay, yeah. So for caller purpose, why are they calling, right? So most of the calls that we receive are basically about administrative work, but we still see there are more calls that are growing about mental health concerns, right? So people are starting to understand what the call center is really about. So we see a growing percentage of people calling about mental health basically, and of course other health conditions. People who call in about other health conditions. For audio quality, so what we basically got, we have so most of the calls or that we receive in good, they have good quality, and this is good for the AI models that we trained. But still, there are those vehicles where the quality is not that good, right? So when we go to the agendas, we see we have basically males. Okay. Yeah, males and females, but we have males are slightly calling in more than females. If you go to the language, basically, as Dr. John Black said, we are providing for now the services in English and Luganda, but we have a very few percentage of people who call in speaking other languages that the agents don't understand, but yeah, we are trying to scale this to other languages. But for now, we provide English and Luganda, and yeah, basically this is what we do currently. And so
I wanted to mention that for the Swahili, the service center in Uganda is only English and Luganda. But we were setting up a similar service in Tanzania to collect data on Swahili. So we don't have that yet because the service in Tanzania is just starting, and my colleague will talk about that. Yes, Sula, do you want to summarize this quickly?
You can summarize this as we proceed with the AI model.
Yes, so what we learned from the sorting process, I've given some highlights already on, for example, the kinds of conditions people are calling about. Yes, this mental health data price was focusing on anxiety, depression, and psychosis, but people calling in for so many things. They call in for epilepsy, for example, which is more of a physical issue. They're calling in, there's a lot about substance and alcohol disuse disorders. So we needed to cover a lot of those as well. And then there's issues about data, about audio quality. That is something to do with infrastructure and people having a bad network where they are, which very much throws off the models when they begin to analyze. If there's like a break in the audio, for example, they begin to mix up. We're going to display in the coming slides on, for example, the system trying to figure out who is speaking at a given time. Is it the patient or is it the provider? And the model quickly gets thrown off its rails if there is a break in the audio. It begins to associate the speech to, now you begin to hear that the agent is the one saying, I am having this problem and this problem to the patient. So there's a lot of those issues that are important to remember when you're training models. And maybe there's some models that can help to recover from poor audio quality, but a lot of lessons that we've been learning from here. As I highlighted, people like to hear from a lived experience person. That was very important. But also, we also realize that a lot of the issues cannot be solved. And this maybe is because people are not confident in giving you instructions and guidance while you are remote. And many of the times people will say, oh, okay, we hear this, but you should come in. You should come in. Yes. So we need to hurry up because of the time. Objective number 2 was data annotation. Okay, so the first part is sorting and then annotation. I'll try to go through this quickly and so you can come in later on because we need to hurry up on this. And so this one was really to understand the data. So from just the metadata of who is calling the sex and all that, now we go into the actual content of what is being spoken. So we have different teams, the linguists, 5 of them, trying to transcribe things verbatim and trying to tag who is speaking. And then we also have the clinical annotation where you have 3 clinicians, psychiatric clinical officers, who are trying to map the symptoms that have been spoken to DSM-5 diagnosis or just a symptom category. So things like this is sleep disturbance or this is delusion or losing touch with reality or things like that. And so we have that sorted on and then once we do the sorting, this goes into the AI model training. And some results of that you can see. Some of it is in Luganda if you can read. But what the data output looks like is that you have a timestamp to say at minute 1 and 2 seconds a caller is speaking and they're saying this, and at minute 3 and 20 seconds the agent answers by saying this. And so you have that. And then you also have the models begin to identify, is it a man or a woman? Because some of these things can affect how people rate their conversation quality. Some people prefer to speak to a man or prefer to speak to a woman. And so we have all these things extracted. And then if you have statements, for example, a person says, I am struggling, I can't catch up, then we can say, okay, that seems to be something to do with impairment in functioning, or Sina Minembe, which is no peace, literally. We can say that is about worry and anxiety. So the clinical annotation, we're trying to map these symptoms to a set of categories. And then we have the conversation quality, which I mentioned, which is using the telephone nursing dialogue process developed out of Sweden. And we're trying to see if that applies to Uganda. And you have the 5 dimensions: rapport, listening, analyzing, motivating, ending. Rapport is, the person greets or they introduce themselves or the different things about rapport. Listening is more about, are they speaking at the same time or is one leaving the other to speak? Because the model is able to detect at a given time stamp who is speaking. And if you have this overlap, then the listening part is a little bit low because one is not letting the other to speak. But we also have, for example, if a person has this back channeling, they're encouraging the person to speak. They are saying that, I understand, they go on, they tell me more. And then we pick those. And, ending is more things like, okay, I hope I've helped you enough. Is there any other question? Do you have any other issues that you want me to speak about? And the AI model has to pick some of those statements, then to decide what the rating is going to be on conversation quality. And again, these are important because then at the end of the day, when we have these, now they are monthly, they used to be weekly meetings, we would give feedback to the caller, to the agents and say, hey, this conversation didn't go quite well because there was a bit of a heated argument between you and the caller. Or, you did not let the caller speak properly, or here, this went well. We're trying to analyze that in an automated way. And then we go on to developing the models. And this is Greek to me. So Sula, please come and speak about all the different model architectures that you used. And you can do that quickly.
Yes, quickly. So basically, after the data annotation, right? So we went through, we went to the modeling phase, right? So what models can we get from, develop from the data, right? So the first model was basically one of the key models was speaker direction, or a model that can separate the speaker, saying, okay, now from this timestamp to this timestamp, there is a speaker, one speaking, or from here, the speaker two speaking, right? So that is the model we basically needed at first, right? And we developed that using the data set that we annotated, and of course, we added on some other public data sets that are kind of similar to that, all right? Next slide, I think I want to go through the metrics, but that's how the model was performing. Of course, as Dr. John Black said, we need to know the gender of the caller, right? So this is the model that detects the gender of the caller and the agent, right? So that we know the conversation, did the speaker want to, did they get more when they're speaking to a male or to a female agent? Basically, this is the model that we developed to that
In
detect the genders. Next model, I think,
I want to say
that was
something here,
about,
Sula, which is in the spirit
okay.
of open source and open data sets, that you can see here that some of the data sets we're using actually not from the call center. For example, to detect gender, we used open source data sets that have already been curated for detecting. So that is important to note because there is already people who have done work on. So deciding on who is speaking, gender, male, female, or language they are speaking, that is something that we don't have to solve because it has been solved. And if we try to do that, we'll spend a lot of time doing it, and we might not have a big enough data set. But it's not mental health specific. And so we can use what is already out there. And this happened in a few other pieces of this work where we were not using our own data set. We use our data set for things that are more context specific, things that are to do with utterances of clinical or mental health conditions. So that's something also to note here, because you see there's a couple of other models and data sets that have been employed in this, and then we have those that are specific to this project. Go on, Sula.
Yes, so another key model was, of course, the transcription model. I think this was a very important model for the next models that I'm going to look at. So basically, here I wanted to transcribe what the speakers are actually saying in the recording in Luganda and English, right? So this is the models that we developed. We have two models for this, Luganda and English. But for future, I think we'll need to do a multilingual model for English and Luganda and Swahili, right? So basically, this is what this model is doing, just transcribing verbatim the calls for the different speakers that are in the recording. Yeah. So the language ID, basically, of course, this is to take. I think this should come before the transcription, but this model basically just tells us which languages are being used at what time in the recording, right? So because some people speak Luganda and then they mix in English, so we need to tell them, okay, now the speaker here said something in English, then transcribe in English. Here they say something in Luganda, transcribe in Luganda, right? So basically, we don't use one model because some people do the code mixing when they're speaking in a conversation. Basically, this is the model for the role recognition model. So this model basically is telling us now this speaker 0, this speaker 1 is now the caller talking. This speaker is now the agent talking. At this instance, basically, this is the role recognition model, what it's doing. So the conversational quality, as Dr. Dr. John Black mentioned, we needed to use the nursing dialogue framework. This is a standard framework, so we needed to rate the model to rate the quality of the conversation using these 5 dimensions you see on your right: rapport, listening, analyzing, motivating, on a scale of 1 to 5, right? So we needed that model to tell us, okay, how did the conversation go between the caller and the agent, right? Basically, this is the model that does that. Was there a good rapport or motivation? Basically, the last model I think is the topic model, the topic modeling. So basically, this is telling us, showing us what symptoms are being mentioned by the caller in the call. If at all they are mentioned, if they are not mentioned, then this model will not give us anything. But if at all those symptoms are mentioned, right, things like insomnia, things that show these symptoms, things like suicide, fatigue, appetite loss, those things that show all these symptoms that you see on your left in this graph here. This is the model that tells us about that. So
I'm
I
going to
think
ask
that's all
Sadiq to
about
come
the
in
models that you'll be seeing in the dashboard. Thank you.
Thanks, Sula. We are running out of time, so Sadiq will talk about the Mhdp-A progress so far.
Thank you. So I'm going to take you through the Mhdp-A Hospital Call Center, which is located in Tanzania. And we already deployed the system and testing it, but we are working on the very, very minor issues. But we have already the toll-free number, which is ready for the callers across all Tanzania. As we all know that Tanzania, we have around 26 regions, and most of them, you can find only 5 major cities or regions, they do have psychiatrists, and others they don't have. So this call center will help most of the people in our country. And we're going to use Swahili language IVR menu, already recorded and uploaded in the system. And also we are going to have a 6 trained agent, of which we are already equipped with and ready for the work. And we are going to have, and the system will be having a recording system. And this is how the system will appear. So once someone calling, maybe you can go to the another one. When someone calling, you can see here, maybe I can show you. You'll hear the main introduction. So there will be a voice introducing you to what is going to happen in a call. And I don't think if you can see. Yeah, okay. So it will be covering the issues about mental health problem and mental health and mental disorders, and also introduction to most mental disorders, which include depression, anxiety, and others. And also will include the issue of diagnosis and treatment, and the issue of the referral system, and also how the Mhdp-A is working about So the service provided. So when someone is calling, will press from the introduction to say, okay, if you want to listen to to know about the mental disorders, then press 1. So if you press 1, you will hear about mental disorders. But inside it, you will find the most common mental disorders. But if you want to go back, you'll go back. And if you want to go back to the main introduction, you will be able to go back to the main. And if you want to speak to the call respondents, then you will speak to the call agent. So that's how it will be functioning. Next. Okay. So we had several feedback on that one, but that one I presented was already working on the recommendation they were telling us. So those key issues identified were the repetition in introduction, missing on navigation options, and IVR flows and content error. But all of those we work on them, and we come up with this very fine one for people to use. Thank you.
Thanks, Sadiq. There was a demo of this, but it can't play. We'll have to do it later. But what I wanted to comment about reusing protocols and using prototypes is that this is almost a smear replica of what we did in Uganda. So it was quite easy to get this going. from Uganda by translating most of the information and then doing some customization according to the, for example, how the referral process goes in Tanzania. And of course, if you are setting up a similar service in another country, you can use a similar model like what we did in Tanzania. The other important thing is the importance of iterative design. As you can see that even when we are using something that is already established in Uganda, it's very easy to make mistakes and you have to repeat and ensure that you test with users. So that's what is going on in Mhdp-A. We're out of time, so I wanted to finish up this quickly and allow Joyce also to give some concluding remarks. But I wanted to also talk about partnership and policy engagement, which we've been doing a lot. We had our launch event in Uganda last year, and the team in Mhdp-A came. But importantly, that we had important stakeholders like the Uganda Communications Commission joining us, the Ministry of Health, because this is important that it can be embedded. In Uganda, we're having some more call centers like this being launched by the Ministry of Health, by crisis events, for example, now in the case of Ebola. And we want to interconnect this so that when you call in because you are stressed about Ebola, they can link you to the Mhdp-A mental health service and the like. And we even had some chatbots like that at the time of COVID. So we need to have this engagement and linkage. We have also, of course, been working with the persons with lived experience. We have a good army of peer support workers that came from a different project and they have been trained. And so they're involved in this process in annotating the data, in evaluating and giving feedback, in rating conversation quality and telling us what really is important for them when they call into the service as representative of the patient population. I think in terms of conclusion here, Joyce, do you want to take this on? Because I want the boss to also speak.
You want me to speak? Good. No, I think we've run out of time. Thanks again, John Black and Sula for taking the bulk of the work, and Siddiqui presenting this. I think it's exciting, the steps that you can take when you think about building an AI model. Of course, we are not yet there. It's not perfect because, as John Black mentioned earlier, the data, if the data is not good, the models will not perform well. And it's really been a big process just to even get the data sets out, curated, agreed upon by both the annotators and the clinicians to even get the data set that we have tried to run this first prototype on. We do have a demo, which is a dashboard. Unfortunately, we've run out of time. We're not there physically, too many problems. But we are hoping that maybe we'll have a way of showing the demo to the room maybe later on or something, so that we actually see how these models work together, because once we presented the pipeline separately, but it's possible to actually have them put together on a call from end to end, just to understand how the whole system comes together to help with mental health care. So I think I'll pause here so that we have some time for questions. Thank you.
Thanks, Joyce. I think we had one last slide about what is next, and we can look at that as people think about questions. I cannot click this forward. Yes, so the next steps, one that I want to highlight is the clinical utility. So there's things that can be done. We can, for example, identify who is calling, or we can assign a role. But what we need to ask is, does the clinician actually care about that? And we've been doing a bit of that in the earlier processes of the conversation, of the earlier parts of the process. We engaged in focus discussions, and then we realized that the feedback that people were giving us was maybe not. We needed to give them a hand, like they needed to touch this thing. They need to get the developed models as opposed to something that is hypothetical. So we actually decided we're going to repeat these conversations later on when the models have been developed, and they are currently doing a bit of that. We had a couple of sessions last week, so that we ask, okay, we have AI that can, let's say, transcribe. Is that something that you actually care about? How are you going to use the transcript? Is it going into a medical record system? Is it a summary of the symptoms? What do you want to use it for? So that is something that we are trying to do, and we're going to continue to do that next. As we said, the team in Swahili, in Tanzania, there's been a lot of approval issues, data sharing problems. We haven't been able to solve that quickly, but we want to do that as well to train the models in Swahili. The good thing with Swahili is that it's a fairly more developed language, because there is also Swahili from Kenya, and we're hoping that will go quickly. But that is another step that we need to do to complete our project. And then the other thing that we're really hopeful about is, once all this data set is out there and it can be used, then maybe we can have the idea of an AI chatbot, so that we go from training the models to understand the conversation to having them generate responses to the user. And we're experimenting with that as the next step. All right, so I want to stop here and thank you all for listening, and thank the team in Uganda for being online and supporting me, and thank Aphrc, and welcome for the support.
Thanks, John Black and the team online. So I want to open up. We have 10 minutes for questions. And I think there are very many things you can ask. I want some. So one question there, I think, for Sam. Yeah, thank you.
Yeah, thanks to the presenters. This is very insightful, very unique solution. Congrats. I have just two questions. The first one is, I know, in Africa, people express distress through the use of metaphorical language. I don't know which process in your pipeline do you deal with that. So maybe someone says, my heart is heavy. How do you translate that into understanding whether they have mental health issues or not? And then the other question is, I think it's, okay, so the data that you generate seems to be like a qualitative data from conversations. And I'm wondering the kind of approach that you've used compared to probably doing a qualitative data analysis of the whatever you have transcribed, like maybe content or thematic analysis. How would, what is the value of the solutions that you are proposing vis-a-vis those other alternative ways of analyzing conversational data? Yeah, thank you.
Do you want to take that one or wait for a few more?
I can respond. Otherwise, I'll forget, and maybe I can preempt the next one by responding to this. Thanks a lot. So yes, metaphors and how people communicate. How I can put this is that we are not trying to manually extract variables, or let's say when a person states this, when they say this statement, it means that, which would be a literal translation or mapping to a condition. What we were doing with the clinical annotation is that they will get a segment, a statement of a transcript, which might have explicit mention of things, I do not want to live anymore, or I am tired, or I cannot take this anymore, or whatever way a person can express it. And then the clinical annotator will give it a high-level code, which would be, let's say, suicidal ideation. And so then you find that multiple statements, which are phrased different ways, they all map to the same symptom definition or symptom category. So we are not trying to train the models to figure out how a person specifically will say that they are, we have this also in English. When people say, I'm feeling blue, the model does not have to pick this literally, okay? And we had some of these coming up. This is not very clinical, but it is from an issue about languages. So we have a district called Gulu in Uganda, and the model will transcribe that as glue for sticking things together. And, well, we can't, that is what it is. And if you have to tell the model, essentially how you solve this is by giving model many more examples of these kind of statements. So this, maybe that aligns a bit of what you're saying, that we're not trying to give literal translations of statements, but the conceptual meaning, the semantic of the statements. And we don't do that explicitly, but we map the conversation segments to a given symptom category. Like this is about sleep disturbance. And that might be anything to do with, oh, I can't sleep, which is an explicit mention of it, or I stay up the whole night, or whatever. They might just say I stay up the whole night, which doesn't mention sleep, but it maps to sleep disturbance. So we are hoping that the models will figure out eventually what the different ways people express this. I agree that it is possible for the models to miss, and we need to have more examples of that, but that's really the approach. We are not trying to do literal translations of the metaphors. on the qualitative data question, we are not doing thematic analysis in the sense of theory building, that we are going in and trying to find out what is in the data, because we have some preformed ideas. So this is more of a deductive mapping to what we want to achieve. So we're not open. We are trying to find, for example, conversation quality assessment. We already have a framework on what conversation quality assessment looks like. And so we're trying to map to that. So when we see that a person did not introduce themselves, we can say, well, on the rapport dimension, that is missing. So we are not doing an inductive qualitative assessment. Of course, the data set can be used by another person who has questions that are in that form. But for now, we have things that we're looking out for because of the hypothesis that we formed a priori. That covers it, right? I think so. I covered both.
All right, and mine is just a question of clarity. I heard you saying that the two can detect the gender. Is it the gender or the sex?
Thanks. So my question is around, I think you were saying that you have more non-patient callers compared to the patients. Let me put it just that way. So I'm wondering whether there's been any kind of like effort to find out in terms of this process. Do these people, the non-patients, call with the patient close by and then trying to find out about a particular issue? Or do they call really just to, for their own kind of information or knowledge around that? And yeah. And then if they are calling as non-patients, do they have like permission from the patient? So I'm looking at that's more like around ethics kind of thing. Thanks.
Oh yeah, I can address those. So gender versus sex, yeah, you caught me there. Let's say we have male, female, that's where we stop, okay? I know that the terms keep evolving, but we're being pragmatic here, saying, because the model that we're using to detect, it looks at the voice signature, and there's a difference between how men speak and how women speak. Now, of course, if you are, let's say, transgender, of course, that will be wrong, because or if you have gone through sex transition, the voice signature might be different. I would say we do not have a very big number of that, but we are also being pragmatic, 80-20 rule. We cover for the majority, and people who fall through this, we can make a mistake there, and we solve it after that. But yes, we are cognizant of this, this issue. The proxies, so it's all over the place, but the majority is that they are calling when they have a patient with them. They might not be in the room. Actually, many of them are calling because they are like, oh, I am here in the community and I see a person outside who is throwing stones. Or I'm seeing a person who is walking around and they seem to need help. What do I do? So the community members do not know how the process of seeking mental services for themselves or for the people that they see around. And that's also an important issue of the call center. People can call and ask, what do we do? And commonly the response is, can you find a way of getting this person to cooperate with you so that you can take them to a nearby facility? And if they can't, maybe you need law enforcement, you need the police maybe to help you. Many times people call to ask for an ambulance, which we cannot send. But usually rarely do we get people calling just for their own information. They are calling in when there is an issue that they see that is next to them. So that is the status of the calls.
Question. In terms of moving this from research to now like implementing it, I'm curious what kind of conversations you've had, say, with your different stakeholders, government, etc., and what are they saying in terms of finally owning it? Someone has to pay for it as well. What are they saying they need to see so as to kind of now implement it? Additionally, what are your referral, like once a patient calls, what then are your practically referral like pipelines? Is it is it ending at, okay, we've given you information, or like how are you ensuring that there's that maybe continuity of care, or even just ensuring these people get care? And sorry, you also mentioned that only a third of your callers are are the ones actually going through whatever the illness is. I'm curious whether you've done some additional research on why that's the case and how maybe you can more directly reach the patients themselves. Yeah, thank you.
Yes, thanks. So scaling and who is going to pay, we are engaging, we're engaging different stakeholders. We have engaged, for example, one thing about payment. So when someone calls into a call center, the main cost is actually the cost of credit, the phone bill. So right now, the calls are toll-free. So they are free to the caller, but the hospital has to pay for the phone bill. Fortunately, the cost is actually not very high. So the hospital can put this on their budget. And this has been happening because when we set this one up back then when I was doing my PhD, 2021 or so, we had a small budget for piloting it, and then later it was taken on by the hospital to pay for the phone bill. And this is also why we want to do the automation using interactive voice response, because then you don't have a lot of human resource involvement. But you might want to improve, let's say, add a new message, and that requires you to go to the studio and record. And so we're trying to make sure that the hospital takes this up and owns. We are also engaging with telecoms, especially like MTN. When we're doing our launch, we ask them to join us so that they can waive off the cost to this, so they can zero rate it. And so there's two ways to do this. One is you can ask the telecom as their CSR, and they can say, okay, the costs that are going to this number will be zero rated, or you can force them by going through the telecom regulator. So we have also done that, going to the Uganda Communications Commission, and they actually have the power to force the telecoms to say, calls that are going to this number are important public health service, don't charge them. And the telecoms don't really lose that much. So we're doing that engagement. But as of now, we actually haven't had problems with credit because it's actually not very expensive. The issue that comes in is, for example, with AI and having to run models if we're going to do this, because then the compute is high. So for now, we are using a bit of the grant to set up GPUs at Butabika. If we ever need to get another high-end GPU, that is going to be a problem. But we are engaging different stakeholders to make sure that that is catered for and sustainable. On the question of referral, what do we do? So this is actually interesting because we have our group of the call agents. We have about 8 of them and the clinicians. And when there's, for example, a person calling in and let's say they have suicidal ideation, that is flagged to the team and someone has to call. Usually, it happens if the agent who answered, it's a round robin, so anyone can answer. But sometimes when the call goes to, let's say, a peer support worker, they might not be in position to handle that case. And then in that case, they flag it, and then someone who is a senior psychiatrist calls them back to find out what's going on and to see that they can come in as much as they can. And this was actually an interesting issue because when we were sorting the data, the assumption was that people were calling in and were answering, and then many of the calls were actually originating from the call center going out. And that actually caused a bit of a problem in the model detecting who the caller is, because at first it was thinking whoever calls first saying hello is the person who originated the call. And it turned out that many of them were actually coming from the call center going out to the patients. So we have a bit of that follow-up, which is unorganized. So it's not a technical issue, it's a more of a workflow issue that has been ongoing with and without this project. And then we, of course, ask people to come in most of the cases because we don't know what's going on. And we follow up maybe a day or 2 days later to see if they came. And sometimes it's not successful. It's what it is. And then the last bit was about that a third of the people who are calling in are actual patients, and then the proxies. So yes, I think the main reason for this is that this is the National Referral Hospital, and it handles people who are really severely who have severe mental health conditions. And so they might not be in position to actually handle the phone, to call on for themselves. They are in, it's a tertiary referral hospital. So people who really, maybe they are suicidal or they really have, lost touch with reality. And so the people who are calling there are very severely sick, so they might not be able to call. And someone else calls on their behalf. And often they don't have approval from the patient because the patient is not in a good state to actually do this. We do have people who call in later on for themselves, and then those are usually in a much better mental health state, and they call in to just interact with the hospital and ask for follow-up questions or to refill medications and that. But that also, I think, illustrates the availability or lack of mental health services and why we need to have more of these services spread across the country. Over.
Thank you so much. I think we've run out of time, but thanks very much to your team for the insights. So a lot of questions, maybe we can hold those during the networking session. So John is here and Sadiq, they will be able to answer. And thanks to the online team who could join. So I'll invite Trust and his team. Thank you so much. Yeah, thank you.
Thank you. They opted to guard me. Security. The security. All right. Thank you and good morning to you all. For all of us who are here, we are 10 voices in an opera or in a choir. There are about 102 other projects that didn't make up here, not because they were bad, but maybe they didn't suit the choir of the Mental Health Data Prize Africa. So we happen to be one of the voices, Pamoja. Pamoja, maybe for our Swahili brother, or Swahili speaking brothers would know that it could rhyme closer to Pamoja, oneness. So oneness was also depicted in our project from the onset to the end, in which we worked with different stakeholders in their different capacities and represent different constituencies to come up with a solution that better speaks to their needs and to address the needs of their constituents that they represent. So as Pamoja, we co-developed a mental health data discovery platform and harmonized mental health measures for young people in South Africa. And here, I've Linda Mazibuko, Augustine Kumalo, and Audrey Moyo, and myself, Trust Gangaedzo, representing a very diverse team in terms of seniority, research backgrounds, and also institutions. We are about 5 institutions and people from health economics, psychology, clinical mental health, as well as epidemiology and data science. And what we are also proud of in our team is a team composition in which we also have as one of our lead data scientists from one of the 10 youngest universities in South Africa. So, with our project, I think we all agree, the 10 teams that are in here and those that were not here, that mental health is a serious issue or public health burden in global. So this is not an exception for South Africa either. Mental health is among top contributors of the burden of disease in South Africa, contributing as the single largest contributor to dialysis in South Africa. And unfortunately, 15 to 39% is the rate or the average prevalence of mental health in South Africa, of which the highest burden befalls on the young people, about 30%. So youth mental health, even though it's high as 30% as it is, it often remains underdiagnosed, undertreated, and misunderstood. So for us to act effectively, we must first understand the scale, the context, and the nature of the problem. And for this to happen, we really have to have good data, for they say what can be measured can be managed. But what about the quality of the measure? That's where Pamoja comes in. So, besides the South African stress and health study, which was conducted around 2002-2004, we didn't have any other large-scale population-based study for common mental health, especially on the diagnostic side. We later have a lot of individual screening studies. These are valuable studies, but often fragmented, using disparate measures. And we also do not have, at the current moment, a harmonized mental health data ecosystem in South Africa. So there's a need for a central repository to access and compare youth mental health measures. And to the right of that slide, would see that these are, for example, one of the fragmented studies in which mental health was measured in rural areas by Audrey and team, who were part of the first Data Prize Africa. So what our project does is to try to create or develop an open access, inclusive and user-friendly mental health data discovery platform to advance mental health research, surveillance, and policy in South Africa. So we understand that there are a lot of studies, which was part of our objective, firstly to scope or identify mental health studies that were conducted in South Africa, then bring them together, harmonize them, and make those resources or the studies open access. So for example, we have DataFirst, we have Saprin. All of these studies, they use different measures of mental health, which would make it difficult to compare, because different institutions or individuals that conduct a study, they conduct such a study to sort of achieve their own objectives, which may mean that reusability of the data normally falls through the way. So where we come in is trying to sort of identify those studies, make them available to users, so that if there is anyone who wants to collaborate with these researchers, they would know where to find them, and also at least identify the gaps that are also in the research field, which studies were undertaken, which are most likely to be undertaken, or how can we collaborate, how can we reuse those data sets. So all these studies have to be ethically approved and in public domain. So our solution is basically two main sort of contributions. The first one is the data discovery, in which we develop a structured data discovery platform that centralizes access to fragmented data sets, supports multiple access, pathways depending on data availability, provides research-ready metadata. Then we also have the harmonization component, in which we extend the harmonization approaches from our, so in our team we have a collaborator from the UCL who are leading the Harmon project, in which they're doing harmonization. So we also borrowed and adapted from their study, then fine-tuned the models to suit the African context. So, on our platform, in terms of harmonization, users can choose individual models for an ensemble approach, flexible and transparent harmonization across South African languages. This means the researchers can compare depression scores or anxiety scores that were sort of conducted using different measures or different languages. So from here, I'll pass on to my colleague, Linda Masbugo, who will go through the process of co-development, the workshops we went through. Then from there, we'll go to Audrey, who will now give a flow process of what harmonization entailed in our project. Then Augustine to demonstrate the platform, or to showcase at least some features on our platform. Then I'll come back to conclude. Unfortunately, guys, you have to remember that our slides have moved. Joel, you owe us.
Good morning. My name is Linda, and I will take you through the lived experience integration into the Pamoya project. So I must say, lived experience was split into two folds. The other fold was the lived experience as part of the core research team, and the lived experience as an external force coming in and contributing towards the Pamoya project. And from the internal fold, we created a policy on how to integrate lived experience into the Pamoya project. And what came up from there is to make sure that the Pamoya remains contextually relevant, and it also prioritizes the voices of young people. And we were also capacitated through the Aphrc lived experience leads, that's Benta and Oyango, or through the monthly upskilling workshops. And the team contributed to the content creation and the integration of lived experience researchers and lived experience experts, the perspectives into the platform. And with that, I can say that we had actually brainstormed and decided that we'll go with the color green, which is the internationally recognized mental health color for the creation of the platform. We also devised or created a directory of verified mental health services for adolescents and young people. across provinces in South Africa, which comprised of hospitals, public health facilities, higher learning institutions that provide mental health services to young people, and local organizations that also provide the same services to young people. And the next slide, Joel, can you assist? The next slide shows the first launch we attended in Cape Town. You can go to the previous one, where we had panel discussions with the lived experience and the mental health advocates to explore and try and get a sense of our understanding with what data means for us. And what came from that is the data for us is a way of telling a true story of, or giving a true reflection of the true reflection of mental health. And also that when we have it data, then we can use this data to hold people in influential positions accountable in ensuring that we have access or better access to mental health services. So these are the pictures of different activities that happened there. We have a group picture and a picture of the meeting that happened the following day. And the outputs from there is the Mail and Guardian newspaper article that came from that. And there is a scan there for your perusal to just check. And the South African Federation also gave you feedback on the launch on their platform. And you can move. And the Mid-3 project, then we had the lived experience and stakeholder engagement that happened at VETS in November last year. And this is where we brought more young people with lived experience and other key stakeholders in providing these mental health services in our community to engage and interact with the platform and also give suggestions on how we can make a platform relevant. And I think this is where a lot of young people said this platform would be relevant for them if it provides a link to mental health services. And this speaks to the directory. And the key output there was the newsletter article by the Saprin Connection. And there's different photos there of the Pamoya team, the group picture, and the platform interactions. I will pause there and hand over to Audrey. Thank you.
Thank you, Linda. Just to add on to what Linda has said, and on day 2 of the November workshop, we had an opportunity to share with students, researchers, and other stakeholders of the knowledge that we know on natural language processing and large language models. So we had a capacity building workshop on day 2. So moving on. So as part of the platform, building the platform, contribution to the harmonization component of the platform. This is the kind of work that we did previously. So we started by doing data scoping. So we're scoping for mental health data sets in South Africa. And the second stage involved extracting the mental health instruments used in these studies. And the next stage involved the metadata harmonization. That means harmonizing the instruments using natural language processing. And we did a proof of concept to show how we can proceed to do data harmonization. So in terms of data scoping, this is just a brief description of the data sets that we observed based on the mental health studies that have been published in South Africa. So we identified about 19 studies that have been published in young people. And most of the data sets that they used were based on surveys, school-based surveys, community-based surveys, and only like one study used a nationally representative survey. So most of them, they were more like small studies, as Trust has mentioned, being conducted in silos. In terms of geographic location, so South Africa has got 9 provinces, and we found that there's a lot of studies being conducted in the Western Cape, whereas other provinces, we're not seeing many studies on mental health. So it's already showing us the Cape, also reiterating the gap in the mental health in South Africa. And in terms of instruments, most of the studies were using different instruments such as the CSD-10, the PHQ-2, the GAD-2, the GAD-7, etc. So it's different instruments being used in South Africa. We don't really have so that's where our platform becomes important. How can we be able to get a big picture of what's happening in terms of mental health when we've got these small studies? So the best we could do is we could do data harmonization so that get at least a bigger data set to be able to see the different patterns in mental health across the country. So as a proof of concept, Joel, could you please move to the next slide? Thank you. So this is just to showcase, you get a better picture when Augustine goes through the platform, but this is what the platform helps. So we identified 2 data sources, that is the Saprin and the DataFirst. So DataFirst has got the needs dataset and the needs CRAME, which was conducted during the COVID period. And for these instruments, Saprin and the needs CRAME, they use the PHQ-2 instrument for measuring depression. So this is the same tool, whereas the needs use the CSD-10. So to support meta harmonization, we took the instruments from Saprin, the PHQ-2 and the needs CRAME, and we put it on the platform, and using natural language processing, we ran the harmonization component, and these are the results we got. Yeah, it's supposed to be 100% because it's the same tool, but it's just a matter of minor change in wording across the instrument. So in this case, on the left, we just had to do direct merging of the Saprin and the needs CRAME data set because they are using the same tool. So all the instruments match, so all the questionnaires used match. So basically it's just a merging of data set. But on the right, we're now moving on. We're trying to merge now the data set, the merge data set with the PH2 questionnaire with the needs, which has got the CSD questionnaire, which is like 10 questions. We found that only one question in PHQ2 and one question in CSD merge. So we can't further do harmonization, basically. So we're still exploring in other ways we can harmonize, but as a proof of concept, we just have the harmonized data sets on the platform. And now I will now give to Augustine to go through the platform with you. Thank you.
Thank you, Audrey. Okay, so first I will take you through on the overall system architecture on how did we develop our system. So from the slide, you can see that we are using the microservices for the backend, whereby we are like using what we call a programming language with the fast API framework. Then for the front end, we are using React. So like on the front end, we are using what we call React for the front end. So in terms of scalability and sustainability, so what we did, we have the modular system architecture, which going to allow us to be able to evolve our architecture in such a way that whenever we have changes on the platform, we don't need to kill the entire system, but we can be able to modify one system at a time without destroying the entire system. So on the second point, we are using containers, the Docker containers, which are low cost and allow us to be able to deploy our system with an ease that different, like within a different institutional servers. Then in terms of open and reusability infrastructure, we know that we are utilizing the already pre-trained models, which is costless and does allow us to be able to harmonize most of the instrument with an ease. Then in terms of efficiency and model integration, then we also have the incremental support scaling approach. So Joel, can you be able to take me to the platform? So like going from this point going forward, I would like to use the platform so that I can be able to showcase some of the things. Yes, please. I think, yes, you can do it live. I think I did give it to Angela too. Okay, while Angela and Joel, they're still assisting, I will take you through the slides. Then once the platform is live, then I'll be able to walk you through. So the first step is with where we are focusing on the item harmonization, whereby now we're trying to harmonize different instruments. So now from the platform, when we try to harmonize different instruments, is that it's not moving. Joel? Okay, so the process of us harmonizing a different instrument, firstly, what you need to do, you need to go to the platform, and what you do, you need to select instrument that you like to harmonize. So let's say in this case, we would like to harmonize a PHQ instrument. So you need to select the two instruments that you would like to harmonize. One that will come in an English version and the other one that will come in isiZulu version. So from there, what you will be able to do after selecting those two different models, you need to now click harmonize button. So like what it's going to do is going to run from behind and it return the matches. So when we are harmonizing the two different instruments, what are we trying to achieve from there? So what we are trying to achieve, we're trying to get the semantic analysis that has been performed by the LLM models, whereby let's say we have two different sentences. One that's asking, how are you feeling? And another one that is asking, are you feeling well? So like from those two statements that I just mentioned, they are written in two different semantic structure, but they mean almost the same thing. So that's what we are trying to do at this point. Okay, sorry about the delay. Yeah, you can zoom, please. Okay, can I please? Okay. I'm struggling to see. Can I come? Yes. Joel, can you assist? Okay, sure. Okay, sorry guys about the delay. So yeah, here this is the process that I was explaining on first choosing the instrument that you like to harmonize from the system. Then after choosing that two instrument, so at this point we'll say we are harmonizing the PHQ instrument, whereby we'll select the English version and also the isiZulu version of the PHQ instrument. So from there, what we need to do, we need to run to harmonize those two instruments. So after we have run the analysis, now we are able to compare the two instruments that we harmonized. So at this point, we can see that from this point, we don't have the instrument that matched our desired threshold. So that's where we started now in fine-tuning the model, whereby the initial harmony, it was pre-trained to use the English version and mostly the Afrikaans model. So the model was not performing well. So after we have fine-tuned the models, we added extra models that they can be able to assist us to harmonize the South African contextual languages. So now what we're gonna do, we're going to show you on the discover aspect of things. So from the discover, what are we focusing on? We are focusing on discovering different data sources because we know that we have multiple different sources, but which are sitting in silos. So in this platform, what we are working on, we are trying to bring all those data sets so that they can be discoverable. And you being able to discover those data sets, you are able to view those different data sources, then you can see the overview of that specific data set that you like. And from there, you are also able to see the linked studies that are linked to that data set. So what do I talk about when I talk about the linked studies? I'm talking about the studies that were done using that particular data set. So from there, you being able to see all that, let's say now you are interested in utilizing that data, you are able to contact the custodian of the data set from here. So it redirects you to the emails and give you the contact people of the people, of the people that you need to contact. Then we also integrated the lived experience on our platform, as Linda did specify, that from our platform, we are able to see what you call different stories that have been uploaded on the system by people with lived experience. And we also have different, what you call contact details for organization that are working with the mental health data set. So going from here, I would like to bring it back to Trust to take us through the remaining parts. Thank you.
Thanks, Augustine, and thanks, team, for that. So from where Augustine had left on the dashboard, especially on the lived experience component, when we conceptualized our study, our aim was to scope the data sets, harmonize them, make them discoverable, and open access. But then when we went to the people in June last year during the launch, and in November last year, mid-project sort of meetings, what I actually pick is we had what we wanted, that is the data, the numbers and everything, but what actual lived experience in the communities or the stakeholders would want is the stories for people to read what the lived realities of other people. So for example, there could be a link now on the lived experience component where you'll be directed, let's say, to stories of people that are living with mental health illnesses, how they cope, how it started or how they found out, and then direct them to services. Where do they find services? The numbers are there, 50%, 60% prevalence rate, but where do they get services? What benefits most of them is the services. So yeah, I would like to just say in short, with this whole process of our co-development process, there is a saying in Zim, a proverb, which literally means to know who grandmother is, you have to be taught. In deeper meaning is, you don't have to experience everything for you to know that it exists. You can learn it through other people's experiences, and that's where lived experience is very important. You would know what are the signs and symptoms, where do you get the services, how do you deal with it, how do you cope, and it will actually in the end build resilience and for you to be able to deal with what you're going through. So in terms of the research output in this study, we have had a lot of newsletter articles, LinkedIn posts, and these are examples, the screenshots from what we've been publishing. And for example, we have the SACAB, which is these are data science, sort of a Sub-Saharan African consortium of advanced biostatistics, which also attended part of the capacity building workshop that Audrey mentioned about, in which they learned from us how to use large language models, especially in health. And on those slides, that was our first time, Augustine and I, to meet Christine, who were meeting through email, but physically we met at the Saprin annual conference last year in Gordons Bay, Cape Town, South Africa. And the one who is smiling is to the left is Linda Maoy, I think is here. Then at the center there is Audrey. And Audrey, in that instance, that was October last year, the South African Mental Health Conference. She won the best poster of that conference. It was a big conference. Then at the end of this month, Augustine will be presenting at the African Data Science Conference in Johannesburg at University of the Witwatersrand, which is just got ranked #1 in the world. Clap hands for us. So in terms of papers that are ongoing, we actually have now our draft for that co-development for the protocol, which we are targeting to submit at Wellcome Open Research. Then we also have another draft, so it's a communique which we already are revising to target the Lancet Regional African Journal, mostly on protecting and intentionally saving adolescents with lived experience embedded in mental health research in Africa. We are also having another one that is also looking at the data governance in mental health. And as also part of our studies, when we were doing the harmonization, like Augustine was mentioning, in terms of the performance of the models, how we fine-tuning and modeling, we already have results of those sort of evaluation of those models that we are using on the platform. So it can't be a journey without reflections. This is just from different aspects of the project. From the project management, which Audrey and I mostly occupy, we have stories. Collaboration is very beautiful. This is what we learned along the way, but it did also its shortcomings, which we also dealt with. So I think our project benefited much from a large diverse team, which actually also helped for us to identify stakeholders and sort of increase the buy-in. We also collaborate with an international collaborator. And the other thing that we benefited most, as you would see, most of us here are LKLA researchers, and I'm the PI. We benefited much from the support from the senior staff, who gave us guidance and the freedom to explore and enjoy all this research and research management, funder engagement, and so on. So we also sort of disrupted now how sometimes data sharing happens, especially in South Africa with two main institutions that do with the data. The fights we are watching from the terraces and so on, but it's a learning curve. And also along the way, it was capacity building. Internally, like I mentioned, us, the LKDA researchers working with the senior researchers, and also having a workshop in which we were teaching sort of other people in mental health space about using large language models in mental health, and also with the stakeholders that we've been working with, the lived experience experts as well, to see how they can best sort of enter also into the research space, amplify their voices, especially for advocates. We have also had main LinkedIn posts from the team, which were reshared and posted. Then we have testimonies from, for example, SACAB and the South African Federation for Mental Health. From the lived experience point of view, the reflections are that meaningfully engaging lived experience improved the relevance and the contextual sensitivity of our platform. However, we would like to put out that it took time for us and for the team in general to understand the technical language and orientation of the research to be useful. For example, indicating that with this type of research that we are doing, which is not an intervention, it's a data science project, it is like time is required for the process of the integration to become more intuitive and highlights the importance of involving lived experience experts and researchers from the very beginning of the research studies. But again, though it took time, it was also with the assistance or the support that we got from the APHRC in trying to understand. But again, we also have to know that also even still contextual differences. Main researchers would know when we go through a co-development or co-creation sort of approach, we take every participant as a researcher. And in some cases, you might not actually need ethics, but when you're in the African context and you mention that you are working with lived experience experts, ethics become more important. and the hurdles of explaining where they fit in and how you are not most likely to exploit them and so on. So it was actually interesting, and we think that we also pass this on to other teams that would like to sort of use a co-development approach, especially with lived experience experts. So it has also raised awareness on the potential of the platform for mental health advocates, for lived experience experts and NGOs who save the mental health for young people. And most of young LEs that we have engaged with are excited about the platform, especially in terms of its advocacy potential, but they foregrounded the significant need for mental health services, which are currently lacking in South Africa. That's why on the dashboard they to sort of advocate for us to put the stories and directions to services. Right, from the platform side, so the strength of our platform is that we developed with intention of making it open access, but also with scalability. So what we just did in this instance, in this 1 year that we're being funded, is to create a highway, a data highway. We may not do everything that we needed to do, like Audrey mentioned. What we now did, in addition to harmonizing the instruments, we harmonized the data items themselves to try to show that it's possible to do this. And so that for all those people, for all those researchers that would now need to use our platform for these services, they can now use it on that. But it will be outside the project. But the highway is there. We created it without having the cars yet. So we also use robust large language models, which we evaluated and trained for local languages. And also our project is strong links to Harmon platform, which means in terms of sustainability and scalability as well. And Harmon is currently used across the globe. Also, the challenge that we also faced, like Augustine mentioned, was to deal with the stability of the harmonization processes with local languages. From the analytical side, the analytics dashboard provides the key mental health metrics at a glance and was designed for scalability, makes it possible to extend beyond South Africa. And we also have to point out there that the instruments that we use are not diagnostic instruments. They are screening tools which depict probable caseness. So we use reliable and adequately powered mental health. Reliable and adequately powered mental health data in South Africa is sparse. So our tool is trying to bridge that gap to ensure that surveillance and interventions as well as policy making improve in South Africa. From the non-technical side of the scalability and sustainability, we would like to look at 4 main items. What we did to make sure that at least beyond the funding phase of the project, we attached ourselves, our platform, to already existing or already established research institutions in South Africa. For example, the Data First, Aphrc, which does the demographic surveillance, health surveillance. And in terms of financial uncertainty, we are yet also to calculate the operating cost of the platform beyond this and try to now have an investment case as to who adopt it or how they fund it. But for now, Aphrc is committed to be the primary sort of host with the Data First and Aphrc secondary options. We also take cognizance of that there are competing priorities also from these institutions that we are dealing with. That was not their core sort of mandate, but we sold our idea to them, which they were able to take up with. So we might not be prioritized in some cases, but we hope that we have good agreements with them that they will be sort of supported. But also financially, they might not also have the capacity to drive their main agenda and ours. So we still also hope to survive and live beyond the project by strategic linkage to existing platforms. So a summary of our innovation is that simply that we intended to do things that we intended to do, but we ended up adding because we talked to people, we heard what they wanted, and we then incorporated it. And this was done in different stages. And so, for example, when we did the harmonization, we fine-tuned the models to make sure that they actually speaks to the South African languages. And like Augustine presented or showcased, and will also showcase later on, we now have a centralized access to fragmented mental health data sets. We direct you to where they are. And on our platform, we also have now a data set that is already harmonized that researchers could access and use. Now, we also incorporate lived experiences on the platform in terms of their lived realities and where services can be sought and in different capacities. Then the core development, which was the anger of this one, is just simply to work with everyone who is in the mental health space to create something that speaks for them. Because in many cases, platforms like this do exist, but sometimes they exist with the mind or the initial concepts that are sort of birthed by the researchers themselves. But when you go to the people now, you know that in this platform, instead of the data alone, we now have a chain until to the service provision, which is the main goal. Data without being utilized to improve well-being is just like a bell. Its duty is just to make sure that people gather or disperse. But now, because we know people could access all the services that they need, we think we have added more to what we have initially sort of planned. And for those who would want to collaborate with us or have other questions that they may not ask because they are shy to put us under the radar, you can contact us on those emails. And it can't be, I mean, like I mentioned earlier on, it was 112 projects that applied. We are here because we qualified to be here, and because maybe the rigor of our work, we would like to believe that we did a justice to what we are doing, and we still continue. So we'd like to thank the funders, the African Population Health Research Consortium, Wellcome Trust through the Mental Health Data Prize Africa. This was an amazing opportunity, a good learning curve. As a PI, this is my first grant in the context of funding cuts. So, and also with our early career researchers here to enter into the research space to learn how research is, how to create lasting collaborations, either locally or internationally, to engage with funders, to discuss, have had conversations with Fred, Joel, who is it, Francis. Those are our main contacts. Thank you guys for your support. And I was asking since I came here to see Eunice. She was also part of the people that we talked quite a lot. So I'd like to thank you guys and Sylvia. When we go to Sylvia, it means it's another stage, but mostly Fred, Francis, and Joel. Thank you for your support. And yeah, and the other co-awardees, Bianca, so we're having conversations on how to run this, as she's also a career researcher. So thank you all, and may this continue.
Thank you so much, Trust and the team. So we'll take questions from the audience, and yeah, it's really good to see.
Okay, thank you, Pamoya team. That's really interesting and exciting. And I know that both Audrey and Darshini were also part of the first Data Prize. So for me, it's even kind of more exciting to see how our cohort from the first prize can kind of be part of the second Africa-specific Data Prize. So the one thing I kind of wanted to ask you. From a funder's perspective, it's amazing to see collaboration between our different fundees. And I know that you've been collaborating with the Harmony team. So could you perhaps tell us a little bit more about how this collaboration enabled this project, a little bit more the nature of how did you use the Harmony tool to enable kind of like what you are doing as part of this project, basically?
Yes, I can add this. Thanks for this presentation. I have a question which I asked yesterday of the Meru team, and I see the same thing is coming up, and I was actually discussing this with Ekin as well. And I saw a slide on the data architecture, so I'm going to ask the question that I asked yesterday about structuring and standardizing the data, because you've been trying to harmonize more from a natural language processing perspective, but that is, in my opinion, very difficult, and I think that many people will be agreeing to this. And that's why there's been processes to structure and map to standards like ICD-10 or SNOMED CT or other interoperability standards and being able to package that data also using frameworks like HL7 so that every other new system that will come up later on or one that is existing somewhere else can share that data because the data is coded in the back. Have you done this? This interoperability framework using things like OpenHIE, for example? Is this something that you have done? I'm very curious to hear your experience on that, and maybe I'll discuss more with you on that.
So we can take that too?
Okay.
Yeah, okay.
I think I'll try to answer your first question. How did we collaborate with Harmony? Yes, so with Harmony, when they came on board, so I think when you said Audrey and Dashin were part of the first mental health data prize, so was Harmony. So what we actually did, so it was sort of a continuation from what Audrey and team did in South Africa to identify the data gaps. It fed actually up into how we conceptualize the next study. Because when they were doing those studies, they also see that gap of data unavailability and data quality. Then when we're now creating this, we now, okay, well, how do we best solve this? Is to try to merge different data sets that are fragmented. Then that's when Harmony came in, because we do know that all these studies now, they use different measures. So what we learned, like from the Harmony perspective, we learned sort of from the open access resource, which is like on the natural language processing or the large language models, but we then actually had to adapt them for our own local context. We specifically using our own local languages. For example, we had about, 12 South African local languages like Chivenda, Tsonga, and so on, to try to make sure that they are also like harmonizable. On your question, John Black, I don't know if Augustine could attend to answer this, or did you hear the question?
Okay, thank you. So in terms of choosing the system architecture, remember that Harmony already built the platform for us. So having them as our collaborators, what they did, they took us through the process on how did they get it, where they got it to. Then from there, we tried to adapt it for the South African local languages. Then what we found is that the models that we used were not performing well for the South African contextual languages. So now what we had to do, we had to fine-tune the models because the models, they use systematic analysis, whereby it digs deeper into the structure of the sentence, where it tries to understand the actual meaning of the sentence, and that is what we were looking for, so that it can be able to allow us to be able to compare two different sentence structures. So I think that's what. I don't know if I did answer your question or you still have a missing part. Thank you.
Yeah, thank you. Thank you. And maybe related to that, I have a question, if there is no question in the audience.
There's actually a question here before you come in, Sylvia.
Okay.
You could have the last one.
Yeah, I know it's related to what he just responded to. So just to say, because you're talking about integrating the South African languages, and I'm just thinking, of course, you have the tools that are measuring different things. But in my experience, even in, I don't know whether the tools you use have specific questions that actually don't align to maybe the ICD-10 or DSM-5, I don't know. But I think the one challenge I remember we had during COVID is some of the conditions didn't even map to the standard. We couldn't find actually variables that we could map to the standard, whether it's ICD-10 or any tools. So we had to come up with our own sort of minimum spec and descriptions and new terminologies, new variables to actually update for the African context. So I wanted you to give some context around that, yeah, for your experience. Thank you.
Okay. Thank you, Sylvia. So I think I understand where you are coming from. I think the tool that you are talking about is the OMOP tool, where it uses different, what you call measuring like CSDA10 and what's or not. So, okay, from my first arrival at Saprin, I had to work with Dr. Linda on the OMOP project, whereby we realized that, okay, there were some contexts that they were not like fitting well into the OMOP. So it needs more of the manual intervention. Like let's say maybe we're trying to match something into the CSD10 and so on. So I think from that experience, that's when we tried to let's say let's go through the harmony, since it's proven to be working well at the US. So I think that's the approach that we took. But maybe going forward, we'll try to now compare the two, like the performance between the two, and try to see if the gap that we are having from OMOP, we can pull some of the LLM models that we used on this platform to close the gaps that we are having under the OMOP. Thank you.
Yeah, and just a quick one to your trust. One of your main objectives was to harmonize data sets and make them accessible. Do you think you've achieved that? How many data sets have you harmonized? By making them accessible, what do you mean? Do you mean they have been cleaned up, made available, downloadable for no-code or low-code analysis? I just want to understand what you mean when you say harmonize data sets and make them accessible, and whether you've actually achieved that.
All right, okay. So the first part of it was on the scoping, which we shared with the Aphrc already, the 19 studies that we found. Then in terms of the accessibility of the data, as a proof of concept, we sort of now harmonized and matched two data sets from Data First and from Saprin. It's not yet open right now as we speak now, but it's there, that people would just log in and request for it, then they'll be granted permission. And also in terms of the open access, like whoever also wants to utilize our services has to log in and just free of charge, just log in, harmonize what you're doing. And also if you want to share your data sets with different audiences, that's the other thing that Augustine would talk about later on. There's an option for researchers from different backgrounds to upload their data, then it has to go under curation internally before it would also be made public. So we are dealing with sort of, because our source also benefited from open access resources, we're also trying to relay it to different stakeholders in mental health space. So you would load your data. If you want it to be publicly available, the terms and conditions are purely yours. We are just a vehicle, a highway, like I mentioned earlier on. Then also just to wait to harmonization is part of what we did. We also have the discover component, which is actually purely like we didn't modify on anyone's work. That was where you would be directed to different studies, and they also have the services that actually summarize those studies, what they are and so on. Yeah.
Yeah. Just one question around how you optimized both the data and the metadata for smoother harmonization. I would like to know how you made sure that the metadata that you got from different sources was interoperable. For example, if you had this metadata coming in different formats or from different frameworks, how did you make sure that you optimize all of that for smoother harmonization?
Okay, thank you for the question. So how we managed to harmonize two different metadatas is that we ran those two different metadatas through the LLM. Then from that analysis, what we are doing, we are picking the keywords. Then from picking those keywords from those different metadatas, then now we write one description about those two data sets. Then there's also an option for one to review if the harmonized metadata, it does speak to what it's saying or not. Then if the metadata, it came to be correct, then it can be approved, then it can pop into the platform. But if it did not match, then it needs to be rejected so that they can be revisited and fixed. I think I did answer your question, or there's a part that's missing. Okay, thank you.
Just to add on the platform, there's a way it would just show you, I think Harmony does that, where it shows you an example of how you should upload your questionnaires when you're harmonizing. So there's a structure that you must follow when you're trying to harmonize. I don't know if it helps answer the question as well. Okay.
Yeah, thank you. That's all from the audience. Yeah, thank you so much. I think maybe one last question. We just have maybe 2 minutes left. So you talked about scalability and sort of expanding. I'll just like to request you to give us an idea of, yeah, what do you think will happen maybe in 1 or 2 years with this platform? Or where do you think it would be? How many data sets can we expect? Oh, yeah.
All right. So I think this is now from the non-technical, the question you're asking. So I think it's not an open secret. I don't know if the correct English, but the funding landscape has changed. We would have hoped actually that maybe since within this 1 year we did what we could, but maybe if they could also additional funding from you guys to continue to make sure that it lives beyond this stage. So, but in the present, like I mentioned earlier on, we have Saprin. The man that actually been paying them, especially for this service, is actually maybe way less than it would have costed them to run the platform itself. So the advantage that we had is like we had Augustine with Saprin, we have Dashin with Saprin in the SMRC. We also, so in that aspect, this is already funded by the government. So what we simply need to do is to continuously sort of have our investment case with the government, because when we did our launch and even mid-project, we already were constantly having conversations with the government that are already funding Saprin. So we just hope that they would adopt it and continue working on it. So for example, there are things that are running in the background that will need a person to continuously be there. For example, when researchers upload their data sets, because all those technologies we dealt with, some are already in research, and the definition of data differs from one researcher to another. So it would need a person in the background as well to still curate the data sets and upload. It can do other things on its own to discover and so on, but there are some things that need manpower in the background. And at the moment, we don't have the resources. We still have to calculate how much would it cost.
When you mentioned MRC, just so that you know, Saprin is also under SMRC, which is mostly funded by the government. So, and they've agreed at least for the next year to hold the platform for us while we still figure out where the funding can come from. And we also have colleagues from MRC who work closely with the National Department of Health. And we had started a conversation on around where we can, if we can get their clinical data from health services on mental health and have it maybe on the platform. Of course, it has to be de-identified for people, but it's a conversation that has started. But unfortunately, there's been a lot of restructuring within the organization. So that conversation there's been a lag in that conversation. But our colleagues who are in SMRC are going to continue pushing that conversation. Maybe within the year or so, we could also end up with the clinical data from mental health services.
Yeah, thank you so much. I think we give the team a very big, I think very important. They are an offspring of the first prize. So, yeah, so it's great to see the progress that you've made, and really exciting to see the work that could come out of it. Thank you. Let's give them a clap.
Maybe you should have just given Linda an opportunity to cough. You can just cough because the questions were going to all of us already. Thank you.
Thank you. So I think we'll take the tea break now for 20 minutes. 20 minutes, yeah. So we should be back here in 20 minutes. Thank you.
Colleagues, I noticed that our 20 minutes tend to be 30 minutes. 1 hour tend to be 1.5 hours. If we could just try and keep it to 20, we can try and move things along better. Which also means that now you should be standing up and having a coffee. Yeah. co-creating, co-designing. Can we co-design our lunch break? We'll go early. We'll make one presentation now, then we'll proceed for lunch, and then we come back slightly earlier than usual, and this time around, hopefully earlier than usual, and then we get going for the afternoon session. So, ladies and gentlemen, we still into the getting to learn what the programs are all about, and coming on the stage right now would be a group from Kenya, the Shamiri team, who will be telling us about enhancing youth mental health, data-driven insights, and digital tools for scalable interventions. So I suspect it's the gentleman and his team. You can tell us who you are and why you're here. Yeah, and then take it on.
Thank you. Sorry, it's still morning. Or good almost noon, everyone. Yeah. I hope you're a bit caffeinated. I'll do some introduction. So my name is Shadrach Lilan. I'm the Chief Technology Officer for Shamiri. And you are?
My name is Rachel, and I'm part of the research team at Shamiri.
Great. We're also joined by 3 other colleagues, 2 over there, can wave. And then there's one who is outside. So, Shamiri. So in this presentation, we'll cover like how our model works, just to get people up to speed if you do not know what we do. And then we'll go into the evidence, the technology, and then also thinking about scaling with government and technology. So, the Shamiri model. Before that, let's take a quick snapshot of the state of mental health. So we have 250 million people, young people aged 10 to 24, struggle with some mental health problem globally. And in Africa, 1 in 4 adolescents experience depression or anxiety, and even less, small amount, percentage, 10% receive that care. And then you can see now, even worse, there's a clear care gap where the provider to population ratio stands at currently at 1 to 1 million. And then the other thing also is, even if you can access the care, it's expensive, given also that we operate in low middle income context, so sometimes this kind of care is out of reach. So even if that's the case, we don't even have scalable and context-specific delivery infrastructure to support this. So at the moment, the mental health care delivery in Africa faces certain structural constraints. So first, it's tried to be built on a workforce that doesn't exist. So as we saw in the previous slide, there's a huge care gap. Secondly, it's also built on treatments that don't translate. And I think there's quite a number of literature which shows that what has worked in high resource Western context doesn't work that well when tried to be implemented here. And then lastly, as I had mentioned, the costs. It can get expensive. So Shamiri is a Swahili word which means to thrive or to flourish. So how can we enable our young people to thrive? So we came up with this model. It's a task-shifted model where we train what we call fellows at the bottom tier. So these are recent high school graduates, people still in uni, age 18 to 24. We give them 10 hours training, and they're supervised weekly. And then at the upper tier, we have their supervisors, and these are mental health professionals, semi-professionals, people who have a BSc in psychology or social work. These people are responsible for training these fellows, monitor the fidelity, and also be the first point of care when you have elevated cases. And then at the very top of the pyramid, you have your clinical experts. So for extreme cases that need that escalation, that's where they live. So we usually go into schools, and then we work there for 4 weeks. We deliver one-hour sessions, 1 hour group-based sessions in schools for 4 weeks. So what was the project here? We wanted to enhance how we deliver this service and make it simple. So how can we leverage data and digital tools to be able to scale this? As you can see from here, there's a lot of manpower involved, and that sometimes can be a challenge. So how can we now then combine the data-driven insights and build some sort of tech platform or leverage technology to be able to enhance service delivery? So here are objectives. We wanted to see one, actually, is from the existing data, how is our effectiveness like? Secondly, for whom does this model work best for? And then 3, can we also now combine all these learnings into some sort of digital platform that can be used to deliver this care? So the methodological approach that we adopted was 1 and 2 fall into the data analysis bucket, where we used existing data sets from RCTs and real-world implementations from 2018 to 2023. And then on the other hand was also concurrently build a platform that can be able to help deliver this care. So I'll have Rachel take us through the evidence bit.
So while looking at the evidence base, the very first thing we wanted especially to look at is the effectiveness of our model in real life context. So we looked at 3 data sets, which were spanning from 2022 to 2023. And what was happening with these data sets is that at least for 2022, we were working with certain community-based organizations. So we had one which was called AMHRTF. Currently, it's called Aphrc. And then in another data set in 4 schools, we were working with another community-based organization called PDO. So that's a psychiatric disability organization. So you find that, for example, while we're working with AMHRTF, we're working in rural settings in Kenya. So the Makueni region, a little bit in Kiambu. And also we have when working with PDO, we're working with them in Nakuru County. So here the real world context is the fact that we are working in different locations in Kenya. So whether we're talking about urban, peri-urban or rural settings, and it's not just us working to deliver the model, we are training these other organizations to sort of like deliver the Shamiri intervention. And so we're trying to ask ourselves, like, typically you would expect along the line when you're scaling either to work with government or other different organizations, can we actually work with these people to deliver our model? So what we're able to see is that effects on like improving adolescents' mental health held when we're working with both the CBOs and even as we're working as Shamiri itself. So even when you try to look at effect sizes, how much are impacting the young people, we're seeing that effect sizes of like from 0.2 to 0.39. This does not matter whether, sort of like there was effect, whether we're working with AMHRTF or PDO, both combined. When it comes to elevated symptoms of depression and anxiety, in both contexts with CBOs, partners, and us, we were able to get 80% of the adolescents from being severely or clinically depressed to having the moderate and mild symptoms, actually minimal and mild symptoms of depression. So we also asked the young people to rate both implementers, us and our partners, and we're always finding that the ratings were given between 89 to 95%. And also, while just looking at going back to this secondary data that we're working with, we were able to actually get old recordings that we used to do during the session delivery. And so we brought in lay providers to sort of like rate those old recordings based on certain protocols. We're looking at 6 different measures and then try and see, you have 2 lay providers rating the same recording, are they agreeing? you're finding that they are agreeing more than 0.95% of the time. And always the ratings, because we're measuring on like 6 metrics, on a 7-point scale, they were always above 5.5. So that is in the aspect of like, fair enough, it works if you give the model to someone else. But what about the context of costs? So here I've just broken them down based on the 3 data sets, because the 3 data sets cut across different tiers. So for example, data set A was the oldest data set, or like the first group that we're working with. So back then in early 2022, at least for us to deliver the program, it was costing $16.87 for every young person, while our partner, what we were able to see, it was costing them $34.41, which is a little bit fair because they were working in a very rural area, which was Makueni, is a little bit farther from Nairobi, where we have our headquarters. And then later on, starting from later 2022 and the very first half of 2023, from what we were able to learn, you see the costs coming down. So we reduced our cost from $16 to $11.22. The organization, the CBO that we're working now, we're able to work with them at $17.37 per student. Again, now here, we're learning, and so even the much later data set C, you're finding again that our cost reduced to 11.12. So it is sort of like a learning process of how we can make the cost of delivering our intervention to be more effective. And so from that particular objective of effectiveness in the real world context, I think, or I believe we were able to answer 4 different aspects of it. The very first thing was good enough. Our model does indeed, it is effective, and we can validate that it is effective when it comes to improving the depression and anxiety symptoms of young kids. It is big enough in the context of like, it does not matter whether the school type, whether it's a boarding school, a day school, a mixed school, a boys' school. So when you look at the demographics of the schools or counties, because we're working at peri-urban, urban, and rural settings, the model still works for us based on the models, the statistics that we did. It is simple enough because community-based organizations were able to implement the model itself, and across the years we've been working for it to be cheap enough. And so that takes me to the second objective that we were trying to look at, individual differences. So you have this particular model, but what works? Who does it work for? Because when you think our model, how itself it is, just to describe it a little bit, it concentrates on like 3 aspects: growth mindset, value affirmation, and virtues. Yes. So we wanted to figure out, for example, does growth affect or help students better than values or than virtues? And so that is what we set out to do. We looked at 3 different data sets from 3 different RCTs. These were our oldest data sets from 2018 to 2021. And this is what we were able to find out. The very first thing is that baseline severity is a key driver to how students improve while going through our intervention. So across all moderators, whether we were looking at the type of schools, the gender of the students, or even just a little bit, we had one common variable on socioeconomics, which I believe was the wealth of the parents. At the end of the day, none of this was affecting how fast or how slow a student improves when they go through our intervention. And the only thing that was really impacting how fast a student improves is their baseline severity. So from the data, the narrative that we got is that when we look at our intervention, it mostly helps the students who are in the mild to moderate category of depression and anxiety. Minimal, we don't really affect them so much, but then that's okay. But that sort of like begs us to ask ourselves, what do we do to the students who are in the severe sort of like category of depression and anxiety? And so through this thought process, this is the narrative that the data is telling us. And so how can we utilize tech to sort of help us target, especially these students in the severe or kind of setting, and also how can we help our partners, especially improve on their cost effectiveness or just deliver the intervention more effectively. And so I'll throw it back to Shadrach.
Thanks, Rachel. So I think for most organizations, whenever they think about scale, the key buzzword is usually tech. You need tech to scale. You need tech it will solve everything. For us, it is helping, but I can't say that it has solved everything just yet. So there are two arms to our technology. There's Shamiri OS and Shamiri AI. And this forms the operational backend and intelligence layer that makes our delivery legible, supervisable, and scalable. So what is this technology? So we have two bits to it. So we have the digital hub, which is the operation backbone that handles the day-to-day logistics. How do you schedule sessions? How do you mark student attendance? How do you even recruit students? etc, etc. All that data that is needed to even do downstream analytics comes from here. And why did we build this? Out there are many data collection tools. You have your Kobo toolboxes, you have your no-code tools, Airtables, etc, etc. But at some point, they start breaking at the seams in very spectacular ways, and especially if the context is a bit new. So we had to go back and actually try and do something about this. And I will show you the ways we started and where we got to. So the Shamiri Provider Platform now is where the supervisors and the clinical experts are also able to now take on and do proper clinical case documentation, handle referrals, etc. And that is embedded within the Shamiri Digital Hub. So where we started, we had this state which I guess most people have seen before. So many fragmented tools, left, right, and center, having difficulties merging data, who owns what, you've run out of row limits, etc, etc. But then now, and this is where also discussions with people with lived experience really came to help. And for us, those are the service providers. What will an ideal tool look like to be able to help you deliver the Shamiri model effectively? So these are some of the things that came up. So sure. So, yeah, I want something where I can be able to just see whatever I need to do for the day. I need to be able to track performance and fidelity of the people that I supervise. I need to be able to see the student journeys, and also for people on the operation side, how do I pay people, etc. Also for the M&E team, we need dashboards to be able to correct costs in real time. So this is where we started, and I guess most people usually start from here. And then we got here, and this was just before the Mhdp grant came in. So even this one, it didn't do particularly well. But the providers need something that should be able to make their work easier, to be able to take away the small headaches, to be able to deal with what's more important, service delivery to the student, not all these other things behind the scenes. And so we got to here after some design iterations and testing in the field. And so you can see even now we have that feature to be able to manage clinical cases. And then even more, we even put in some AI stuff. So how do I know the session went well? Because as a supervisor, I'm not in the group session. It messes up the dynamics, it's just not right. And even it's physically impossible. So we had AI be able to listen in and even developed a code switching transcription model in English, Swahili, and Sheng. It's open sourced, I'll tell you the details later. And for those who are interested, here's a demo, there's a QR code. You can use my official email. Not sure that's secure. but you can use this. So for those who are interested, check it out. Just give a few minutes people to. Great. So once from the evidence, it seems like we need to find a way to sort out precision care for the people with high, severity and different presenting symptoms. How do we match them to care as quickly as possible? There's no need for someone to wait until the third or fourth session to get matched. Yet, if we just get in the baseline score, the system can be able to flag and immediately say like, okay, this one just needs to be seen. So that's where we want to adopt the findings from research and bake it into the mechanism to deliver this care. And that's there. And so we did that. We analyzed the data. We have the data infrastructure in. And then for us, we have this really clear policy. We don't believe AI is in any way ready to be the primary caregiver at all. So instead, we prefer saying that we'd rather have an AI in the loop system as opposed to a human in the loop system. So a good analogy for this is cars. So a human in the loop system is like the Tesla self-driving cars. You don't even give it much input. It just takes you, wherever you go. It doesn't ask you for anything. But AI in the loop, on the other hand, is like, something like cruise control. You're still in control, but the car sort of takes away some things which, are headaches or bothers, So for us, we think that AI is best suited, in its current state, it is best suited to take away the things around which prevent you from delivering effective care. So all the unnecessary paperwork, doing transcriptions, summaries, etc., blah, blah, blah. Because at the end of the day, for mental health, it's that human touch, which is really important. So how we imagine this happening is that once we get that baseline data, these recommendations will get surfaced to the supervisor, and then they'll use their best judgment to see, or the experts, their best judgment to see like how to address this case. We're not going to have the precision care say like, okay, because so-and-so during baseline, this happened, then absolutely, do this particular thing, because you might end up, messing a student's life. So for the infrastructure, thus far, we have served 48,322 students via the Shamiri Digital Hub at 10 implementation sites. And then also we have a NPS score, like Net Promoter Score of 8.36 among the users. And those users are from the bottom tier, the fellows, the supervisors, and the clinical experts. The system is heavily modularized. People only see what's relevant to them. So yeah, as I mentioned, the Shamiri Digital Hub codebase is open sourced. So any organization, feel free to use it. Also the model that does the transcription of English Swahili Sheng is also on Hugging Face. You can see me after this for the links. All the analytical scripts, the data sets, pre-registrations and methodologies, also on OSF, some also on GitHub. And then, yeah, we also open access. At Shamiri, we believe in public goods. So all this money that's coming in and things that you're able to do should be able to enable service delivery by other people as well. And just to go back to the lived experience integration, so of course, for the product and tool development, we want our providers to enjoy using the stuff that we have to be able to do better service delivery. So this also meant like we added more dashboards. How do you think about offline support? How do you think about making things light? Because some of these people use like really, cheap smartphones. So if you want to create something like so heavy, like someone's going to be struggling with reloading or refreshing instead of actually dealing with the student during data entry. And also for the system prompts that we use for some of the AI functionality. Sometimes as a technologist, like you just want to see something work and that's fine. And then you hand it over to, you know, a lived experience partner and then it's like, whoa, you're way off. This is actually harmful. So you have to iterate and co-design that. Similarly, on the research and open science side, co-design and reviewed research findings. Also to try to simplify the technical project documentation to, you know, make those summaries accessible for non-technical audiences, and also just trying to improve clarity on that. And then now for policy, protocol, and strategy, and I think this was really helpful by the workshops that we're doing, developing that safe protocol and initial PLA engagement policy and action plan. I think this was one of the really interesting outcomes from those meetings. And also, yeah, capacity building through the upskilling workshops. So the next steps, after you've done all this, how do you scale and keep things going, you know? So we think the big bet here is it's good to be able to prove that you can hand this over to government and to be able to run it themselves. And the way you do it is, you know, for us, it's really simplifying these models as much as possible, making the technology as self-contained as possible. Even someone just like, you know, once you read the documentation, some trainings, set up the application, it encompasses what the model can do. So the question has shifted. Does it work? Yes, you've seen the evidence. You've seen the shiny tech and all that stuff. But can government run it? So for now, we want to have the government as the doer and also possibly the payer. So instead of Shamiri being the one running the models in schools, you provide the infrastructure for other similar organizations and government to be able to do it. And that's how we try to use leverage technology to be able to do that. Have the Shamiri Digital Hub be the operational clinical backbone, and have the Shamiri AI be the intelligence layer to be able to facilitate the work. So as you can see there, for the AI-enabled stuff, being able to automate fidelity tracking, supervision, that's it. Our next step is precision care, you know, reducing even being able to adjust the ratios of supervisors to fellows, like this, some of the things that technology has enabled us to do. And so, as it stands right now, we're able to deliver our service to a student for around $7. And we think that we can be able to bring that down to $3 to between $3 to $5. And we think also our bet is that's the price point that government can bite. So in 2026, one of the pilots that we've started is with Muranga County to see if they can be able to run this model by themselves. So the good thing is, if you're Kenyan, you know it's one of the more progressive counties and it's easier to trial some of these things with. And then now, we hope by in 2 years, we've more or less explored what the Kenyan student population has or will be. And in fact, maybe at that point, government is the primary doer, not us anymore. Trying to go into East Africa, and then 2031, you know, Shamiri just remains like a small HQ, and we help with research and improvement of the model. So, yeah, I hope this demonstrates how data and digital tools can be combined to address one of the most pressing challenges in youth mental health. And so we needed to identify what works, why it works, for whom it works, and try to build systems around those systems that allow for scale and impact. Yeah, so we had a diverse team. So Tom, of course, Tom Osborne was our PI. Unfortunately, wasn't here. He couldn't be here. He had another engagement where he was the only one who could do what he needed to do. And then myself, the CTO. I also have a project co-lead, Professor Christine Wasanga. I have Rachel here. We have Nixon there. Hey. Faith. And also Wangoi. Yeah. So thank you very much.
Great. Can you try that again? Let's see. This time round harder. Yeah. I think so. Yeah, that's more like it, eh? We are just about to go for lunch, so let's finish all the energy we can, go pack it up again for the afternoon. Anyway, ladies and gentlemen, that is the Shamiri team, Shamiri OS, Shamiri AI. You've had great stuff. I invite questions on behalf of the team. Let's see how many hands. There's one by Bianca. Who else? There's Sam, there's Winnie. I'll take those three for now, and then we'll come for the second round. Bianca.
Thanks so much. It's really exciting work. Thanks for sharing with us.
Do you want to speak a bit louder?
Okay.
And can I advise you to just write the questions down, and then once we have taken the 3 rounds, then you can respond to them. Yeah, there we go. Thank you.
So I'd love to ask you 2 questions, if possible. So the first one is on the data management systems behind this and data privacy and security when you hand over to government and how that works, who has access and what identifiers are in the data. And then the second question is about the precision model for treatment stratification and whether you have sort of evaluation metrics of how well that works or some outcomes data. Have you actually used it to stratify people into care, and has it helped support choosing effective treatments?
Yeah, thanks for this really excellent presentation, and so great to see how you've thought about further steps and sort of integrating into healthcare systems. I was wondering, you talked about the effectiveness mainly for mild to moderate symptoms, which makes a lot of sense, I guess, given your intervention. And I was wondering whether, if you're thinking about severe cases, whether you are considering this as a step care, so kind of passing them on to other service providers, or whether you're working yourself, whether you have some ideas on how you might, be able to provide help for those cases as well.
Yes, I have one question. Nice presentation. So you talked about the cost of delivery going downwards, and I wanted to understand what are the key issues that are driving the cost down, and what lessons can people who are implementing learn in order to bring the costs further down. Thank you.
Right, thanks. Start with Bianca's question. So for data management, security, handling, and access. So because the code and appropriate documentation is open source, what we are trying to say is that government should be able to run those on their own servers, right? So we do not want to own the responsibility of managing their data. And I'm sure also that's how most, Ministry of Health infrastructure does work. You can build systems for them, they're open source, like OpenMRS, etc. They run it on their own servers. So for us, we wanted to make sure that the application itself is so easy, lightweight, and super easy to set up that they can be able to do it, and how they choose to deal with the data, that's on them. Second thing about the precision model, so that's work in progress. That's the follow-up, a key follow-up from the work that Welcome and Mhdp are able to, and Aphrc able to fund. So stay tuned. We'll be able to publish that hopefully in a couple of months' time. Yeah.
So I can take the question on severe cases. So right now, as we have it at Shamiri, is that a lot of times when we are delivering the intervention in schools, you find students approaching the lay providers, who we are calling the fellows in these particular cases. And actually the fellows have sort of like a risk factor protocol when a student approaches them outside of the normal intervention session. And so they have like a checklist in which, as they're talking with a particular student, they go through it. And so what happens is a fellow is able to establish if this is a risk case or if they can actually have the conversation at that point. And also now that's when we talk about referring them to their clinical supervisor. And then how this is sort of like being embedded in our OS is that we have that clinical cases module. So the supervisor is able to write notes about this particular student and how he should be handled, he or she should be handled, whether they'll need a psychiatric evaluation, sort of like further referral, or if the supervisor, who is a trained psychologist, handles the case while they are in the field. So we do have, from the OS itself, we actually do track these students, any clinical cases, and how we are handling them at that particular case.
Sorry, and just to add on to that, like when you imagine a system like this being integrated into government as well, right? So that they can be able to track from the school level up until when they got into maybe mainstream, you know, the main healthcare system. Yeah, so that's one of the things we're thinking about. Yeah. Last one to Sam. There are a couple of variables, I think, with what, how we're able to drive down cost delivery. So I think actually the biggest cost is manpower, right? And so how do you start tuning certain levers to be able to see if you can do more with less people? So for example, let's say at first you had one supervisor could manage like 5 people. If you're thinking about scaling that you know, it becomes a challenge. But if you can tweak those levers while still maintaining the fidelity of the program, so let's say now one supervisor is able to manage 15, 30, 40, and that's where now you can see tech coming in to fill in those gaps. And tech is cheap, it scales, but manpower does not scale. So that's those are the kind of levers that we've been able to pull to get the costs even lower. And we're doing more research, maybe even the number of sessions, etc., that kind of thing. I'm not best placed to answer that, but Faith has more ideas as well.
I think something else that really helps is the devolution of services. So if you can imagine that we're trying to do sessions here in Mombasa, but we're based in Nairobi, that becomes very expensive. If you're printing everything in Nairobi, all your staff is coming from Nairobi, that becomes very expensive very quickly. But if you now devolve it and then you have some hubs that are located in the place where you're trying to implement, it becomes a lot cheaper. But then now it also brings up the question of how can you track that what is happening in the place where you're implementing is happening the way it's supposed to be. And that's where the digital hub again comes in, so that you can make sure that you're keeping track of the fellows and all the things that are happening on the ground, and make sure that everything is running as it should be. So that's really a big cost driver.
Do we have other people interested? We still have Bianca, but just before Bianca comes in, I have just 2 clarification questions, and you can just answer them as they come. Are we talking about 5 counties or 2 counties in your presentation? Because I saw 2 numbers. 5 counties, 2 counties.
So in the very first, well, trying to answer the very first objective on who it works for, like the real world context, we were dealing with 5 counties, those data sets, because we're looking at Nairobi, Kiambu.
So
now,
the title says 5 counties, down there says 2 counties.
Okay, now that's, so for this one, this
okay.
is
I think
the
now
very
it's
first
clear.
objective, so it's 5 counties.
Now it's clear.
And then for the second objective, 2 counties.
Lived experience. Who exactly are these lived experience? Because I heard him explain lived experience. There was a bit about policy making tools easier for policy workers. So it wasn't clear to me whose insights, lived experience insights you're incorporating, and then improving the tools for who. Because then I would imagine if the lived experience are young people with mental health problems, then the insight will improve services to the younger people and perhaps, some downstream effects to other elements. Could you just clarify that? Who really are the lived experience experts?
Right. Hi, everyone.
Hi.
Yeah, my name is Nixon. I was coordinating the lived experience work. So we have, in the Shamiri model, and it's something unique that the Shamiri program allows us to do, we have lived experience across different fronts. So the first one is the lay providers who provide the Shamiri intervention within the schools. So a lot of the feedback that was involved in the development of the Shamiri Digital Hub, we were coordinating them to help us understand how we can improve the features and some of those things that were happening in the development. Then the other front, although now the challenge is we would have really loved to work with the students, but working with minors for us, it's been a bit of a challenge to get approval from the Ministry of Education. And that's why we fragmented the work at the lay provider level. So we've formed a Fellows Alumni Council, which is now the guys who advise us on some of the work that we're developing. And then, and that's something I think we really learned now from this grant. We made sure that we've done a clearer audit of how the advisory council actually works with us, especially in the research and the tech development. And that's now ongoing work that is still carrying on from this grant going forward. So I hope that answers your question to some front.
Maybe not, but yeah, I can have this conversation because it sounds to me like you're talking about experts. But, like steering council, advisory council, but yeah. And just finally, before Bianca comes in, when you say that AI is listening in, analyzing session data to identify high-risk young people for referral, first of all, what is the session data? What's the form and structure of a session data? So that it's bounded in a way so that AI can listen in, analyze it, and then use it for referral. What is the form and structure of that session data?
So for that, when I mentioned that bit, when AI is listening in, that is actually to help the supervisor ensure that the lay provider deliver the intervention following the appropriate fidelity. So the AI does not escalate yet. That's why the precision care comes in, which you want to do. But for where the AI comes in to listen is because you still, as part of trying to dial these levers, you still want the groups, each group should have been able to deliver the same content or with maintaining a certain fidelity across certain dimensions. I don't know if I'm answering your question well, but we can have this
clearly again not, because form and structure, session data is amorphous. So how does it listen into, it's not bounded.
The first thing is the transcript. That's the basis.
Okay, so like the Zoom meeting where you get notes out of it and then use it and then...
The transcripts and also audio features. Okay. So things like tempo, pitch, rhythm, chroma, those kind of cues which, a transcript can't give you.
Okay.
Yeah.
Anyway, I have 1,001 questions, but clearly I can only ask that later. Bianca, please. Anyone else apart from Bianca? We need to know. Okay. We have John Black. Who else? Going once. Okay. Let's get the two questions.
Okay, I was just really interested about the psychological treatment components and your assessment that the intervention appears to be more effective with people who meet clinical thresholds. Can you hear me?
Now we can hear you.
Okay, sorry. So my question's about the psychological treatment components and the finding that the intervention is more effective for people who meet clinical thresholds for depression and anxiety, presumably. So my question is, so the treatment components are growth, mindset, gratitude, and values. But you would expect people with depression and anxiety, clinically significant depression and anxiety, to possibly need additional treatment components. If you sort of read the CBT literature, you would think that there might be things that might need to be added for people with more severe symptoms. I just wondered if the team had thought about other modules that you could potentially add to the treatment plan. Yeah.
I want to ask about the score. There was a score displayed, which I guess is some kind of assessment of the session. Maybe that is to do with the fidelity to the intervention as designed. What's the framework for giving a score? What does a score of 2, which I see there, mean? Is that good? Is that bad? Is it a range of 1 to 1,000? Is that validated? Thanks.
So I'll first answer Bianca's question. So from the data itself, it's just showing us that the people who we are mostly helping, or at least with the highest improvements, is the mild and the moderate levels, right? And then the severe ones, we're realizing that they're not as improving as best as the mild and the moderate levels. So of course now that ties into the conversation of like, we definitely need to work on the severe group of students. And so, yeah, I think this of course stretches to like the care team, who unfortunately none of them is here, who come up with the model itself, and perhaps it's just us relaying the information to them like, hey guys, perhaps we need to target these people other than just tracking them or like identifying them early on through our existing systems on OS.
Just a quick follow-up. So, I mean, in the trial we did of a behavioral activation intervention for adolescents with depression, we found that a lot of young people reported social issues. Well, first of all, we measured suicidality. So there were a lot of suicide risk assessments and referrals. And then there were a lot of reports of child abuse and neglect, which we had mandatory reporting. Even if they weren't specifically asked in the questionnaires, they would be volunteered to the peer counselors. And I'm just wondering how you manage that and whether those are considered risk management or actual treatment components.
So for us, for example, if you noticed, we have PHQ-8 instead of the usual 9, just because we got rid of the suicidality like element from the question, from suggestions from school principals in Kenya about the whole stigma issue. And definitely I feel like perhaps even it's a challenge for us from the research side, we can extend to measuring other different aspects besides what we typically do. And yeah, I think it's a challenge for us to think about. Oh, yeah, sure. Just about this particular feedback that we have a 6-item rubric that we usually use to test for fidelity. I might forget a couple of those items, but one of them would be protocol adherence, clarity, purity of the session, and they're usually rated on a scale of 1 to 7 in this case. So if you're doing humans, you have 2 humans listening into a recorded session, and they give a score between, it's like a Likert scale, strongly agree, strongly disagree, and all of that. So it's on a 7-scale item. And then we look at the agreement between the 2 different. So in this case, it's just that the AI, after being fed the audio recording and looking at the transcription, for this particular fellow, lay provider, under protocol adherence, they're given 2 out of 7. And on average, so they have like a 4.3 out of 7, 6. And so now the supervisor for this particular fellow is seeing all of this feedback, and then they have to incorporate all of this when they have weekly supervision sessions. Yeah.
I just wanted to confirm if this scoring rubric has been validated or it's internally developed by Shamiri, and how reliable it is, and can we use it, for example, in our own project?
Okay, right now it is used internally by Shamiri. Yeah, but of course we can see if we can validate it.
So I'm no expert in AI, but I think listening from AI projects, and we'll come back to Zante shortly. If you get the mic. for you to use the tool, you need to train it. So which best version of a session was used to train so that it can then analyze the transcript and say this one falls on the lower category?
So actually the challenge is the transcript itself. Getting the transcript is where the problem is. So from that we already had so many audio recordings from previous years. So we just had a goldmine, which was now ready to be able to support this work. So we used Whisper from OpenAI, the open source version. And then now we fine-tuned that on around 60, 70 hours of recordings to be able to now to measure the WER and CER to somewhere that it's okay. So that transcript and the extraction of things like pitch and etc. By the way, we diarize the transcript, so it says speaker 0 spoke at this time, da 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 da. We actually feed it to, and we also do PII scrubbing. And then we've
so many acronyms. Yeah. WER, CER, PIR.
Personally, identifiable information. Okay. So we remove that, and then we feed it to Gemini from Google, actually. Reason being, for English code switch text, Gemini performed really well. And I'm assuming, my hypothesis is that the nature of data that Google has and how they've trained that model is able to understand things like Swahili and Sheng. We tried it with ChatGPT. It did well. Claude, completely out the loop. Now, if you go to some of these open source Chinese models, they also didn't understand Swahili at all, so we couldn't use them. However, when we settled upon that, this was towards the end of last year. There have been so many advancements since. So for us to be able to be able to swap out the model that's generating the analysis, not the transcript, we'd have to create benchmarks and evals, of which now that's a project that's currently underway, and we'll hope to, put something out there for it.
Right. Zanthe, please.
Cool. Thank you. So I have two questions. I think the one is, did you validate the PHQ-8 in this population? Because I think what we tend to see is, particularly in adolescents, suicidal ideation drives a lot of what you detect as depression, because in that age group, thoughts of death and self-harm are very common, and they're very common idioms of distress, even if they aren't indicators of suicide. So have you done any work to look at what it captures?
For us, I think for all our data sets from the 2018 one all the way to 2023, even uniquely by themselves, we have validated the PHQ, GAD. Sometimes we even have the short Warwick, and we always find, like, for example, on something like reliability, always get measures. The least we've ever gotten, at least from this data set, was like, when you look uniquely per year, has been like 0.7, but we usually get for at least reliability between 0.7 all the way to 0.82 most of the time. Yeah.
Thank you. And then the second question is actually just to follow up on your point now. So when it comes to using young people's data to train these large models, particularly using open source software, we've had difficulty in the consenting processes, right, for AI-related research with young people. And so I'd be really interested to think about how you described and really ensured informed consent with young people when it comes to sharing, like, clinical transcripts, interactions, even if it's disaggregated data, to ensure that they really understand what that means.
Yeah, and I think when you answer that, again, as a wannabe mixed method researcher, I always struggle with anonymizing transcripts, because there are statements in there that are difficult to expunge or redact, as it were. I think just linking back to what Zanthe is saying, how then do you then use that transcript to train an AI model?
Yeah. So, by the way, when using Gemini, we didn't have to fine-tune it. You just adjust the system prompt. So we're not leaking our data like that for that. Before we even get the recordings and the data, like, we go through a lot of approval processes and etc. And also within the session, we do get obtained written consent from the students to let them know that now this one is is going to feed into an AI model. Now, my bet on how to mitigate this, and even just a long-term view, is as these models get smarter, some of them get open sourced, and as we get better at understanding how to tweak them, then you can just keep it within your own ecosystem. You don't have to leak anything out to. So if you're fine-tuning your own model stored in your own servers, not going to ChatGPT servers or whatnot. Yeah. But if that's a problem, I know, and this now becomes really expensive, is you can go and find, they're called business something, BAA agreements with, and that's a whole other mess. Yeah. But the better we are at trying to run these things locally and cheaply, which it will get there, then I think that problem sort of takes care of itself.
Ladies and gentlemen, there's a question online. If you can hear me, please go ahead. Philip, can you hear me?
Yes.
Go ahead.
Can you hear me too?
Yes, we
I can hear you.
Go ahead.
Great. So, yeah, you mentioned that you upload, like I know that especially for Google and Gemini, they are very good with translation. Are there any concerns with like ethical concerns with uploading the data to the cloud services?
So that's why.
Thank you.
Oh, sorry. Yes, let me respond to that. Yes, there are ethical concerns. That's why if we didn't pay attention to that, we'll just upload everything to either of these providers either way. So we try to make as many steps as possible. So for example, the transcription, that happens on our servers. Like there's no leakage outside to any third-party service. Now, even before it gets to Gemini, we take a lot of steps and measures to actually try and scrub as much information as possible so that, even if, let's say you come and see that transcript, you wouldn't know what they're talking about. Or rather, you wouldn't know the people they're identifying or the schools or the places that they're in. So it's I think for now, that's the best effort we can get. But we're doing work behind the scenes to actually, that's why I'm saying making those evaluations important so that you can be able to swap out and confidently say the way Gemini performed, the way a human will perform is the same way like something I've hosted on my own machine will perform. And I think, stay tuned for that. I think in a couple of months we'll have something on that note which should hopefully help other organizations facing similar challenges.
Is not specifically your question, so I want to release you guys, but with a caveat. There's a lot of stay tuned that has come from this team. Stay tuned for this, stay tuned for that. You need to set up your antennas very high and wait in the coming days because there's clearly a lot of cooking being done. You're cooking, so we are here waiting as you cook. So great, thank you very much, ladies and gentlemen. And make sure to interact with the team when they do the demos and ask further questions and just understand how the Shamiri OS, Shamiri AI works and the great work that the Shamiri team is doing. So thank you so much. John Black has a general question and he promised that that's going to go to welcome APHRC and other experts in the room. So you have the mic, John Black.
Yes, thanks for the opportunity. It follows from the discussion we just had. This is about infrastructure. In many of the projects, people have needed to use high-performance computing. This project is about data science. We have struggled to, procure GPUs, set them up in this place, and now there's a discussion of sending data to the cloud, which has its own issues, BAAs, and all the acronyms he's been discussing. And so the question that then goes to APHRC and welcome is there any thought of setting up shared computing infrastructure so that projects can use them in a way that it is reliable, trustworthy? We don't have to struggle with, negotiating with Google, OpenAI, whatever. And also, I think that will be more efficient because, yes, during the training, we might need high-performing computing, and then we procure it, but then later it sits down because we don't need to do that much computation. So, this is to, I guess, to you, Ekin.
I think I'll pick Sylvia is a PI on the project. I'll try and protect Ekin for now and see if she wants to answer seeing as she's a funder in the room, we'll come back to her. I also share similar sentiments, akin. But let's start with the PI.
Yeah, thanks for that question. I think even in my opening remarks, I mentioned that the biggest challenge we have with whether it's using natural language processing, large language models, setting up infrastructure is a big challenge. And even we at Aphrc, whereby you need to partner in many ways with the providers, with private sector, to be able to get infrastructure going. But I think it's possible to have this conversation at a deeper, maybe level, to just see how we can work with the different teams to share infrastructure. But yes, it's a big challenge. Yeah.
I actually wanted to add that I think with some kind of concessions and agreements, bigger partners like Aphrc could perhaps offer facilities that they have that are being underutilized, like a whole server sitting there, perhaps only being used 30% of the time. But there could be also issues around data transfer, data sharing. Again, I'm no expert, but then you have to manage and do all that. Akin, let me not delay your point.
Okay, after your protection, thank you. I think, like from a founder's perspective, the main question is that what happens to this infrastructure in the long run? Like, you cannot fund something for 3-5 years and then say, okay, we are out of it. So there are instances of welcome funding infrastructures. For example, we do fund DHIS2, but I think there has to be a very good and specific reason and a good rationale why we are funding it. And this is my opinion, not, welcome opinion, but I think it would also be important to see partnerships in terms of, are there any kind of governmental partnerships, any funding from the governments or ministries going into it, and can welcome be a smaller part of it rather than this is something that we are funding as a solo funder, like for X amount of years. And if you do have any kind of ideas about how the longer term sustainability of such infrastructure can look like, I'm really curious and I'm really happy to hear about that, basically.
Great. And I think it's the conversation we were also having about opportunities in this room, right? It's not just about data, but it could also be about infrastructure, about technical capacity, about skills. There's just so much in this room, right? So that perhaps we can leverage, synergize, and see how we can take it forward, right? And I know I'm not speaking for Aphrc, but I know as an institution, the whole issue about capacity strengthening, about supporting individuals and institutions, not just on technical aspect, but also even on governance issues and everything else, is still the mainstay of the institution. So now research is just a small component. We have other ongoing aspects, including support on governance, support on training, support on all those elements that are either offered when requested, sometimes donated, and sometimes charged depending on the scenario. So I think it's beyond maybe the data prize, but the data prize offers an opportunity for this conversation to go on. You wanted to say something?
No, I'm putting it to Africa CDC because I know they have also a cloud infrastructure, but I'm not very sure how that works and how different countries can access it. So perhaps that's also something to discuss with Africa CDC. Yeah.
Do you want to say something, Dr. Odede? We don't want to put you on the spot, though. If you need to consult and come back to us, yeah.
You're on point. I need to consult.
Okay. Yeah. Now, I've worked a few times with Africa CDC, and I know their positions are based on consultation first before release. So we don't want to put you on the spot. Yeah, but again, if there's something like that, it's something to tune out for, right? It's exactly 1:45. I want to give us suggestions that we do lunch for 45 minutes so that we are back here at 1:30. 1:30, ladies and gentlemen. Can you repeat 1:30? Yeah. Which also means that now you just need to stand up and head over to the restaurant and have your lunch so that you don't have to wait and be at the back of the queue. We meet here at 1:30. We get started with the afternoon session so that we can finish on time and have the interaction session in the evening. Enjoy your lunch and see you here at 1:30. Yours truly will be standing here ready to get started. Thank you. Thank you so much and enjoy your lunch.
I'm very proud to present on behalf of the team from the Western Cape in South Africa. And I'm presenting on our project, Transforming Mental Health Service Delivery in the Western Cape, the integration of digital tools to improve care for common and severe mental health conditions. To give you a little bit of background into the problem that's currently being faced in the mental health context, there is significant prevalence of mental health disorders, with mental health conditions affecting 1 in 3 adults in South Africa, with high rates of prevalence for common mental disorders like anxiety and depression of greater than 10%, and prevalence rates of around 1 to 4% for more severe conditions such as schizophrenia and bipolar disorder. Mental health conditions are also risk factors for increased poor outcomes and mortality rates for both non-communicable and communicable diseases. And there's a significant disparity when it comes to service delivery for mental health services, with around 92% of the budget for public healthcare services allocated to inpatient hospital care. That leaves only around 8% for primary care in the public healthcare sector. And previous research also indicates quite a significant treatment gap when it comes to mental health disorders of greater than 95% for common disorders. And with this large treatment gap, the disparity in services tends to result in high relapse rates, which in turn then results in increased healthcare costs with this revolving door mechanism of patients needing to be revisited and readmitted within the healthcare system. South Africa also created the South African Mental Health Strategic Plan, which is essentially a policy framework to try and address the disparities in mental health care provision within the country. And the main idea within this framework is to try and shift resource allocation towards more integrated primary care service delivery and community-based services to then downscale the reliance on specialized in-facility healthcare provision. Our project that we've completed here under the Mental Health Data Prize aligns quite strongly with this framework in the sense that it enhances surveillance of and monitoring of the pressures on public mental health services in order to facilitate more strategic allocation of resources in the sector. And in addition, our second tool also helps to align by improving retention in care at a primary healthcare level in order to try and prevent an escalation in the need for further care at in-facility. So our project had two main aims, which was to develop these two data tools, the first being a mental health dashboard, giving characteristics for the mental health cohort within the province of the Western Cape. And the second tool is a continuity of care tool, which is essentially trying to pick up on patients that have fallen out of care and to try and enable service providers to re-engage those patients before they present with more severe outcomes. In terms of the objectives within the project, the project overall is aiming to enhance mental health service utilization by improving monitoring and surveillance measures for the province. Ultimately, we're aiming to provide a data-driven approach to allocating resources and structuring policy within the province. The idea is also to promote open science principles by publishing under open source platforms and providing awareness around what data is available within the Provincial Health Data Centre and better informing researchers to be able to then access that data should they require it for any research. And then lastly, we are also aiming to sort of prevent loss to follow-up by making sure patients that fall out of care can stay within the care continuum and prevent an escalation to more specialized service needs. To give you a little bit of contextual understanding around how these tools come about and the environment in which they sit, I'm just going to walk you through the Provincial Health Data Centre, which houses both the tools and the data that powers them. Then the single patient viewer, which is ultimately the web-based platform through which the tools can be accessed. And then I'll describe the mental health episode, which is how we identify which patients should be included in the cohort. And lastly, the tools that we've developed for this project. So to begin, I'll describe the Provincial Health Data Centre within the Western Cape. Ultimately, the data centre acts as a health information exchange, which collects data from all of the source systems across the province, ranging from labs data through pharmacy dispensations, attendance to in-facility hospitals, small amounts of data coming from primary healthcare where that data has now started being digitally captured. And then it also extends to diagnosis coding and labs from the National Laboratory Services. We then can link all that data to our internal data architecture with a unique patient identifier for each patient. And then ultimately we can then aggregate across that data to create tools at both an aggregate and individual level in order to enhance service provision. Largely, the data center is prioritizing service provision over research, but ultimately the data is available through an established research protocol, which requires ethics approvals and study protocols to be in place, but the data is ultimately available for research purposes as well. Next is the single patient viewer, which is a web-based platform that houses all of the data and data tools and acts as a unified access platform across the province for people both within the service sector, but as well as policymakers and stakeholders for the province at large. Reporting provides either a patient-level reporting on a patient's medical history for in-facility use, and in addition, there's aggregate monitoring to different population-specific groups that may be of interest for either research or service provision purposes. This platform is secure, account-controlled, and password protected, and there is granular permissions provided at either a report level or also additionally facility levels within those reports as well. Next, in order to provide an understanding of the data for the cohort, we first need to be able to establish which patients should be included within that cohort. And ultimately, because the data we have on hand is routinely collected data and not bespoke data for research purposes, we have to try and make inferences about the types of conditions people have by using the different types of routinely collected data to act as evidences, which we can use to then infer the conditions. And certain evidences will be able to provide a higher level of confidence in the presence of that condition. So when it comes to the mental health episode, which is what we call the inference engine for that condition, we are mainly reliant on either admissions, either to a specialist psychiatric facility or to some sort of psychiatric ward at a district facility. There's also ICD-10 coding that we can rely on, and then pharmacy data, and those all form sort of a higher level confidence version of evidence. Then at lower levels, we also have the psychiatric RMR, which is essentially a routine medical record for head count, which just marks what services a patient sought out at a primary healthcare facility. And then lastly, as just supporting evidence that the admission method indicated some sort of psychiatry, though this is often changed after we've established what the diagnosis for that patient might be. And so that's why it's left as only supporting evidence. And so now that we've established who should be included within the cohort, we can then begin to develop the tools that describe that cohort and its service pressures and needs. So this is where we started to develop the tools for this project. And the development of the tools followed the Center for Health Research's roadmap for e-health development, which is essentially a 5-step approach. The first being a contextual inquiry, which establishes what the environment is, what data is available, what tools are available, and what the needs for the environment are. The next is a value specification phase, which establishes what exactly would we like these tools to do? What are the values that we're aiming to achieve using these tools? The next step is to actually design prototypes for the tools, and that's followed by some sort of dissemination plan so that the tools can actually be put into practice. And lastly, there's this iterative process of evaluating the tools and then going back and refining them so that they can better adapt and adjust to the environment in which they serve. The team responsible for moving between each of these steps is a steering committee, and within the steering committee, we try to make this as multidisciplinary as possible, and so this includes our lived experience experts, frontline clinicians that actually work with the mental health patients, policymakers within the province, then also district and facility managers, data scientists, and lastly, public health specialists that specialize in the data that we're using. And so this group will then provide approval for prototypes and movement between each of the development stages, and they also establish what the values for the tools should be. Now that I've provided a little bit of context around where these tools are situated and how they can come about, I'll start by giving you a little bit of a demonstration of the tools themselves and sort of describe how they came to be. I'll start with the first tool being the mental health dashboard. And so underpinning the front end of the dashboard is our back end, which involves a daily updated data set that links the different patient data for the cohort between our different SQL relational databases at the PHDC. This is then kept at a patient level with a set including over 500,000 patients at this point in time. And this daily updated data set is then connected to a Microsoft Power BI dashboard through a de-identified version of the data set that is then also linked securely. And the Microsoft Power BI front end is then able to aggregate the data set by different population groups or different domain-specific areas, as well as geographical areas and time trends as well. And so just to give you a little bit of a demonstration as to what the dashboard looks like, I'm not going to go into too much detail describing it, but just because you guys will be able to see it at the demonstration in the sort of next phase. But just so you can see what the dashboard is looking like, I'll walk through firstly a provincial summary for an overview of the whole cohort in the province, then looking at those evidences I described for the episode, and then moving through the different types of evidence like the diagnoses, the dispensation groups, and then lastly some service utilization for those groups. So upon opening the dashboard, you land on this front page, which you can then use to either move on to the tool itself, or you can receive some information as to what the dashboard does, how to use it using the documentation button, and a little bit of a description as to how to interpret the data therein. Lastly, there's also a button to provide feedback for the tool. There are two different feedback mechanisms, one relating to requests for changes to the dashboard itself, and a second relating to requests around feedback on the underlying data, if you believe that there's potentially an issue with the data that's being displayed. And then that way, there's no confusion sort of switching between suggestions for improvements versus an actual problem within the existing tool. And upon clicking on that View Dashboard tool, you're then taken to the navigation page, which highlights the 5 main areas within the dashboard. And so that's the provincial summary, and then the different evidences, the diagnoses, the different dispensation groups, and then lastly some service utilization. And I'll be moving through each of these sections in succession. So looking at the provincial summary, this is kind of what the page looks like. It gives you a general overview of the cohort, described by all of the evidences included. And so there you can also get an idea of roughly what proportion of the cohort has high confidence episodes, where we can be fairly confident that there is an inferred mental health condition present. We're also able to visualize where across the province these individuals sit, broken down by the different districts within the province. And you can also get an idea of what the population pyramid for this group looks like. And the power of the Microsoft Power BI front end is that you can use these visuals to then filter the other visuals present on the page. And then with a little bit of a deeper look into those evidences I described earlier, you can now see roughly what proportion of evidences are attributed to the different patients. And you can get an understanding of the kind of subsets of the combination of evidences present. And so you can see, for example, in the upset plot at the bottom, that there tend to be more people with both a diagnosis and some sort of mental health drug issued than either of the other two evidences. And then you can also get an idea of, by the first evidence date, roughly how often we're seeing new individuals coming into the cohort. Next, we'll look at the different diagnosis groups. So these are the different psychiatric diagnosis groups that we have at the moment. And so we start with a little bit of a provincial summary, looking at a general overview for all the individuals who've received some sort of psychiatric diagnosis. Then we move on to psychiatric comorbidities, looking at the associations between groups who've received more than one of these psychiatric diagnoses, and then there's highlight pages for each of the groups themselves. And so I'll just take you through the provincial summary and the psychiatric comorbidity pages, and then show you one of the highlight pages, as the rest of them will essentially look the same as that page, but just be filtered to the specific group. So we'll start by looking at just the general provincial overview. And so here you can get an understanding of roughly how many individuals in the cohort have received some sort of mental health diagnosis. You can also see what that population looks like using the population pyramid. And again, you can use that pyramid to then filter the other visuals according to either gender or the different age categories as well. You can see roughly what proportion of these diagnoses fall between the different psychiatric diagnosis groups, and you can also see roughly where these individuals are situated across the province by the district. Next, looking at the psychiatric comorbidities, you can also see a bit of an upset plot looking at either the number of individuals who've received the different type of psychiatric diagnoses. Here I've limited to the 4 most prevalent groups, and then thereafter you can see combinations of the different psychiatric diagnoses, where I've grouped the rest of the groups under this other category. But then if you were interested in looking at more detail for the group, you can just look at it in the table below to get a better understanding of roughly how many individuals have those smaller counts of diagnoses. Then looking at a specific highlight page, again, you can see roughly where across the province these individuals are found. And then this is as a proportion across the 100,000 population estimate for each of the districts in the province. You can see what proportion have some sort of psychiatric comorbid diagnosis, and you can see roughly what group that comorbid diagnosis falls within. And then you also get an idea of the population pyramid and proportion between the different sexes are available as well. And just to give you an example of what it looks like to filter any of the pages on the dashboard, here this is what it looks like if you, for example, click on the Southern District within the Cape Town metropolis. Then it filters all of the other visuals so that you can see what the proportions are in just that sub-district as well. Next, we'll move on to the psychiatric dispensations. Again, we follow the same pattern of looking at a provincial summary, then co-prescription as a form of sort of comorbidity, and then the different dispensation groups. And so here we've, again, just kind of focused on the main groups because the other groups tended to get a little bit too small, and then they become fears of re-identification risks. And so we've tried to limit it to just groups that have a sufficient count of individuals who've been dispensed that type of medication. So to look at the overview, you can again see roughly how many individuals have received some sort of psychiatric dispensation. You can see the counts across the different dispensation groups. And then you can also see how many of these individuals have received one of these dispensations within the last 12 months within the chronic dispensation unit for the province, which handles all of the regular dispensations of medication outside of a hospital setting. Again, we have the population pyramid that can also then be used to filter everything else. We have another look of an upset plot looking at co-prescription counts for the different psychiatric prescription groups. And then this can also be filtered by either sex or age group. And we have the actual counts in the table below if you're looking for a little bit more detail. Focusing in on one of the highlight pages, again, we have the sort of geographic breakdown of roughly where these dispensations are taking place. We can see the proportion of the individuals within this subgroup that have received some sort of diagnosis, what that diagnosis is. And then again, broken down by sex, and also an indication of the proportion of those who've received the medication within the last 12 months as well. Each of the specific dispensation groups also has a second highlight page, and so this also focuses in on the co-prescription, as well as a look at the first dispensation date associated with the highest associated diagnosis group. And so here we, for antidepressants, for example, we can see that the diagnosis group that was highly correlated with antidepressants was those with mood disorder diagnosis. And so here we can see roughly how many of those individuals received an antidepressant dispensation by year. Lastly is the service utilization section, and this is essentially going to break down how many points of service utilization by the different types of service utilization is taking place for just the mental health cohort. And so this is everyone who's got some sort of indication that they've got a mental health condition present, and then looking at how they're engaging with public healthcare services across the province. So to start out, I'll just look at the provincial overview. which looks at either counts by the different types of visits. So that's broken down by either community health work, hospital admissions, hospital outpatient visits, in primary healthcare visits, or some sort of self-enrollment where they're sort of enrolling into the digitized platform for the PHDC. And then that's broken down either by individuals or by the total number of encounters that take place each year. That is then filtered using this active service users page. And so this is where we filter to individuals who've had any kind of public healthcare interaction within the last 12 months. And then we consider those users to be people who are actively engaged within the public healthcare sector. And once we've filtered by this group, we can then see roughly which type of diagnoses these individuals have, the rough number of encounters we're seeing them have across the year, and then what proportion of those individuals are actually considered to be actively engaging with public healthcare services. Looking at one of the highlight pages for the specific types of encounters, so here I've focused in on primary healthcare encounters. You can see roughly what proportion of those encounters are either visits or visits for the dispensation of some type of medication. We can get an idea of the rough count of these encounters that are taking place over time. And then we can see which of the districts across the province are facing higher levels of encounters by number of individuals who have some sort of mental health condition in that area. There's also a second page for each of the encounter type highlights. Here we're looking at specifically for primary healthcare encounters, roughly what proportion of the group is having how many encounters per year. And so, for example, we can see here that around 20% of the cohort is having at least 2 encounters over the course of the last year. This is then also broken down by each of the different encounter types, either a visit or a dispensation or a lab test, for example. And then for each of those different types of visits, we can also get an account of the number of individuals who've had those types of encounters across the year. So the second tool that we've developed for this project is a continuity of care tool, which is largely unrelated to the mental health dashboard. Here, the target users of the tool is also quite different. So where the mental health dashboard was quite largely aggregated and anonymized, this tool, in contrast, is individuated and has identifiable information. And so the users of this tool are strictly limited to those who have been provided access as service providers for that individual. And so a person would need to be providing mental health services at the facility which that individual receives care in order to receive the details for that patient that's fallen out of care. And so how this tool works is it's got a backend which runs using a combination of different SQL stored procedures that interface with the different relational databases within the Provincial Health Data Center. And those stored procedures ultimately put together a table of all of the identifiers, the diagnoses, treatment details, and follow-up information for the individuals in the group. This is then connected to a Power BI paginated report, which essentially just visualizes the data as some form of a table that can then be exported and sent to the different users. And this tool is again firewalled and password protected through the use of SPV. And ultimately, the identifiers are only visible to those who have permissions in order to see them. So in order to start establishing who should be included in the tool, we need to define who the monitored population is. And the core principle is that once a person meets the criteria for being within the monitored population, then they are considered to require continuous or chronic care, and that they should not be falling out of care, or there shouldn't be a point at which they're no longer receiving some sort of treatment. And so at the moment, our inclusion logic is to limit the group to those who have severe mental disorders, and that's reliant on either ICD-10 coding or the provision of some sort of medication that indicates that they have a severe mental disorder that requires continuous chronic care. And then once a patient meets at least one of these criteria, they are then added to a group of monitored individuals. And once we've established who should be receiving continuous care, we then define what the disengagement measures are. And so our working definition is that if a patient would be considered disengaged if there's no evidence of any healthcare provision received within a defined period. And so for individuals who have been receiving medication on a month-to-month basis, the initial threshold that we're suggesting is 60 days. So if a patient hasn't received medication for at least 60 days, then they get added to the group of disengaged individuals that would be included in the tool when a clinician tries to pull it together. And so for individuals who have longer acting forms of care, so if they're having long acting injectables and they should only be receiving those every, say, 4 months, then this disengagement window can then be adjusted. We also rely on an automated re-engagement rule. And so if a patient is within the disengaged group, if they have any kind of evidence that they've re-engaged with care, either they've received medication or they've gone into some sort of facility to have a visit, then they will automatically be removed from the disengaged group. And so this is what the prototype looks like at the moment. It's a little bit less flashy than the dashboard is. But essentially, it's a table that includes all of the details that the user has filtered to, so which facilities they've included, the date range, the age range, the ICD-10 codes that they've maybe limited to, or specific individuals. And then this will include all the details from patient identifiers through details about what condition they have or when last they'd received medication, what medication they have been taking and at what doses. And then lastly, we also have information around follow-up attempts that have taken place to re-engage this patient. One of the benefits of using SPV is we are also able to make follow-up attempts through the platform. And so just by clicking on the patient's folder number in this table, you're able to go to their profile and then either make calls or send SMSs to try and re-engage the patient. This will automatically update this table with the date that the last follow-up attempt was made, the status of that follow-up attempt, whether it was successful or not, and the means of follow-up that was attempted. And ultimately, then these demographic details can also be shared with community health workers, and they can try and engage the patients in person if necessary. Some of the major strengths of our project are our association our association with and the fact that we've been embedded within the Provincial Department of Health. And this means that we're able to disseminate our tools province-wide quite easily, as there are established mechanisms for service users to access the tools quite easily. The PHDC also has email alerts or news flashes that take place regularly for new tools. And we can use this to inform our existing user base of the tool's availability and any updates of those tools that take place moving forward. When it comes to sharing research outputs, we're also able to then share through our partnered academic institutions for this project. Ultimately, the Provincial Health Data Centre has quite a regular presence at provincial health surveillance meetings. And there's quite a strong foundation of trust in our tools and our platform at large. And so following any rigorous procedures that we have in place before the release of tools, we know that clinicians can be confident in the data that we put out. And so by and large, there's a lot of trust established in the use of our tools once they're available. We also have relationships established with clinics across the province, and so that makes it easy for us to reach out to partnered facilities that we can pilot tools at before rolling out province-wide. Also associated with our project are some research outputs, the first of which being a cohort characterization study, which is foundationalized around the dashboard component of the project. There's a project protocol completed and the draft manuscript in progress, where we have a preprint planned to be ready for next month. And this largely just focuses on identification of the mental health cohort and the characteristics of that cohort at large, and then this changes and time trends in their service utilization over time. And so here's an example of one of our current results, which looks at the increased rate of service utilization over time. When it comes to interpreting these results, there is some slight complication in that there is an ever-present rollout of new electronic capture systems taking place, and so it's difficult to really know whether it's an improvement in people having better uptake of services or whether we're actually just capturing things a little bit better. But for certain things like hospital admissions, those capture systems have been in place for quite a long time, and so there we can interpret the trends a little bit more easily, but at a primary healthcare level it becomes quite difficult. Our other research project is a study on the retention in care tool, and so this is focused on trying to identify patterns of disengagement and which individuals within that group are tending to have larger rates of disengagement. And ultimately, there's hopes that we'll be able to have future studies looking at the beneficial effects of this tool being put out there and whether or not that results in better retention rates over time. When it comes to open science components of the project, we have created our accounts on OSF and GitHub, and the project concepts and details have been outlined on these, along with the associated and accompanying metadata for the project. And ultimately, there's hopes to have a public-facing component of our tool, the dashboard, which does sort of rely on being able to validate our episode, to provide sensitivity and specificity details around who's included in the tool. But once that is in place, we'll have a public-facing component that will improve visibility for the data to the general public and to NGOs. When it comes to publications, we've also committed to publishing in open access journals with preprints on OSF preprints and medRxiv, followed by any peer-reviewed articles. And we'll publish under a Commons CC BY license as well. When it comes to engaging with lived experience members on the project, there were some significant impacts when it came to a direct impact on the outcomes. And that was that there was a strengthening of the relevance of outputs for the project, in that we could make sure that any outputs we found, we could see whether or not those truly reflected what was happening on the ground, and whether lived experience members were able to sort of corroborate what we're seeing within the data. Additionally, they're able to provide some sort of input on the interpretation and language of what the data is making visible, and to make sure that we're using more inclusive language and things that aren't going to be ostracizing at all. And ultimately, this supports a informed and responsible patient-centered use of the data, making sure that we keep in mind that the focus of the data is ultimately to improve the provision of services for the patients that we serve. The other area of impact that will be lasting when it comes to engaging with lived experience members is that this has ultimately changed the approach that we have to developing new tools. It's allowed us to establish some sort of relationship with representatives of lived experience groups, and that makes it a lot easier to approach them and engage with them when it comes to developing new tools in future. And hopefully this makes it more of a common practice to use not only within the mental health space, but when it comes to the development of data tools at large. When we want to focus on who really benefits from these tools and what the impact of the tools will be, there's quite a wide range of individuals that will receive benefit from the tools, and so this comes across for health system planners and policymakers in the sense that they now have better visibility when it comes to monitoring and surveillance measures for the cohort across the province. And this can then help them establish changes in policy and resource allocation over time. Other beneficiaries are the facility managers and clinicians that now have better visibility of the service pressures they're facing, the types of conditions people are sort of arriving with and requiring care for, and they're better able to compare the way their facilities are engaging with patients compared to other facilities at their same level as well. Mental health researchers also benefit quite largely from this study, as it's now made a very comprehensive and complex data set that captures really rich details for the mental health cohort in the province that previously never existed. And so this will be the first publication on this very rich data set that then makes visibility of the cohort a lot more detailed. And with this data set in place, other researchers are now able to then have a better insight into what information they can request from the data center as well. Ultimately, the people who benefit most are the patients, as when it comes to the continuity of care tool, we're now hoping to retain patients in care so that their conditions don't escalate to the point of needing higher levels of service provision. And ultimately, we're better managing the conditions that they have. And should the tools be used for better resource allocations, that also ultimately benefits the patients as well, as the facilities run a little bit better and they can provide services in a little bit more streamlined way. When it comes to the challenges that we're currently facing, one of the biggest ones is the need for a gold standard data set. Ultimately, we need to be able to assess the sensitivity and specificity of our inference engine and the way we're picking up on mental health patients. And so the lack of having a gold standard data set to compare against means that we're then also limited to who we can show this data to, as we want to maintain that established trust in our information. And so we don't want to be putting out information that we can't say has been validated and has some sort of associated sensitivity and specificity measure. Another one of the challenges that we're facing is that we would like to provide data measures that are at a population level. We want population level statistics, but firstly, we're limited to those who are accessing public healthcare services, as it's quite separated from those who access private healthcare services. And then within that subset of individuals, we're also limited to those who actually come and seek care, because we're using routinely collected healthcare data, and as opposed to some sort of survey data. And so that means that we're needing to extrapolate on the data that we have to try and create some sort of population level statistics, but ultimately there are going to be some detriments that come through that process. Beyond the project, there are a lot of ideas when it comes to further developing both of the tools. So starting with the mental health dashboard, these are tools that really require continuous adjustment, maintenance, and evaluation. As the landscape changes over time, we need to better adjust to either the needs that we're aiming to try and provide surveillance around, and also over time there's better capture of data available. And as that takes place, we need to be able to incorporate this new data so that it's more representative of what we're actually trying to describe. Ultimately, what I described on the previous slide as well is we're in the process of collecting some data from some partnered facilities so that we can have some sense of validation for our inference engine. It's not going to be the same as having a gold standard data set, but it's at least a step in the right direction. And through this, we're then able to provide some sort of sensitivity and specificity measures, and then we can have a little bit more faith and trust in the tools that we've created. Another important next step is to shift when it comes to the different diagnostic groups. We're in the process of shifting away from reliance on either diagnoses or or medication dispensations. And so in the same way we've got this episode that makes inferences about the presence of a mental health condition, we want to have individual episodes for the inference of different, of those psychiatric diagnostic groups. So we'll have an episode for depression, for bipolar disorders, for schizophrenia, and break them down individually so that we're not reliant on just one type of evidence, and we can get a little bit more of a comprehensive view when it comes to estimating the presence of these conditions. And then lastly, upon receiving some sort of validation measures, we can then start looking at creating public-facing elements, which really benefits the public at large when it comes to visibility of mental health awareness and service pressures. And this also sort of empowers NGOs to be able to better advocate for funding as well. In terms of the continuity of care tool, some really important considerations is at the minute we are really largely focused on chronic mental health care patients, but there isn't necessarily a need for this to be the case moving forward. We can try to adjust the tool to include conditions outside of just the mental health cohort, and we can also start looking at ways to use this tool for acute patients as well. So if a patient's, for example, discharged from a facility and we are intending for them to have some sort of follow-up at primary health care, they could be added to the list of a monitored population, and then if they miss their follow-up, they could then require some re-engagement. At the moment, we have limited the scope just to a group that's a little bit easier to identify, but there is definitely room for this tool to be expanded on further. Thank you very much, and I'm happy to take some questions on our project.
Great. We only have a slot for 2 questions, so first come, first served. Bianca and Linda. Good. Let's get the mic. One online. Okay.
I'm going to squeeze 2 questions into one. So I was thinking about what it would take to scale this up to another province, and what components in terms of the setup, human resources, technical skills, data management systems, etc. And if you'd thought about costing the setup and maintenance cost of implementing a system like this. I'm just thinking of, are there packages or pieces, components that could be implemented beyond the Western Cape, like potentially through the district health information system or otherwise? And then second question is, have you had interest from clinicians or pharmaceutical companies in doing platform trials? It seems like you've created a platform that would be very valuable to a lot of people who wanted to iteratively and adaptively study the effects of different treatments.
Thank you. There's a question online. Linda has seeded his question because it's been covered by Bianca. If you can hear me online, please unmute and speak out. Dan. Dan, can you hear me?
Yes, I can hear you. Thank you so much. This was a very good presentation, and you put in a lot of time and effort to put this together. I had a question that was lingering in my mind as it was presenting. It's a good tool, and I wondered why they don't open it up to all patients, and why they selectively pick a few patients, a few diagnoses, and what do they do for the rest of the diagnosis? Yet, the way as described the tool, I thought it would benefit everyone.
Just to clarify on Dan's question, was that for the second tool or for the dashboard?
For the tool where you had to select a few diagnoses to enter into your cohort.
So I'm assuming that was maybe for the continuity of care tool? So yeah, I guess I'll just start by answering that question. So it's ultimately not a requirement for the diagnoses to be entered. It's more of a filter option. And so at the moment, we've got a few filter options for that tool that'll be either to filter to specific patients where you input folder numbers and you're trying to see whether or not that patient is currently disengaged or what the sort of status of their current disengagement is. Then there are also options to filter by different ICD-10 groups. And so if you're wanting to, for example, see all of the individuals with a schizophrenia diagnosis, what their rate of disengagement is at this point in time, then that's also an option. But none of these filters actually have to be used, and so you can just click to make it no filter, and then that'll show the full cohort, just limited to either your facility or by age group, for example. I hope that answers your question. At the moment, they don't go beyond mental health conditions. Oh, okay. So that's kind of what I described in the sort of beyond the project. At the moment, we've decided to limit to specifically chronic mental health conditions. So we're also excluding some of the conditions that present a little bit less chronically as well. And we're focusing on individuals who should be receiving some sort of continuous care, largely because we don't want to create an extra burden on service providers. We don't want them to now be following up with larger groups of patients that potentially don't need to currently be engaged with care. Ultimately, there is room for it to expand both to more acute types of diagnostic groups and also to expand beyond the mental health cohort. And so, for example, the HIV cohort is probably a cohort that would benefit quite significantly from a tool like this. And then we can ensure that ARVs are more routinely collected and used. Yeah, I hope that answers your question. And then on to Bianca's question, or questions, I guess. So, yeah, I guess your first question was in relation to a connection to other provinces, and if there's some sort of ability to create packages that could extend to other provinces if available. I hope I got that correctly. So ultimately, the issue is that what the tools really hinge upon is the availability of digital data. And so the Western Cape has benefited from having the gradual rollout of electronic capture systems across the province for quite a few years now. I think it's around 2 decades, where a lot of the other provinces are quite a bit more behind when it comes to that. There's definitely efforts in place to be gradually rolling out electronic capture systems, but it's difficult to really make larger inferences about what the cohort looks like when you have really big gaps in where they're accessing services. And so I guess that's focusing kind of on the dashboard component, but then that issue is even larger when it comes to trying to see whether or not they've been retained in care, because ultimately you don't have much visibility of what care they're really receiving. I think in terms of the way the process for rolling up evidences is used, those kinds of things could be quite easily transferred, such that whatever evidence is available is able to be to really be synergized with other evidence that's available, so that you can better infer the presence of conditions, for example. And it is becoming a sort of growing practice globally. It's based off of the approach used for phenotype algorithms. And then I guess there's maybe some components in relation to data set architecture that could be transferred as well. But ultimately, actually having a working tool is hinged upon the availability of the data. And so if that's not really available, then it makes it quite difficult. When it comes to actually engaging with other provinces, there is quite a strong divide between the provincial departments. And there isn't really a willingness to share patient data outside of the province. And so ultimately there isn't really much visibility. And even the divide between sort of national and provincial departments is quite strong. And so we struggle to, for example, have good visibility of mortality data unless those mortalities take place in facility. Ultimately there are talks in place to try and form relationships where data can be shared, but they take a very long time, and they aren't in place just yet. And I've forgotten your second question. Oh, yes.
Have you had interest?
So we haven't actually, because we're using routinely collected healthcare data, none of this data has been consented. And so ultimately, when it comes to its use for research, that's something that we're apprehensive to do. And so we would want, if someone is hoping to use the data for research, it would need to undergo a rigorous process of ethical approvals and internal approvals as well. And so, I mean, when it comes to aggregated data, it becomes a little bit easier. But ultimately, we're not wanting to extend the data into being so research focused, because when it comes to the Provincial Health Data Centre, the main goal is focused around service provision as opposed to research. And so, it's mainly to do with the protection of patient data because it hasn't been consented.
Great. Let's give Timothy a hand for a very articulate presentation. Yeah. That was Timothy, backed by Mhdp-A, the gift, giving moral support from the other end. Oh, there's Andreas and Olivia. Where's Olivia? Okay. She arrived today, ladies and gentlemen. You remember her introducing herself? Yeah. Okay. So, time for a quiz, and you have to get this quiz while standing up. Yes. Guys, let's stand up. It's lunchtime. If I'm struggling, you must also be struggling. I need company. How do they say that? What loves company? Misery loves company, right? Not that I'm miserable, but you know what I mean. Yeah. All right, stretch a bit. Do something. Onyango is going to come here at the front. By the way, we have our very good support team for lived experience expertise, and Onyango is one of those. Onyango works very closely with Benta. Benta, where are you? You can... We really have to look so that we don't miss Benta. Where is she? Oh, she stepped out. Okay. So Benta works very closely with Onyango. He's better called as Rix. He's a king of spoken word. Sometimes. There you go. Speak for yourself.
Good afternoon. Mine isn't as witty as Doris's quizzes yesterday. But in the spirit of giving back hands, I just want us to do a little exercise with our hands like this. While you're at it, I need you to shout the first word that comes to your mind. Just shout it out. The second one? I can't hear everyone. And the third word that comes to you? Beer. Meru now. All right, that's all. Thank you so much. See you tomorrow.
So you'll have a chance to hear a lot more from Onyango or Rix the poet. He will say a lot more about himself, but he's a very interesting character as an individual, but also very useful in the advocacy for mental health. Beyond that, he's been a great resource to the Mental Health Data Prize team. I'm sure the teams can attest to the work that he has done with you together with Benta. And for that, we thank you a lot, Rix the poet, and we'll see you tomorrow. Okay. So we've caught up a bit of time. So I really would want to bring in the team for DHIS2. I'm sure there's someone in the room representing the team. And as you remember, this is a project being implemented in Uganda, and most of the other members are not here. So we will listen from them. Let's stay engaged again. And then there's going to be a quiz at the end of this presentation. So please take your notes, and then I'll come back with a quiz.
You're cheating exams. The quiz is about the presentation. So, yeah, thank you very much. So we'll take it on from here. I'm Prosper, representing the team in Uganda. I'm sure my team is online to support me because they have been the most team that has been active behind this scene, and to bring you what we are looking at. So for Uganda, we're really trying to build on an existing implementation of health information systems. And so as we look towards this presentation, we can already see that if this innovation is going to do what has been done in Uganda, we can quickly be able to cover almost 80 countries globally, because the DHIS2 is now implemented in over 80 countries across the world and used almost to the ground, the health facilities, service point. So we want to really upfront say this has been a collaboration with the Ministry of Health, and it's sad that they are not part of this presentation to come and present, but we have really worked so closely with the Ministry of Health and used Ministry of Health tools and the Ministry of Health structures to do the entire implementation. So we will just share a little bit about the gap that we were trying to address as the call for this prize. Actually, there were gaps, not one gap. Then share a little bit about the methodology, the approach that we used, and some results that we've so far been able to see in terms of data insights, but mostly importantly in terms of the findings on the ground that will be able to immediately inform policy, which copy I've shared with you, that we are looking towards to launch very soon. And then we will share with you the next steps. And as a matter of fact, some of these next steps are already in implementation as I talk. So it's mostly, what is going to be improved. And then we'll have a chance to have questions and answers since we have caught up with time. So in terms of the problem that we were looking at is really the digitalization of the primary data collection in primary health care facilities. And we heard about Africa CDC also asking that we need to go into primary health care digitalization. So our challenge is the mental health data has not been digitalized. Even other data has not been digitalized in Uganda for over decades. It's a few facilities that we are coming down to implement EMRs, but the lower facilities, the primary health facilities, where we do find a lot of depression, anxiety, they are not digitalized. So what this means is that the data has been staying in the paper registers. And what is picked is a simple summary that does not give a good picture. And our project really looked at, if we really want to address mental health challenges, we need to keep the patients in care. So we need to be able to see that we can be able to follow them through the different visits, but also across different facilities. Because they will be referred, they will be transferring themselves into the different clinics. We also have seen that these paper records were not able to give us a clear pathway of a mental health patient or client. And so the digital part of it needed to come in so that we can be able to have this data readily available to the clinicians and the policymakers to be able to follow up the clinics. And also look at the referrals, because most of our countries run referral systems that are not properly documented. So this solution again is really also to help us be able to document the referral mechanisms. The other problem was that a lot of data that has been collected on the primary register, very small summaries aggregated, make it to the policymakers. And so we urgently needed to be able to see how to address this. And in working this solution, we looked at who the beneficiaries would be. Of course, our clients or patients who will be seeking services from different clinics in the different months of follow-up. The health workers who will be able to retrieve easily the previous visits, and the facility managers who need to do planning, especially around human resourcing, stocking, and clinical visits. And of course, the Ministry of Health partners who use this data for planning at the national and regional level, communities, and lastly, to you researchers who will be going to Uganda to look for the data, to do your modeling and forecasting using the individual level data that is coming out of this project. Of course, why this really matters, because we have not seen a lot of research that has used longitudinal patient data, especially in the mental health. We have had a lot in surveys or relying on aggregate data. So again, to really bring the problem to what we were trying to address, we also have a scenario of this young lady, Genesis, 25 years, and that's actually the age group that we find that is mostly affected, and arrives at one of our health facilities, which is the National Referral Hospital, that supports our mental health clients, and diagnosed with depression. She's given medication, but that's the last time we ever hear about that record when we go to the registers. So in the paper register, she gets completely lost. We cannot be able to follow that. We cannot not go to the piles to be able to look for the, when they were supposed to come back, what are the contacts, and they have alerts, SMS is sent to her to be able to return. So in our analysis, as we share what exactly we did, we found that just like Genesis, almost 85% of the records that we were able to digitalize do return for care, which is a big, big problem. While a system like, longitudinally tracking them and having reminders and having dashboards that shows you who has been lost to care would be able to close this gap. So as you can see, that was our statistics from the paper digitalization registers. We attempted to go back 3 years in time and digitalize all the paperwork. And these are some of the findings that you would see, that, we are losing quite a number of our clients due to care. So that's why our innovation really comes in handy. And that's why we are happy to share that, this is how far we've been able to go. So in terms of the methodology for the Rio project, one was to really be able to digitalize all the paper registers. You may not be able to see, those are registers, piles and piles that you find in primary health care clinics or hospitals, piled. The moment you're done with this register, it is stored somewhere, And some of them were even retrieving from the, containers that have been isolated for quite a long time. And so we designed on DHIS2, which is a web-based platform. We designed a tool, a centralized tool, to be able to capture all the data the way it was captured, no changing, no transcription, just the way it was captured at that time. We also be able to see if this reporting that we've been getting as aggregate is really matching with what we have on the ground. And guess what? It was surprising that, we have different reports. What is in paper is different from what the aggregate numbers you've been receiving at the national level. So we entered all this data into the tracker capture. And some of the characteristics of this data is that it is not identified. So there is no unique identifier. So the day you come, you are given a new number. They forget about your previous record. And so with this project, we try to go back and recreate a longitudinal record. So we designed what DHIS2 is good at is a patient tracker. So it will get you enrolled and track you through their stages of treatment, especially for the chronic diseases. We've been using it for HIV, TB, and antenatal management. So once we had all these records, quite a number of them, we went through the process of cleaning and all that, and then we developed a tracker which has registration and follow up within the treatment. And once we had that, then we started doing some analysis, producing some insights, and we were able to build some dashboards that we've been able to, we'll be able to share with you during the discussion. So this is very key, is that we're really looking at using clinical data and longitudinally to follow these clients. We are not talking about a one-off survey. We just want to be able to register a patient and follow them through time. So at a clinic, when the client does not show up, we should be able to have a line list of those who are scheduled to come but did not come. It's a tool that we have integrated within all the other services as we roll out digitalization for the lower health facilities in Uganda. So at this point, you will be able to have more of the data-centric data for this patient. So you, as I will show the tool, you will be able to see that, now we can have mental data integrated already with HIV, TB, malaria, ANC, and all the other services that they receive at the health facility. So the package that we are trying to roll out at the end of this project, as we move forward, is really a package that is going to be inclusive. So it will be a package that has a longitudinal tracking of patients with dashboards for the health facilities, the sub-national levels, and also the national level, but also including the partners. This particular package will have to incorporate in the quality checks to address the important data that we need to be able to present and use for analysis. This including, the risk factors, diagnosis, when they switch from different medications, but most importantly, being able to link the patients. And we also want to release this package with training materials that can help the health workers to be able to review the data more often. Because most times they will be entering the data in a rush, but at the end of the month or a week or a quarter, they need to sit down and be able to review their data. And this particular module will also be allowing them to be able to have mentorship support from the districts. Capacity building is what we do and will be part of the package that has training materials, videos that the health workers can utilize to be able to look at this. And of course, to the public, following the data governance policies of the Ministry of Health, data will now be available for the researchers and also manuscripts as we see some of them coming up. So just to show you the tool and how far it is in terms of the development and the deployment, we are building a ship as we move. I will show you a few slides or screenshots of how the tool looks like. It's a very simple tool that we have designed with the users, and be able to make sure that it is very simple enough to be able to be utilized in the heavy clinics, and it doesn't take a lot of time when they are doing the data capture. But most importantly, that it can also be utilized. It can also be used on the smartphones that we do find in most of the health facilities. So it's a both web and Android-based tool. It's offline, so that you can be able to go offline. We don't have connectivity in most of the health or the lower facilities. So it has an opportunity to be able to sync back and sync down to your phone as you work. So that's how the tools are simple as that. When you log into the system, the facility is able to see this interface, and simply just to be able to search for any existing client using whatever parameters we have selected there. So they are able to search within the health facilities and across facilities. They are able to register if they search and the client is not in the system. Up there, they are able to pull data from the central server to their local working space, synchronize metadata, because we are building the system as we get it implemented, and also push data back to the server for the general public consumption and also reporting. This is the display of one of the clients that we have in our records. Has been coming over time, and you can see, consistently how this client has been coming for services, for medication, checkups, and all that. And you can quickly be able to see some quick analysis here, in terms of the weight has been going up, the height is also going up, and quickly the clinicians can be able to start, thinking through the referrals that are happening here and what other services they are also going to be able to receive is also displayed here. So this is where the clinicians interact with the system. And here you can see already the integration with the other services. So patient came for mental health check-in, and in here, he or she can be able to get services across this spectrum. It could be something to do with, postnatal, maternity, or HIV counseling and testing. So that this data can be useful in terms of, identifying the risks that we'll be able to see in our insights. That is also part of the patient encounter, where you have the medication, so you can be able to see the medication. The laboratory tests are also part of that, the screening and all that can all be put into the system. So this is, in that, how the clinicians will be are able to interact, because it's already out, are able to interact with the system, and mental health data has also been integrated part of this. And I will be able to share with you how far in terms of scale we have been able to go by the end of the slides. That would be a simple dashboard that the managers, different level, can be able to use to be able to monitor the progress in terms of data entry and so on. And this is coming from the data that we were able to enter, and you can be able to see the different participating hospitals, and in terms of whether they were new or reappoint or new visits or reattendance, and also some of the risk factors. As you can see, very, very minimal data that are able to be captured from the records. So this dashboard cascades all the way from the national level to the facility level. So depending on how you log in, you will be able to access data to what you've been assigned to. So if you're at the district level, you'll be able to see data from your entire district. And in terms of reproducing this design, as I shared before, this is built on an open source platform that has widely been utilized by many countries. So as a matter of fact, what we are is being able to produce a toolkit or a package that other countries can be able to utilize to improve their mental health tracking, especially if they are using DHIS2, it's just going to be a plug and play. And we've done this with different funders. Right now we are doing the outbreak management with Africa CDC. WHO has had so many packages of this type, and so we should also be looking at a package of mental health that can be able to be utilized. And again, we have been able to share all that we have been able to do in this, including even the metadata. So in terms of the results, we initially worked with 18 regional faro hospitals, looking at data for 2022, 23, and 24, to try to be able to digitalize the paper registers. And because of time, we were so ambitious, we thought we would be able to digitalize all the records. When we look into the system, these 18 regional faro hospitals contributed to almost 400,000 visits in that period of time. So we set out to digitalize all the 400, but unfortunately, because of time, we were only able to digitalize 194. Of that, when we look at when we did some cleaning, there were quite a number of empty records that were coming through. Some of the records that were unusable because they had no diagnosis, they had no prescription. Basically, they had, just basic information. So most of them were dropped, and we could uniquely identify 140 clients in the system. When we brought all this data and applied some machine learning, we were able to look at this. And then when we looked at the longitudinal, trying to reconstruct the longitudinal way, we were only able to look at only 14% of that, the 140, had more than one visit. And again, I will show you the slide, how it goes. And this is very, very key for what we are trying to do. If we can only just have one snapshot and doesn't know what is going to happen or what the outcome has been in terms of improvement, then we're going to have a big challenge. So our biggest challenge in terms of the insights was missing data. So you could see that we were able to remove all these records, which is a very big chunk of data, because some of them lacked the diagnosis, so we don't even know what it was all about. Some of them were duplicated. You could easily see the analysis could easily see that this is a same record. Maybe somebody entered it twice, again, which is a challenge of unique identification. And we felt that we really needed more information for our more insights, which we did not get into the records. Like, for example, symptoms, severity, the outcomes, whether the patient was given an next appointment and they missed it, and the referral, whether the referral was completed. In the system, they say they were referred, but did they really reach? So we really look to see that we can be able to, as we move, add these particular data elements that are very key for more insight, for programming, for prediction, for forecast into the system as we build it. We tried a little bit to do some predictive modeling, and this again was, trying to look at how would we look at continuity of care. What would be some of the predictors that can be that clinicians can be able to use to see if the patient is likely to come for the next day. And again, because we lacked most of the important information in terms of prediction, this really does not really give a good picture, but a starting point that, we see some of these predictors that we looked at, like the month of visit being one of the determinants of whether the patient will be able to come back. And again, these months are out here, and the different clinical health workers are able to see what those different months they have to do with, when the patient present and why they're not coming. We looked at things like, the sex also as a predictor, and all these really show that, this model, if it can be embedded into the tracker the way it is right now, we could be able to avert the challenge of continuity of care. This is what I was talking about. This chart would be very good if it was having complete data, to the extent that you see the different type conditions reduce as the visits go on, but it's not the case. They are reducing because the data is missing. The continuity is not there, and so don't conclude that as we go on from visit one to the next visit, we are able to get our patients in good care. And it's not this. This is just to show you that we are missing quite a lot in terms of missing data, and so we really need to improve and be able to follow up our clients. The other insight that was very, very key, that was really, really glaring, was the burden in terms of the age groups. We found out that majority of the affected clients or patients are the youth, which is not different from what all of you have been able to analyze from the data that you have seen. But this really calls for government and policy changes, and also the way we implement and target the different groups for supporting and sustaining our programming. This is also something that came up very well in terms of trying to show the adoption of policies and treatment guidelines that we have in the different countries. Some of the treatment guidelines are as old as 10 years, but you'll find that most of the health facilities have not been changing the treatment, have not adopted or looked at the treatment guidelines in terms of, what medications the different patients are receiving. And again, also, it was very clear that even for the continuity of care, there was a lot of switching between the different medications. And so the policy here really needs to look at, what can we be able to do to be able to improve the prescription, and this is where we bring in the prescription dashboards and having the facilities be able to look at what is available in terms of, because the system is going to really implement and push for these guidelines that we are only availing the medication that is prescribed. So the next one is really to look at the next steps and what we recommend moving forward. And these are recommendations, what we are going to also be able to do, but also recommendations that you can be able to do moving forward. Okay, so we have developed a policy brief following all the analysis that we've been able to do. So you can scan it there, but you have a copy also on your table. And then this policy brief has really 6 areas that we want the ministry to be able to adopt. One is the continuously digitalize healthcare, public healthcare, and standardize the care pathway, because right now there is no standard care pathway for the mental health patients. Just like we have with HIV, it's supposed to be coming after 6 months, you do a CD4 count, you do a viral load after 12 months and all that. So it's also recommending that this needs to be established. Investment in a capacity in the capacity, the staffs and the data clerks that they do take care. Prioritizing the youth, as we have all seen, and then strengthening the follow-up mechanisms, where we really need to put in place a system that can be able to follow our clients. And of course, routinely using the dashboards for that. And this is the last one. So in terms of what we're going to do as the team together with the Ministry of Health is to improve the mental health data set for better modeling. So we have an opportunity to be able to add in more data elements within the current implementation. We will be able to support the Ministry of Health if we get resources to complete the development and the integration into the main registers that are being rolled out, but most importantly, continuously support the rollout and the scale. So far as of today, we are actually, I checked, we are 657 facilities out of the 4,500 facilities that we need to be able to roll out to in the lower health facilities. And then, of course, continuous capacity building. And the side of data, which is part of this project, is to really enhance the quality, keep monitoring what is coming through. Integration with climate data, that's another area that we, as a HISP, again through another project with the Wellcome Trust, we've been able to integrate climate data within the different systems, and this actually in most of the countries now it's done, but particularly for this instance, for this implementation, we want to bring in climate data and see how it plays around, dashboard enhancements, and build more models and predictive analysis around this data, the rich data that we're coming out, and also support implementation of decision support tools. That is the team, and the project team together with the Ministry of Health leadership from the mental health. This is our commissioner for mental health, and these were all the regional referral hospitals directors who participated in this project. This was at the initiation, and also their data management teams when we are starting the project. And of course, thanks to the team that has been part of us, we bring here the University of Oslo because we work with them along with the DHIS too, and the HISP Africa team that supports most of the implementation. So thank you very much, and I think I thought I had time, but I was warned.
Well, you've done enough and very well with the presentation.
Thank you.
You still have time to answer a few questions though. I'm sure yeah? You can't run away. Yeah. So that is a HISP team. Did you tell us what HISP stands for?
Okay. So HISP is Health Information Systems Program. It's a network of different HISP groups. In Africa, we have what we call HISP Africa, and we are a consortium of 15 now registered HISP groups across the different countries. So we do support system strengthening, information system strengthening, not only in health, we have also done some work in education in all these countries. So wherever you go, we have HISP Kenya here that can be able to help and support the Ministry of Health in terms of this data management.
Great. Like the earlier team, we find two groups that have the benefit of being embedded within government data sources. PHDC clearly have an advantage with working with the Western Cape government, and we have another one here from Uganda who have that benefit of working with government. I imagine that policy and advocacy should even be much easier again for you, because the benefit is almost straightforward to the government.
As a matter of fact, we have a running MOU with the Ministry of Health around research and the system strengthening.
Okay.
Yeah.
Great, Winnie.
Yeah, thank you so much for this really fascinating presentation, and amazing to see your integration into the different healthcare facilities, so many of them already. I was wondering whether you had any reflections on how the uptake has been there, or whether there have been any challenges. You've mentioned training already, but I guess, mental health care providers are stretched as they are. Is this making things easier for them? Do they feel that this is an extra burden? And how can you, do you have any reflections on that?
Yeah, thank you very much. Should we first take?
No, you can answer that as we look for another person.
So, in terms of the challenges, of course, there are always going to be quite a number of challenges. One of the major challenges that we've had is the mental health did not have a dedicated paper register that is able to follow the care pathway. They've been using the OPD register, which is general, and a lot of information is missing. So that's a challenge that we are going to address by trying to help the ministry define that care pathway. Then, in terms of the uptake, of course, the other challenge we found was the healthcare workers. The availability of these healthcare workers, especially in the lower facilities, they are not available, so they are improvising, and so what the kind of care that they are receiving is not professional as it would be required in that area. But in terms of the system uptake, we're not finding challenges because we're going through paperless. The paper registers are now being withdrawn, and now the system is replacing the paper registers. So the uptake is just seemingly, because you're not going to be now filling the paper form and then turn it back and put into the register. So they are using that. Then the other major challenge, of course, is in the infrastructure in terms of the gadgets to use. So some of them are using their own phones to be able to enter this data. And the internet connectivity, the government is negotiating to whitelist this so that they can be able to have free access to the system. Thank you.
Any other? Wow, that must have been very clear and straightforward.
Okay.
All right.
I will take it, sir.
No, John Black, you raise your hand late. We are going to penalize you for raising it late. Yeah.
Okay.
There you go.
Thanks. We've been working with him, but I'm going to ask a question so that I bring it to the attention of everyone else, and maybe he has some ideas. So I have a small problem with the teams that are working with aggregate data, like the data that goes into DHIS2, because it's like you are waiting for the data to be collected and then you use it, which is also good, but as a clinician, as a doctor, I'm also concerned with the data, the collection process when the data is, the point of care. And I don't see efforts to deal with the issues at that point. So, for example, issues to deal with identity management and having unique identifiers, for example, which, of course, becomes a pain for you downstream. But we hear this problem over and over, and the teams never really want to deal with that problem. There is, of course, designing interfaces for people to capture data digitally, having it standardized, giving them feedback on missing variables, so that we don't wait 1 year later and find data that is missing or incomplete or the quality is low. So are you doing any efforts in solving data at the point of collection as opposed to waiting for it downstream?
Let me just clarify that question before you answer. Are you answering as a government representative or as a data user? Which cap are you wearing at this stage? John Black, which angle do you want him to take?
I want him to take it as a person who is doing a project.
Okay.
In this case, to say, okay, while I'm focused on the secondary use of the data, I'm also going to try and
improve
help a bit of the data as it is being generated and collected.
Okay.
Yeah, thank you very much. So again, Dr. Black, John Black, you need to, you recall we are now dealing with individual level data. We are not talking about aggregate being entered at the district level and so on. So this implementation is with individual level data, and the data is in the hands of the clinician. So the app is being used by the clinician. So we have, and we are still continuing to attempt to put in some logical checks that, would prevent from missing data, mandatory fields like, age, sex, and what should be mandatory. So all that is just in the system design to really show that, to be able to improve the data collection. And with mandatory fields, with prompts and skips and all that, to just make sure that, it is seemingly very easy to manage. So that's what we are doing in terms of the clinic. But when it comes to individual identification, yeah, that's the biggest challenge, because there have been a lot of debates on what identification to use. And so for our project here, we're coming up with an algorithm that can generate an ID that will be given to the client to keep moving with as their unique identifier. So it's a system-generated ID that we are working on to be able to be utilized to be accessed across. Otherwise, the national identification is not yet in place. Thank you.
Dr. Linda.
Right, mine is just a follow-up question. So based on the colleague there, the question was quite simple, and I want us to really think about this. Is the effort right now to move away from just doing paper-based forms to more of digital forms? Because that will really solve a lot of the issues that we have been presenting for the past 2 days.
Actually, particularly for Uganda, it's not even something that we are debating. It's just a funding challenge, because the paper registers have been very expensive for quite a long time, and they have been funded by the partners, especially the paper partners. So since last year, we've run out of stock. So it's not a matter of saying, okay, I have paper and I have a tool here. It's now that we are now going to sort of a challenge, which actually is very good, that was created because of the funding challenges. So it's been passed that all health facilities turn now to digital tools. So the big volume facilities are using the EMRs, while the health center facilities, the lower ones, are using this tool for digitalization. So there's no more paper. Even if you want it, you will not get it unless you buy it for yourself.
But is there a vacuum between stocking out and rolling out EMR? I don't think it's a switch of a button, right? There's a big vacuum in between. So what's happening
Exactly,
in between?
and that's why, because even rolling out an EMR is equally more expensive, and that's why we're going for a low, easy, cost-effective tool like this at the lower facilities. Yes, in the process here, we've had some facilities, run without recording, and that's actually very, very challenging. And that's why we are vigorously trying to cover up these health facilities. On a daily basis, we're trying to see that we can be able to recruit more facilities into the e-register.
Great. So what we hear about the work done by this program, Strengthening Medical Health Data Through Digitalization, is essentially an extension of what, Linda, you're talking about, DHIS, known to use aggregate data. But they are now moving this application to the OPD, where you capture data through an electronic medical record capture form, as we had from Western Province. Data is entered, then it's pushed back and becomes eventually aggregated into DHIS2. That's how I understood it, and it really is ingenious. For sure, necessity is the mother of invention. Is it the father of invention? It's the mother of invention. We really load a lot on our mothers, man. You know, caregiver on this side, here again, the invention. John Black, we should be kind to our mothers. Ladies and gentlemen, can you stand up for a minute? Can you stand up for a minute? And yes, please clap for John Black. I don't think, not John Black, for him as well, yeah. For Prosper from DHIS2 Uganda, I think he's done a great job representing his team. I just want us to stretch. I don't know why my director of research doesn't want to stretch. He's been resistant to my requests. I'm not even talking to him directly. I'm asking the room to help me get him up. And yet he's a NCD researcher who is always telling us not to. No, sir, we demand that you stand up. Yeah. On this one, I'll use my power of the mic. Yeah, you know, when we go back home, I may suffer, but I have a body of witnesses in the room. Okay, ladies and gentlemen, I want you to take 5 minutes break. Stretch a bit, catch up a bit. We'll come back and do one more project, and then we will move into the other session. We had agreed to pack 3 projects in the afternoon. I think we are doing very well in terms of time. Thanks, Prosper, for helping us. Please stretch for 5 minutes, like proper stretching. You can stretch in the room, you can stretch outside around the pool, and let's get seated by 3:30, and then we'll get started again. resume the sessions, even as you try and connect with that. I can actually see Rita, and I know Rita works with Dr. Mwesige, and Philip, the team from Digitizing Psychosis. Rita, I can see you. Hi. Yeah, I can see you. You've shared something in the chat. Is that for everyone's consumption or for my own consumption?
To that data set as we present.
Oh, okay. So there's a data set that has been shared. I think my colleague Angela will download that and keep it something. She has also requested that you will move the slides from your end, right? Because we don't have a copy of your presentation here. And I think that's better because, again, you're presenting remotely. Joel, could you help me get the colleagues to get seated? So just give us 2 minutes, Dr. Mwesiga. I had given a small break to the colleagues, and they are just taking their seats now, and then we'll be with you. But you can go ahead and try and share your screen. Yeah. Great. We can see it.
Is there a way you can make it bigger? Yeah?
To make what big?
It's yours, yeah? Oh, okay. No, I thought it's on your side that is not full screen, but turns out it's actually our end. So, yeah, we will work on that from our end.
So, ladies and gentlemen, we have...
Frederick, can you mute, please?
Can I do what?
We are getting some feedback from your side.
Well, if I'm mute, you can't hear me, so...
I don't know.
Maybe there are two...
Okay. Is there another laptop connected that is not muted? Okay. So allow me.
That seems to be better now.
Okay, so the culprit has addressed the issue without identifying themselves, which is okay. We did have to know who it is. All right, so thanks, Damaso, for showing up. The online team has been very quiet. We really hope that this afternoon you can help us to get engaged and to remain focused on this very last presentation of the day today. Certainly not the least in terms of the work that is being done. So I would love to invite the team from Digitizing Psychosis, as we call them, led by Dr. Mwesiga. But I have to warn you, Dr. Mwesiga, that I really suspect that you're going to say something to do with Arsenal. We have agreed that that London club does not feature in any presentation. Everyone in the room has said that they don't want to hear that, and I'm speaking on behalf of 40 plus people in the room. So be duly warned. Having said that, having gotten that out of the way, you are allowed to take on and make a presentation. Over to you, Dr. Mwesiga.
Thank you, Frederick.
Mwesiga.
Unfortunately, it is in my first slide. Can you hear me?
Yes, we can hear you.
Okay, thank you, everyone. We are the Digitizing Psychosis study has been introduced. In the interest of time, I'm going to introduce the presenters today, although they represent a larger group. So everyone
psychiatrist and senior lecturer at Makerere University and the president of the Uganda Association of Psychiatrists. Wilma is a biostatistician. Rita is a founder of Aphrc Spaces and the lead expert on the team. Dr. Awujo is an INI, Capacity Development Fellows, and they're just happy to be mentored by champions. And Philip, the last champion, is a full-stack AI developer at MRC. So I think the first thing we want to acknowledge is that we actually Dr. Navende's lab at Makerere University. And we are really grateful because without her support, this project would not have been successful. And this picture here, where with people looking confused, shocked, worried, is just an idea that hard work pays. And we think we've developed a very good product. I think one of the key things compared to other projects is that we didn't have data at the start. So we're really proud of what we have done. And what we're going to do is in 4 core themes, we're going to try and explain exactly what the project is about. So I'll start with a challenge. I think the simplest challenge is that most mental health data in Africa is on paper charts, patient clinical charts. So this idea that we're going to revolutionize mental health care AI in Africa struggles because electronic medical records are not really available at the moment, and most of the data is in paper charts. And so it's really important that we figure out a way to bridge the gap of turning these legacy records into AI-ready assets. We have tried to do that, and why we are passionate about this is that we tried to do it before. That paper on the top right-hand corner is something we tried to do. We tried to figure out the predictors of engagement in our setting, and we had a sample size of 1,667. Those were all the patients who had come to Butalika for the first time in 2018. Butalika is the National Referral Hospital of Uganda. So we tried to extract data from the files, but it was very tedious. After about a month, we had only managed about 100 files, and we had limited our extraction to the face sheet. So if you really want to get data, we need to find a way of actually getting this data from these face sheets. So here is an example of a face sheet. This is a dummy face sheet made in Makerere, and here is an actual clinical note, de-identified. There's no patient data. And I think the question is, what would happen if we could, capture more than 100 face sheets and in fact go beyond the face sheets and actually look at the details and get data from them. And for us in this study, we're looking at the drivers of engagement, but it could be for anything. So we had 3 main research questions, where it was, can you take a paper clinical file and extract the relevant information from it, and do it quickly and accurately? Can you convert that information into a structured data set? And then can you analyze the data? And Hekima AI platform is designed to do just that. And what it does is that once you do that, you then have once you have that data in a digital form, then you can unlock a lot of things. Real world care, predictors, and all these models, building models, which is very important. So that's the core of what we're trying to do during this project. So I'm quickly going to hand over to Pido here to tell you how Hekima actually works.
Good afternoon, everyone. So to begin with, I think the most important thing is that we worked with the different review boards and got ethical approvals from the UNCST and Butalika National Referral Hospital. And a key thing to note is that we did not use cloud services because this is patient data. So all our models are locally hosted. Just an overview of how the application works. It's a Django Python-based application that uses Celery and Redis. Sorry for the technical jargon. But in simple terms, what happens is that we digitize the files, we hand them over to the first model through the application, which extracts text. Then we run an intermediate model to do redaction on the text that has been extracted. It uses natural language processing and near entity recognition to redact personally identifiable information. Then we have our second model, which then gets this de-identified data or redacted data to extract now data about these patients and then generate a longitudinal data set. We also have human reviews, especially for the outputs for the first model and for the text extraction and for the data extraction. Just to show you an example of the output, you can see on the left, that is like a patient sheet, notes. What I just wanted to highlight here is that when you look at the bottom, on the left, there is a first name choice that the model correctly identifies and redacts. So you will see on the right of that image at the bottom, there's a redacted person. Moving on, so this is an example to show that whereas the model is doing great work, it's not perfect and there's need to improve. This was a different patient reading information, and you can look like the best example I can show is on line 1, where it mentions no HX. HX is shorthand for history, no HX of cocaine. But when you look at the image on the left, that word is not really cocaine, it's more closer to alcohol. So the model is struggling with the handwriting in that case. Dr. Mwesiga mentioned that it took over a month to extract data from 100 files. The image here shows, so the image on the right is an extract from our application. This text is very small, I'm sorry about it, but I just wanted to show you from bottom to the top that each line represents a step in processing a file. And on the left, you see that this file had 17 pages. It took about 16 minutes, just under 17 minutes. So that's an average of about 1 minute per page. And the longitudinal extraction for this page took about a minute. So you have processed an entire file in less than 20 minutes. The link that Dr. Mwesiga shared on the chat is the longitudinal extract, our data set for about 132 files that we were able to fully process. And going forward, Wilbur will be showing the analysis that has been run on those 132 records. So, Wilbur,
thank you, Peter. Wilbur, do you see the sheet?
No, I'm still seeing the link.
Okay, just a minute. Let me stop the process. Okay, but people have the link. But let me just share it again. Where is it? Okay, you can start talking as I share the link.
Okay, thank you, Udo and Dr. Emmanuel. So I'm not sure if Francis is in the room. Most of the time we had check-in meetings. He kept asking for the data. So I'm here to reassure him that the data is actually there. And it's longitudinal also. So the data has both demographics, then subsequent visits that the patients came back to, those that were able to come back.
Well, but first go to the results as we come back to you. I think I'm in the wrong account. That's the issue. Just go to sharing. Oh, it's me sharing. Okay, let me go to the next. We'll come back to the.
You can move to the next slide.
Okay.
I think it's showing the notes.
Yeah,
I think
you need to come out of presenter.
First time share, then we share.
What are you seeing now?
You're not yet sharing again.
We are seeing you.
Okay. And now?
Yeah, sharing.
Oh, yeah.
We are now seeing the slide.
Thank you. I think that's okay. So after curating the data, we had to check for how accurate it is. And amongst the things we needed to check for, of course, we had a humanly generated data set that was the metadata. That was the gold standard on checking for accuracy of our system-generated data. And to check for accuracy, we used, amongst many other things, a few of these. For example, for the sex, how many of them were in agreement with what the metadata had. So the metadata is the humanly generated, and what we were running against that metadata is what our system generated. And close to 94% of those that were captured by our system were correctly captured against the metadata that we have. Age, only about 51% or 52% had the exact match. It might seem low, but we probably know why. The reason is if you look at a patient file and the patient comes back for several visits, when the notes are being taken, the clinician usually writes the patient's age. So on subsequent visits, if it's a year later, if the patient was 44 last year, it will be 45 this year, it will be 46 next year. So the system was capturing several ages. That's why we have a low concordance on the age. Next. Then our next question was, can we then analyze this data to generate insights? And some of the insights we're going to give in this presentation. So previously, the work we did about 4 years ago, we were only able to look at face sheets, and a face sheet only has basically age, sex, and a few other demographics. So that was what we worked with the previous time. But with our model, we are able to generate much more than what is on the face sheet. We are able to look into the clinical notes and pick out diagnoses. We're able to look also for the clinical characteristics. For example, we're able to get inpatient admissions that we're not able to get previously. We're able to get the different medications that are prescribed in the notes. We're able to note if there is improvement from the previous visits. If a patient had aggressiveness at admission, that is also can be picked. Those who have been reviewed or scheduled for subsequent visits, it can also be picked up from the clinical notes. Those who have HIV or other conditions can also be picked up in the notes. And we also picked up something interesting about referrals that we are going to discuss in the next slide. So like I said earlier on, we had a task of looking through 100 files, and it took us about a month to look at that. And that paper was published with an engagement of about 34.5%. So that means only about a third of the patients remained engaged from the initial visit. So when we ran our analysis again from the data that we extracted, we get something similar. We get about 36.4% of patients that remain engaged. The levels of engagement are low, but something that we can highlight that probably explains that if you look at the bottom corner panel of clinical characteristics from the notes, the first item there is referred to or from another facility. So some of these patients you might assume have disengaged or have not come back for subsequent visits, but probably have been referred to another facility for review. And then in the bottom right corner, we have two panels, panel A and panel B. So panel A is showing the exact number of visits a patient had post the baseline visit, while panel B is showing the minimum number of visits. For example, in panel A, I can say that 19% had exactly one more visit post the initial visit. Same with 19% also had exactly 2 visits, 21% had exactly 3 visits. When I move on to panel B, of course, all the 48 had come back for the first subsequent visit, that's the first follow-up visit, but the number keeps reducing as the number of visits increase, and probably that is expected. Maybe some recover or some are referred to other facilities. Then we analyzed for potential insights into the factors that could explain the engagement that we saw. And on top of what we had seen previously, we were able to look at several other factors. For example, inpatient admission, clinical improvement, where there is clinical improvement noted, where there is a review scheduled in the notes. So those 3 showed higher odds of the patient being engaged. Other things like HIV, gender, age did not show any significance. Substance use disorder was showing some tendency to disengagement, but it's not statistically significant. So in a summary, we've been able to show that our platform, Hekima, can transform patient clinical charts into a longitudinal data set that can be used for research. Of course, many other questions can be answered from the data that we have generated. Then Hekima also can pretty accurately, despite limited model training, pick up a number of things that we couldn't pick up in the initial extraction that we did 4 years ago. And then in a small preliminary data set that we've showed, we are gaining new insights into engagement that we could not see previously in the original work. I invite Rita to take us to the next session.
Hi, my name is Rita. So, when we started working with Hekima, our goal was very clear: to transform the handwritten clinical records into structured data that could support research and future AI tools. But as the work developed, it became bigger than just creating a data set. We began to see that the real impact was in the process. It was in the asking, how do we make this data trustworthy? How do we make it ethical? How do we get to shape it? Who gets to shape it? Who gets trained to build these systems? And how can this work speak to policy and improve mental health care? It showed us that mental health AI in Africa cannot just be about technology. It has to be about representation, local capacity, lived experience, and communication. And those are the 3 impacts we're going to talk about. I will start this discussion with the lived experience impact. When the project started, I was hesitant and thought to myself, this is just another project where I get pinned onto something as a lived expert. But the process has been different. We as lived experts have been involved from the scanning, the collection, the labeling, the interpretation of this data. And with that has built our voices to be louder, to be stronger, and to advocate for other lived experts on different projects. And this is really important because when you're looking at AI and the data sets, the facts that are being saved to this work are our personal stories. This is what we go through on a daily. These are our illnesses, the crises, the treatment, the relapse, and you're trying to figure out why we go back or don't go back. So being involved in the data that has helped shape this project has really been powerful and useful. Hekima went far and beyond what I thought it could do. It went ahead to support the projects that were being led by the lived experts. For example, last year, they were one of the funders of the second mental health run in Uganda. 350 participants came that included people from policy, mental health advocates, the normal Ugandans who are curious about mental health and what mental health research can offer. And that gave Hekima an opportunity to communicate what we were working on. I will give the next discussant to talk about the capacity building that Hekima has gone ahead to do.
Hello, this is Imi. Today I'm speaking on behalf of the fellows that were involved in this project. I joined this fellowship as a data analyst, and from day one, we started the work. There was nothing like sitting in class, just all we had to do was to get engaged in the work. When you look at the first floor, you're looking at the process that we went through. We went from paper records, digitizing, the CRFs, the ethics, the data cleaning, analysis, dashboards, evidence, and policy. Every single one step we covered from across different backgrounds and roles. So the thing was, we're hands-on. It wasn't sitting in class and learning. So the first point in this, like how this project impacted the fellows, is we embedded in real work streams. So weren't placed outside, we were placed inside live work streams rather than classroom training. The second point that I'll talk about is the hands-on across the full pathway. We gained experience in digitizing, archiving, ethics approvals, CRF design, data management, analysis. I was involved in the data management and analysis and the dashboard design. So we did all this as a team. We're 8 fellows, and we all went through these processes. Then the third point that I'll talk about is that these were real outputs, not simulations. From the protocols, the databases, we did the work. We did the records, we digitized them, and went through the entire process. The next point that I'll talk about is the competences built for AI readiness. This built the skills in mental health research, data science, implementation science, and AI readiness. The fellows contributed directly in this activity, and it was a hands-on which improved and strengthened our competences in the research. Moving on to the next point, it's a new generation of practitioners. When I talk about this, I mean all these 8 fellows, we participated in the work. So that means each and every person had a special role that they were involved in. And I guess we are ready to lead, analyze, govern, and build something that can be used further. Then the next impact was on the institution. The institution, as you have seen above, the eight work streams, like every output was a real project. And these 8 work streams that I'm talking about are the extraction forms, the variable dictionaries, decision rules, documentation, and databases. So like the outputs and the work streams all together benefited the institution. So the first point that I'm going to talk about, but please go back to the previous slide. Yeah. So it strengthened institutional capacity. Like across this pathway that I talked about in the previous slide, from records to research, this data that we got can be used for research and we can get results out of it. And then the next point is the systems and processes were established. So we created a system of data capture, governance, analysis, and evidence generation using this AI, Mhdp-A. Then the next point is we got paper. We got data sets from paper to AI ready data sets. And these data sets we have as the data set that was shared. That's some of the data that was generated from this. And this it is research quality and it can be used. Then the next point is evidence-based service improvement. So what Hekima did, it enhanced capacity for evidence-based service improvement, policy engagement, and future AI generation. With what we did, I believe more is coming in the future, and this can be helpful. Yeah, that is all I have to say. I'll hand over to Dr. Aujo.
Yes, Dr. Aujo.
Thank you, Imi. Yes, thank you, Imi. I hope you can hear me.
Yes, we can.
Okay, thank you. Yes, this is Dr. Aujo, and I will be talking about the third impact, which is science communication. Through this project, we did not stop at the technical part, the part of the computers, the part of the hospital records, which were hard to extract data from, but we went ahead to break down this AI to the communities, to patients, to their families, to policy makers. Just judging from the previous presentations, most people talking about AI. I've seen it has been complex for almost everyone. For some, it has been abstract. One of the early morning presenters talked that this is all Greek to him, and to most of us it has been, and it gave us an opportunity to collaborate. And even to some AI looks like something that is threatening. I think we have all heard of the word going around that AI has come to replace human resource and all that. And so despite all that, we had to explain this to the public to help simplify this. And in so doing, we came up with communication teams. You can see most of them in those pictures. And these helped us to simplify the communication to the audiences, to help them to explain why the paper records that we are using matter, why it is important for us to extract data from these records, why it is important for us to use AI, but not just to stop at using AI, but also to involve lived experts, to involve the patients themselves who have suffered from these disorders in this extraction of data. And also, we explained to the public why it is not about just replacing clinicians like people have anticipated AI is doing, and not just about exploiting the records, but to use this information that we have generated from this to hope to improve the mental health systems. We also showed them that we are extracting data from real people, from real records, from people's journeys, and I will encourage us to look at these data sets that have been provided online. You can appreciate the longitudinal data set whereby you will see that this patient engaged for this period of time, and then after this time they stopped engaging. You will also be able to see some of the reasons as to why these patients did not engage, and we had to explain all that to the public in a way that was understandable, that was responsible, and that was engaging. Yes, because of the different ways that they understand. And our work paid off. People were listening, and that is evident in our social media performance. We see that we were able to have 550 followers on across the various social media platforms. We were able to post 290 posts, and we were able to have close to 85,000 impressions. But also what is beautiful about this is that our biggest impressions came from TikTok. Who are the biggest consumers of TikTok? These are the youth. So that means our engagement was able to reach out to the youths as well, and we are very proud of this. Yes. And then also here, I'm going to show some of our outputs, and one of them is this metadata. It's available on that link. It has been shared on the WhatsApp platform, the emails. This will be able to help you see what we have been working with. And also these are other outputs that we have, our preliminary data set, the community engagement videos that you see on YouTube, and also across the different, those are our social media handles on Twitter, on TikTok, on LinkedIn, on YouTube. I hope following this that you'll be able to go and check out our content. And if you trust us enough, maybe we shall get some likes, maybe we shall get some impressions. Yes, thank you. And then other data sets. Our data sets are soon to be uploaded on GitHub as well. Thank you so much for listening to me. Let me invite Rita to come and complete the impact. Thank you.
Yeah, so for me, the impact of Hekima has been threefold. First, it gives people with lived experience a meaningful role in shaping the future of mental health data in Africa. Second, it helps build the local capacity needed to ensure that this future is African-led. And third, it creates a way for us to communicate and share mental health data in ways that are accessible and useful. The question now is not whether this can be done. The question is how we can scale it, strengthen it, and ensure it informs decision-making at every level of the health system. And that then brings us to our policy perspective.
Thank you. We have little time, so we'll just run through this with Pido. Over the year, we have engaged with the Ministry of Health, presented to technical working groups, met the head of ICT, and the sense we get is that the ministry is interested. But I think it is, as the DHIS2 team said earlier, it's really interested in linking community and facility data primarily, but it's also interested in how you can use Hekima beyond engagement. And I think the issue is that we can do both things, but I'm not an expert on that. Pido here quickly is just going to tell us how this can be done.
So primarily, like everyone has been mentioned, infrastructure is a challenge. And we have been lucky enough to get support from Dr. Nagende. As you can see demonstrated, we were in the middle of the night working at the AI lab in Makerere. But going forward, and together with the ministry to align our priorities, our tasks would be ideally to have the infrastructure in place to address the issues, and then also do targeted training for the different models that are being used to help improve on their output. Like I mentioned, that the current hardware that we have was insufficient and struggled with the task. This is an example of a handwriting that was difficult to read. And then also on the other side is that we, as the ministry aligns to integrate data across different levels across the country, though we would want to work with them to have the proper infrastructure to serve the country, in a sense that if a health facility has documents that they would want to digitize and extract information, they would be able to upload their scans, or we would help them to scan and then upload to the enterprise servers that the ministry would probably have, or if we were able to acquire together with the ministry, and provide the service to different facilities across the country. So let me just invite Dr. Mwesiga to share the final reflections on the project.
Okay, this is my favorite slide. It's been a year. When we got the grant, we felt like Bill Gates, and we thought we had won the lottery. But then we started working together. We can't underestimate collaborating. Data scientists, biostatisticians, lived experts, records people, psychiatrists. And many times we felt like manu funds. You know, the other groups that started with a lot of data always seemed ahead, and they always looked like they're always winning. And we always looked like we had one player of the year. But then, but then we had, I think because of how the support Joyce gave us, we had this breakthrough. For those of you who understand the West Ham game, that's where Arsenal won the title. VAR, last minute, they cancelled their goal. So after 22 years, basically, or after a year, we actually were able to start producing longitudinal data sets. And here, special thanks to Joyce again, but Sylvia and Francis, because we would go for meetings with our small wins. We would say, oh, we have been for a mental health run. And they say, but where are the longitudinal data sets? Where are the insights? So we thank Francis and Sylvia for pushing us, because we now have longitudinal data sets, and we're going to produce more. We're going to train more and make them better. And we're also generating insights, and we now feel like champions. So this is a summary. The files we've scanned, we've built models, we've trained fellows, we've worked very well with lived experts. I think one of the key things is that our final report is going to be made in collaboration with an independent review by You Belong Uganda. So basically, we've put money aside for them to come and review our reports, review our work, and tell us if people with lived the lived experience for psychosis think what we have done is well. We've gone on social media, we have supported people. But I think this is truly the last slide. In truth, none of this matters. And I think our message is that unless we can actually digitize more of these files, Africa cannot say that it's going to be part of the mental health AI revolution. Very grateful to Penda for communication, Hekima, USHS Women Judah Funds, Tabika Makere, Heart Spaces, You Belong, and of course, welcome APHRC and the Mental Health Data Prize. Thank you.
Thank you. Thank you. Thank you so much, Dr. Messed it up at the end, which is okay. Sometimes not everyone is wise enough. No, thank you so much. No, I can only joke with him because he's my friend. Let me clarify that. Yeah. Yeah, it can easily go the wrong way. Yeah. Yeah, no. We have personal beef between me and him regarding Arsenal and Manchester United. I knew this was coming. I didn't have to do it here, but it's okay. We've heard about digitizing psychosis, better called Hekima. Hekima also translated as grace, right, in Kiswahili? Grace. Where are the Kenyans who speak Kiswahili here? Hekima is grace, right? No, it's also grace. It's also grace, by the way. Yeah, grace. I insist. I insist. Where is ChatGPT when you need it? Yeah. Neema. Actually, Neema, yes. It's your Hekima, Neema. Yes, Neema, actually, yeah. So you're right, Neema. I had to switch to Kiswahili to get that. Neema is, so Hekima is, Hekima, Neema, grace. Where? Okay. I don't know what I'm saying. Anyway, Hekima gave us a number of things. They digitize psychosis records. Stay there, Dr. Mwesiga, don't leave. I'm just trying to recap what we've heard from you and correct me when I go astray, as I most likely will do, because personal reasons. Analysis of the data to gain insights from it. You've indicated what you did. Perhaps what I didn't understand is where 132 fits into the number scanned at the end there. So maybe you can also clarify that. There was, of course, meaningful engagement of people or persons with lived experience. You've heard from Rita. Rita, great red card over there. I wouldn't know how to translate that into USD. Maybe you could make it easier for us by translating the Ugandan shillings into USD. But the red card looked quite costly for some of us to afford. There was capacity strengthening, and we heard from the next generation leaders in research. It's amazing what a data prize can be done by different teams, and we've seen a different array of deploying the resources were provided in the data prize, quite massively used differently with different types of impact. But we have heard what that has done and how they were involved in the whole pathway. We've also seen the impact on science communication, and Mary Bita, who is online, I just saw her chat that she loves the reels on LinkedIn. Maybe that's an invitation for the rest of the people to go there and see the LinkedIn and the other social media handles, how those reels have been placed there. Maybe it's a good lesson in communication. And there was a marathon actually that was supported by the prize. Again, like I said, you never know what this prize can do, and it's done a lot of things. In Uganda, there was a whole marathon that was supported by this, and I imagine it has something to do with mental health work in Uganda. So among many other things that you've heard, the jargon and this AI language, all that, I mean, by any standards, looks like a lot has been done in this project in Uganda. And therefore, ladies and gentlemen, this is an opportunity for you to speak and ask for clarification. There is one question online, so if you hear me, if you can get started, and then we'll come back to the room. What's the name? Mary, go ahead.
Just a comment, just to really appreciate this team. I think I'm one of the few people who had faith in this project when they had no data. Mainly because I work in a rural area of coastal Kenya, and I know the massive challenge of wanting to make insights out of data, but it's all just in paper and there's not much you can do. So I think there's great potential. And I think computer vision is rapidly evolving, AI is rapidly evolving, and I think very soon we will take very little time to translate a lot of these files and answer very many questions. Mine is just the question I've been asking from the beginning, as in what next in terms of sharing this platform with people from other areas of the region and the world who have this similar challenge, especially since I think your project is unique in that language is not a barrier, because most medical notes are in English, for example. So just like what next? How soon do we expect to be able to access such a platform for our own areas of work? Thank you.
Great. Dr. Mwesika, if you can just take that down, or do you prefer responding as we go?
You can guide Frederick, whether we answer or whether we wait.
Okay, just go ahead and answer that, and then the next round we will take a few questions.
Okay, so yes, Mary, when we started again, we had an idea of how things would go, but when we were in Kampala, things were thrown into spanners into the works. We couldn't use cloud-based servers and things like that. The application is ready. What it needs is just a bit more training. So we've set ourselves a high standard to do this work. So right now, PDoc here can give you a link and you could send us digital files and we could upload them. Two things would happen. One, we would have to disturb Dr. Nabende Samo and her students. So like last night, we was looking for space with her students to do some other work. So we would be able to run it, but it would not come as fast as we want, because we've just said it's a structural issue. And if the structural issue can be managed, then people can start using the application. The application is ready. The more data we give it, is the more it will learn, and the better it will be at extracting data. Then the issue I think Frederick mentioned about the files. So we did scan about 16,000 files, 200 something thousand pages, and that data is available. Our ethical approval, however, is for only 1,667 files. So we will seek some sort of amendment to use more data to train the model better. That's why we are slowly releasing only the 1,667 files. That's the data set that we have ethical approval for. We don't have ethical approval for the 16,000. However, the 16,000 allow us to improve the model. And we have an agreement with Mhdp-A to train the model on all the 16,000. I hope that helps to answer.
Great. Yeah, certainly. Any other question online? No question online. We have some in the room. Who else in the room would like to ask a question? Okay. We have Prosper. Who else? One final person. Okay, please don't raise your hands after Prosper and some have asked. No, you can actually if you get inspired, yeah.
Yeah, my question is straightforward. So given the challenges we have with handwritten notes interpretation and then the clinical shorthands, how do you think we can improve on the accuracy of the model, especially even as you think of scaling to other places? You get records of people whose handwriting is probably even worse than the ones that you have trained your model with. So how do you plan to improve on accuracy with this tool?
Thank you, Sam. You know, actually, if I was to answer, I'd just say, why don't you just tell doctors to write properly? But then I don't think that's a good answer. We have Dr. Mwesiga, I hope you've got that question. How do you improve accuracy for bad handwriting? Is it bad handwriting or just good handwriting by doctors? You have another question in the room.
I had two actually. One was about accuracy, and given the handwriting that we find in so many of these clinical notes, and trying to really transcribe. But the other question is around the storage that which you are talking about, and it's been one of the biggest challenges that we've had with these innovations when it comes to integrating them in the main Ministry of Health mainstream. And so I was looking at whether you are looking towards a model where you can scan process without saving the scan, whether that would be something that can improve in terms of the processing and the storage that you're probably going to face challenges with if you want to scale this.
Okay, on infrastructure issues and storage capacities. Anyone inspired by that round of asking questions? Okay, Dr. Mwesiga, if you could reflect on those two questions.
So I'll ask Pido, who does more of the to answer.
So I think the first question was with regard to accuracy. The solution to improving accuracy has got to do with training. So you train the models on different kinds of handwritings. Now, how we have been doing the training is that we get patient files from Mhdp-A Hospital, and we have been working with SHOs. So these are senior health officers or like studying clinicians, because students studying to become psychiatric clinicians. And what we do is that we annotate these files. So what that means is that you get the files, you scan them, and then you give the scans to these SHOs who then sit down, read what is on those files, and then type out. Now, the advantage is because the SHOs also work at the hospital, they are more familiar with reading these handwritings, and then they type what they have read. Now, then you train the model on those annotations. And the more training on annotations you do, the better the accuracy for these models. And since you're using a rich variety of handwritings from different clinicians over a long period of time, then you also get a variety in your training data set, the annotation and training data set. So that is how we are improving accuracy, and that is our long-term plan, to scan more, to annotate more, and to train more. Then when it comes to storage, yes, storage is a challenge because you want to capture high quality scans that you will ensure that the model is able to pick up the handwriting and transcribe. But then you don't want to go too high in quality for these scans, because then that will increase on the sizes of the images that you're saving. A sweet spot for scanning these images is somewhere around 300 dpi. So dpi is dots per inch. As the image is being scanned, it's how it's saved. So 300 is efficient enough that the quality is maintained and the size won't be as big. I think there's sorry to correct you, Dr. Masida, but it was 6,900 files and over 200,000 pages. Now, the total size for that is somewhere around 10 GB. So 10 GB is a manageable size of data. If you extrapolate that and say across the country, maybe you're going to somewhere between 4 to 5 terabytes of storage is sufficient enough. So I think it's about managing the efficiencies, ensuring that you have a good enough quality scan and having the good quality but minimal storage requirements. And that is because it's almost impossible to run this kind of analysis without having a saved scan. We need to save those scans for the models to be able to read them.
So I think, just to summarize, it's we have gone through many of these questions. What's the ideal size of it? Or what's the ideal quality? How much space do we need? And in many of the reports that are going to be written, we have sort of like taken a position. So when PIDO says 300, it's because we've tried better, we've tried worse, and we've found a middle ground. When it comes to accuracy, at first we thought we would get people to just write a few handwritings with a few letters and then it would learn. Then we learned along the way that maybe there are shorthands, different formats. And that's how there's actually a whole annotating platform that has been designed by PIDO and the team because of that. So as we share many of the reports, many of those things have been thought through, and hopefully there will have to be discussions around them about what's scalable, what's feasible, but we are sort of like saying what is most ideal in the setting. And then the last thing about why we need the scans is the electronic medical records actually are designed to take up scans. So Butavika Hospital, one of the things they do want is for us to be able to upload those scans to the different patient records. And one thing we haven't talked about a lot today is an application that has been developed that can quickly integrate the scans with the actual patient record. So you get a patient record and you upload it directly into the electronic medical record of the patient. But that's where PIDO talked about needing a sandbox to test and the one from the ministry is currently down. So we didn't put that data there because we haven't yet validated it. Thank you.
Great. Okay. Great. I think let's clap for the Hekima team for great work. I had another term there. They started without data and they had the faith of a mustard seed, and it paid at the very end, just like the great team from London did after 22 years. Translate to 1 year here. So you never know. Vision is a great thing. and we totally are behind you, Dr. Mwesige. All right, ladies and gentlemen, thank you so much. I think that wraps up our 10 projects. I really would love to hear. Please stay online, Dr. Mwesige, don't disappear with your team and as well as our online team. I think it's been interesting to see all these projects and what has been achieved, across projects implemented in South Africa, in Malawi, in Uganda, in Kenya, the conditions that are being targeted, or at least problems that are the focus of these projects, and the different work activities, work packages, and just how the prize has been deployed in different ways, and at the core of it really is just to deliver data-driven solutions for what bedevils this region as a big problem: anxiety, depression, and psychosis. We've seen projects that combine different conditions in terms of the activities that they put out there. We've seen the last project focusing on psychosis, perhaps the only project within this prize that has also focused on psychosis, as it were. So there's been a lot in terms of how the prize has been deployed. A lot of work has been done, and we clearly have had that a lot more work is left to be done, but as I said, we are taking stock, we are seeing what teams have achieved, and we have engaged and shared about what we can do, what we have done, and what we plan to do. At the core of it is the conversation around infrastructure and those capacities that are required to midwife these projects or these solutions properly. And perhaps that's something that was glossed over, or perhaps it was assumed that data enough would have been it and the technical skills in the people. But the moment you start talking about NLPs and LLMs and all that, there's other inherent issues that emerge. And these include computing power and all of that. Some of it was already embedded in the project. There was a lot of support provided, not just on lived experience, but we had the open science expert, who was around to support the teams as well. And we've seen reports around how data has been deployed whenever it could be. Of course, conversations emerged what kind of data sets need to be placed on the OSF. And I think those were addressed during all those sessions. It was not really about analytical data sets with identifiers. It was mostly about the metadata. And I think over the time we discussed that, and most of the teams have implemented. We know that some teams have been working on proprietary bits, and therefore publishing their scripts online would amount to almost giving away what they are doing. And there were things like that to be discussed. What really needs to be published on the AOSF? And conversations with our friend Fanwell, who was our expert in open science, have been, guided the teams properly. There was, of course, conversations, about lived experience involvement, which is beyond tokenism, and really what activities can be rightfully done and implemented and led by that. And it sets the stage for us to bring everything in together tomorrow in panel conversations and issues around just where do we go from here in terms of enhancing policy impact. As we keep getting reminded by our ED, is that research has to be done. More people have to do research, but the challenge is really to get research leading to impact. Policy and programmatic impact is what we are targeting. And if that's where we are targeting, then really, ladies and gentlemen, today is just the beginning of another phase in this work. So for those projects that have made headway into what was the objectives, we congratulate your efforts. for those who have a lot of work to be done, for those who bit more than they could chew, you know, and had to go back to the drawing board. Yeah, these are, I guess, the realities of this kind of work. Innovation requires that you become a little bit more flexible, that you engage a lot more with other people, that you bring in expertise that you don't have, and sometimes you retreat when the spanners are thrown in the works, like Dr. Mwesiga said, and then you go back and figure, what do we really need to do to ensure that we stick within what we have as a vision? So there is feedback from Damaso. Damaso, I really would prefer that you just unmute and speak. You one of the co-PIs of the project, and I think it takes more effort to type than to just speak. So do you wanna say it in your own voice?
Can you hear me?
Yes, loud and clear.
I've raised these points, of course, when we were. Now there's an echo. I can hear myself. Okay, that's better. I've raised these points when we were doing the trial, and my key question is what next? That is, I think you alluded to it, what is the policy impact? We have some prototypes, we have developed dashboards, we are making publications and etc. But I think for me, it is something beyond that. This was a 1 year of a marathon, and I think each and every team made impressive efforts. There's no doubt about that. But the key question would be, I really hope that these prototypes, these efforts, and these solutions will not take them back to our workspaces or workplaces and put them in the shelves and then stop at that. For me, what I would be looking at and what would be of interest to me would be whether each and every team has, or whether the teams have some ideas on how they can think about scaling, they can think about model refinement, they can think about policy engagement or stakeholder engagement, so that these solutions, at least they can be impactful, maybe 2, 3, 4 years down the road. It would be very interesting, Chair, if at one point in time, we can see some of these solutions being taken up by governments or by counties, county governments or national governments and being implemented in the real world. I think for me, that's what I would call impact. Thank you very much, Chair, and back to you.
Thank you, Damaso. Well, I think those are reflections for today. We're gonna have, of course, proper reflections tomorrow. This work goes on until tomorrow, so I think that is well said, really, in terms of what next. It's always been the question that we call him DK loves asking, and I think it's always an important question to always ask, what next? You know, so we can mull over that and then continue this conversation. Remember, ladies and gentlemen, that there's going to be an opportunity, at least for those in the room, to demonstrate their projects. We still have that planned. There's going to be this setup based on the screens available in the room, and they'll be split so that they are not showing on one screen. At least that's what I've been made aware. But because that is almost like an activity that we can finish and leave at our own pleasure, and as we go find tea and coffee, and then look for dinner or at least walk in the sun, it makes sense, therefore, that we do our end of day feedback session, so that when we go to the demonstrations, people walk around and view what they want to view and ask questions that they want to ask, and then from there we can leave at our own pleasure. Again, that's just one opportunity. Other opportunities to sit down and have a conversation with the person that you're interested in having. It doesn't have to be on the display boards or display screens. So there are many opportunities to have these conversations. And if you prefer just sitting down and have a conversation, that's even better. So please make sure to do that. So we'll do like we did yesterday, a bit of guidance. Please make the feedback a little bit more informative. Not just one word, except if the question asks for one word. And then we see what you say. It's fully anonymous. We don't gather your personal details. So no one will see that you said something, about Arsenal. So if you could go to Menti, I see 14 people have already connected. The code is 37353529 on menti.com. And let us know what key things stood out for you today. It could be project, it could be an activity, it could be, it could be anything. It could be food again. Yeah. It could be the sun. It didn't rain today, yeah? Yeah, it didn't rain today, and it looks very promising for us to step out into the pool, into the beach, white sands. Okay. Do you want, what is the code again? The code is what is that again? That is the code. Where is it? Can someone read for me the code? It must be somewhere on this thing, right? Okay, the code is 37353529 on menti.com. Yeah. So great to see so much engagement across ministries and other stakeholders. Shamiri's project to ease mental health access for high school kids stood out. Systems already integrating with ministries. The HISP Uganda presentation. Lots cool to see project digitizing and making mental health data accessible. How important to keep working to improve our systems on province, population, region at a time. Team's presentation. Tim, Timothy, yeah, I loved it as well. Tim, you're gifted in your articulation. When I grow up, you know who I want to be. DHIS2, Prosper, yeah. Guys, I hope you're not writing your own projects. Like, if you're not gonna beat the drums for me, I'm gonna beat for myself. Yeah, well, I think it's allowed, right? Those are not laws that we set, so yeah. And guys online, please feel free to also add to this feedback. Exploring the role and feasibility of NLP to analyze core records. That stood out today. The presentation was which presentation? Can the person who wrote that rewrite it and tell us exactly which one? The presentation, do you want to scroll up or? Yeah, the presentation was very impactful. A lot of projects can inform each other and teams should collaborate. I totally agree. And I think during this session, especially the issue of infrastructure, data sets, skills, and all that, right? So you have Samuel Edie, for example, from our team. From what I heard, it was Greek for John Black. Some things, so clearly he needs to hang around people who speak the Greek. And for other people, it's just like fertilize our understanding of these things. Nice management. I imagine that is time management, perhaps. Yeah, good weather. We are missing out, though. Yes, the earlier we finish this, the better. So please, let's do it. Let's do it faster. The 19 people, the 9 people, the 7 people are letting us down. We are missing the sun because of you. Yes. That only a few projects are already working with governments. Hoped to see more of them already integrated with who would be sustain us. I see your frustration, but as we all know as researchers, it's not always easy. You don't just walk the Ministry of Health and say we are doing a great job, here it is. In fact, sometimes even with a great piece of work where you co-created with them, it may take another 5 years of policy cycle for you to see any move. So we appreciate that is actually also possible. And we wouldn't begrudge those who have tried and are still trying. Thank you so much I will improve again, keep improving. Hekima's project is a contextually very relevant project and a problem that is very unique. Okay, great. Let's move to the other question. I think we've had a bit. The first question, what stood out today, it could be similar to what went well today. I mean, at least from how I interpret. But let's see whether we can answer this question separately. Right? I mean, in my head, it sounds like I would say the same things, but what went well today? Timekeeping went well. Time, I imagine. I'm going to ask really, who said time? Self-identify. So just time. Or IP address. No, we don't have to do that. But yeah, give us a little bit information so that we can work with it, right? This is what would perhaps AI tool would call noise. It's like, what do you mean, time? Yeah, so let's give it a bit more context. Blue skies, blue ocean, blue pool, lovely. AC not cold today, lovely. The AC, okay. I give up. Presentations. What about this presentation went well today, okay. Food was amazing. Lovely. No? Not for you? Yeah? Oh, you are late for food. Well, happens when you're late, then you don't know whether it's good, yeah. You can't vote. Uganda team needs a treat in Mombasa. Thanks for considering. If you are from Uganda, we know you are the one who has written this. There are only 2 people from Uganda in the room. So Prosper and John Black, please. Are we drinking today? Guys, yes, certainly. Please drink. Just drink responsibly. Yeah? Is there any leftover booze from last night? Angela? We know who are the last people standing. We need to ask them if there's anything. Arsenal was mentioned. That went well today. Champions of England. You know, Mwesiga, we can see your handwriting, so please don't. Manuel, I can tell your handwriting, so don't hide behind the... Oh, okay. Okay. Speakers use the mics better. Great. Great. We need a, you just instigated a response. Yeah, we actually have funders in the room. That is a twist that can easily come out of this. So please keep sending these messages. It's going straight to the ears of the funders. We need alcohol. We couldn't drink properly yesterday due to today's presentation. And we now know exactly who has sent this. Because they are the people who did not present yesterday. We know who sent this. Trust and your team. We know you. Yeah. Okay, good energy in the room. Great. Can we go to the last question before we reset? What can be improved? Please, on this one, please give us very honest feedback. Very honest feedback. We prefer working with things we can really take. Angela, do you also want us to do the other activity when we are going out? Okay, great. What next? Question to the funders. And yet the funders asked you the same question. So this is a very cyclical question. It's always a question. Yeah, what next? So, yeah, we'll all think about it. 1 person out of 37. Mic drop. Like that's it. Like that's just the question. Okay. You're not sending, my brother. We need an answer from you. I know we did not drink enough last night, but it's fine. We're gonna make up to you. We need an answer for you from this one. The scan is there. I insist. No, you can delay. Okay, could we have another cocktail today? Okay. What can be improved? That question does not, that answer is not very specific to the question. So we eliminate it, we remove it. Yeah, it's wrong answer, right? Yes. It does not relate to the question. Yeah. More longer breaks, 15 minutes at least. No, today we are really catching up. And you know why? Because we were not honest with time ourselves. So we paid some bit of price for that. In the morning, we started very late, close to 1 hour late actually, maybe not 1 hour, but at least half an hour later. Did we rush presentations? No, we didn't. At least I can defend ourselves on that. We didn't, because we even had room for more questions and people didn't ask. So that is not true. We debunk that accusation and return it to the sender immediately. Is there a way we can delete it from the record? No. You can't delete it. Okay. You know, it goes to the Hansard. That's the problem. Yeah, the Hansard, you know. And we don't want to be accused. Icebreaker, yes, we did some. Maybe we'll do a bit more tomorrow. We have finished the technical stuff. Tomorrow will be more conversations. So I believe we can have this. No presenter bias. I'm not sure what that means though. Yeah. No presenter bias. Yeah, it's tough, huh? Tough. Please resend another one with a bit more context. Yeah. So, yeah, okay. If you could resend that with more context, I think we can unpack it. Deficit in the AI infrastructure and skill deficit in the continent. I think you'll be surprised that actually we don't have skill deficit. We have a lot. It's just that we don't talk enough. There are people who talk AI in this room. I mean, did you hear the guy give me a lot of acronyms in the morning? WERCR, I don't know what stuff, you know, agents, stuff like this. They're like this. There's a lot of these skills in the room. We just need to partner better, right? I really disagree that we have skills deficit in the continent. Yeah. I wanted to give an example, but it wouldn't have been morally good example. About mulot. Kenyans know mulot. Yeah, that's why they're laughing. Now, I'll have to give you this example for you to understand the context. So there's a very remote village in Kenya where top hackers, for some reason, emerged from. And they only had to go to the very remote place to find them. And it became very widely known. So, I mean, they were ethical hackers, some of them, right? Yeah, unethical hackers. We are happy. Thank you. We can include product demos when presenting because technical questions can only be asked after demos. Okay, good idea. I think it's the deficiency with the setup that was a problem and we couldn't do much. More time outside, we are just about to go. I get the message. Yeah, if you want to talk to me, you can talk to me directly, please. Some presentations could have been better shorted. I totally agree. I think we always have this, right? And the more we make these presentations, the better we become. And yeah, great. I think I shouldn't bore you to death, ladies and gentlemen. The sun is calling. We need to stretch a bit today. We need to make the most of the sun. We still have tomorrow to engage. If you remember your agenda, we are going to have the panel tomorrow. We're going to have conversations, and a lot of exciting things are planned for tomorrow. I know most of us, or almost all of us, will still be here, so look forward to seeing you tomorrow. I will invite Joel or Angela to guide us on what's happening regarding this, or if there's nothing to be guided about. Do we need to take a small break as you set up this? Yeah. Yeah, that's what I'm saying, because we need to know whether they are splitting the screens. That's what I'm asking.
Yes, maybe
Joel.
you can take some 5-10 minutes.
10 minutes.
Or 5.
Okay.
5 is enough.
I know what you can do with those 5 minutes, me and Angela. Right? So, yeah. So what we'll do is that you'll pass by our desk at the entrance. You'll finish for us the registration for today if you haven't. And we'll give you a token of appreciation for being good people today. Right at the gate. As you walk out in the sun, then come back for a setup of that. Let's make that 5 to 7.5 minutes, and we'll be back for the demos.
Yeah,
Again, thank you so much for your support, ladies and gentlemen. I wish you the best for the evening.